Hello, mic testing. There will be some delay.
Hello, mic testing.
Hello. Hello. कर्नाटका से है यहाँ पे कोई? Anyone here from Karnataka? afternoon, ladies and gentlemen. We are shortly starting the program. Requesting everyone to get settled down, please. Good afternoon, gentlemen and ladies and gentlemen. We are starting the program. Kindly get seated. हम जल्दी शुरू करें प्रोग्राम को. If Radhe, please ask everyone to get inside. We are starting program in next 5 minutes. Please cooperate, get inside. Okay. अगर आपके जान पहचान में कोई है और वो यहाँ पे अभी अवेलेबल नहीं है तो प्लीज़ कॉल देम एंड आस्क टू बी हियर. हम कुछ ही क्षणों में प्रोग्राम शुरू कर रहे हैं. Ladies and gentlemen, distinguished guest, please be seated. हम प्रोग्राम शुरू कर रहे हैं. हम कुछ गेस्ट का वेट कर रहे हैं and we will start immediate after they are arrived. But we want your kind cooperation कि आप सब लोग अपनी जगह पे बैठ जाए. Yeah, please cooperate.
Hello. Good afternoon, ladies and gentlemen. As we are going to start our program, I request everyone to please take their seats. Good afternoon, ladies and gentlemen, distinguished dignitaries, respected speakers, and esteemed guests. It is my absolute pleasure to welcome you all to the Initiative on Hemophilia Care IHC 10 2026, a platform that brings together thought leaders, policymakers, healthcare professionals, and the community to shape the future of hemophilia care in India. Today, as we gather here in New Delhi, we are not just discussing healthcare, we are working towards dignity, access, and a better quality of life for people with bleeding disorder. To begin this formal gathering, I request all the dignitaries please come on stage and take their seats. I request Dr. Nalini to please come on stage. I request all the dignitaries please to come to stage and take their seats. To begin this formal gathering, I request everyone to kindly rise for the national anthem.
मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you, everyone. To set the tone for this important gathering, I would like to invite our esteemed dignitaries for the invocation and lighting of the lamp, a symbol of knowledge, hope, and progress.
धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तु ते दिव्या दिव्यारे दीपत्कार कानी कुण्डलमोतिहार दिव्याला पाहून नमस्कार तिळाचे तेल कापसाची वात दिवा तेवे देवा पाशी उजेड पडे विष्णू पाशी माझा नमस्कार सर्व देव देवतां पाशी.
By lighting the lamp, we are not only beginning this event, but also we are paying respect to Shri Ashok Verma, who began his journey with HFI, and now we have around more than 100 chapters all over the country.
बाहेरची लक्ष्मी घरात येऊ दे घरच्या सर्वांना उदंड आयुष्य सुख समाधान शांती लाभू दे शुभं करो.
Thank you, respected dignitaries, for illuminating this occasion. Now, I would like to invite Mr. Premrup Alva, President of HFI, to deliver the welcome address and key requests. Please, sir.
Namaste, good afternoon, and thank you all for being here. So IHC was just a thought, एक idea था कि 17 अप्रैल जो वर्ल्ड हीमोफीलिया डे है, हम हीमोफीलिया फेडरेशन इंडिया एक बड़ा फैमिली है, हमारे पास 100 चैप्टर्स है, 300 HTCs है, मगर हम यूनाइटेड हैं. सो IHC एक सोच था कि हम कैसे यूनाइटेड करके कैसे हम एडवोकेट करें और हाउ डू वी प्लान थिंग्स टुगेदर एंड मूव फॉरवर्ड एज अ कम्युनिटी. सो वी स्टार्टेड दिस 10 years back. Today I'm very happy that this is the 10th year. We have seen a lot of success, we have seen a lot of challenges, lot of struggles. Our wants have, many of our wants and needs have been achieved, but our milestones keep increasing and growing. We as a community are getting stronger, and it is wonderful to see the commitment of everyone present in this room, present and who have come and who are not able to come for this program, because this entire hemophilia, thalassemia or sickle cell is more of a passion and a good combination of a heart and mind run program. The dedication, especially which the program officers, the state nodal officers and doctors have given us, we are always thankful and grateful to them, and obviously the government of India from 2016 to have started the whole hemoglobinopathy and hemophilia program. We are ever grateful to them, and I want to take this opportunity not only to welcome you all, but thank you all for the gratitude from not only myself, but the 30,000 Hemophilia Federation India represents. Thank you so much for being here, and welcome all. So every program of ours, we always acknowledge our founder Ashok Bahadur Verma. It was his vision that he was an amputee with one leg, suffering with hemophilia, no factors, and he thought that we'll start a federation. So the foundation is very important. What we have got today is the foundation which he created. He didn't create a chapter. He created a federation, and he brought in, we started with only 3 chapters. It was Delhi, Kolkata and Trivandrum. So he brought it and then went to nook and corner. I'm from Bangalore. He's come to Bangalore to make a Bangalore chapter. So everything we have done in the federation is because of him, and gratitude to him always. And thank you so much. Our vision has been one country, one treatment. Okay, children free of pain and without hemophilia, without disability. So today we stand at 100 chapters, 101 hemophilia treatment centers, which we in some direct or indirect way support with medicines, but the number of hemophilia treatment centers which are associated with us indirectly is over 300 plus 29,000 registered PWH, and if you add other bleeding disorders, it's above 31,000. So our collaboration is we work under World Federation of Hemophilia, and obviously a lot of respect and thing to the Ministry of Health and Family Welfare. We also collaborate with social justice and empowerment. So what does HFI do? Okay, we advocate and we try to influence policies. We don't. We are not socialists. We are a partner. Okay, we don't create dharnas or anything like that. We want to influence and advocate, build capacity. Now we come with a lot of knowledge of our doctors, most of our life we have lived with hemophilia. We have that capacity which we share to the government, and we increase awareness and education both within the community and outside. We support hemophilic families and PWH. We have a complete registry and we do a lot of planning. Going ahead, we are going to be collaborating with many other like-minded NGOs, and I would like to acknowledge many of our partners, including NNHF, and then the World Federation for supporting us throughout the years. So mainly, we were a platform. For example, when I was born, okay, I thought I was the only hemophilic. So there was nobody. Federation was not there. Okay, and we put advertisements in Bangalore to connect with other people with hemophilia. So Federation and the chapters have created a platform of connecting PWH and to provide life system support or life-saving care. So in hemophilia, what is very important, which we should all acknowledge, is the kind of development and care has developed. It's just not giving factors. What we need is a complete comprehensive care. We definitely have problems in neurological, orthopedic, dental, okay, physiotherapy and gastro are some of the most important multidisciplinary areas where we need to collaborate, because this is something which happens throughout our lifespan. At some point of time, we will have to go through this. So what is one country, one treatment? Our vision. Okay, our vision is a ideal blueprint is to diagnose early and proper management. So early diagnosis is extremely important, with especially thanks to the support which the government is giving. So quicker we diagnose, better we can prevent disabilities and have children without pain. So, you know, and adequate treatment. What are we talking about treatment? We are talking from plasma derived to non-factor therapy. We need to have everything is left up to the doctors. We advocate for everything. Establish an uniform mechanism of procurement and distribution. Many times, for example, okay, the whole state may be procuring medicines, but there will be only some districts which have a lot of medicines and many districts don't have medicines at all. That's not fair for the people. We believe in access to care. That means the treatment should be as close as possible. Ideally, there should be an HTC in every district, and there should be a comprehensive care center like what I mentioned, which can take care of neurological and other complications, at least 1 to 5 depending on the size of the state, and there should be a complete, structured system. What we also do is continuously educate, because as we know, and all the doctors here know that very well, in MBBS there is only one paragraph of blood disorders. So we take it upon ourselves to do a lot of education and training. Okay, one of the things which we want and we need support from the government is to focus more on prenatal diagnosis and carrier detection. We'll be trying to do some projects, probably maybe with ICMR in the near future. Probably we can think of some other areas which we can work on. Disability certificate is something which some states are finding it difficult to give, but most of the states have achieved the disability certificate. And educating and training personnel and insurance coverage is a long-term fight. Okay. Yeah, I think basically again I would be more of gratitude today, and thank you all for being with us for the 10th year of our celebration of IHC. Thank you so much.
Thank you, sir, for setting a clear and purposeful direction for today's discussion. Now I request Dr. Nalini to please grace us with few words.
I can go there and talk. That's better. I feel very incompetent to sit here. Good afternoon, everybody. On this important day, I feel proud to be here to speak about the warriors in hemophilia. The first warrior, of course, you know, is Frank Schnabel, who sowed the seed of International Hemophilia Foundation, and our Indian warrior, Ashok Verma. I know, I have seen him personally, how much he has struggled, and he lived for hemophilia till the end. All of you they are not the only warriors, they just sowed the seed, but all of you are hemophilia warriors. Whether you are a patient or whether you have been working for hemophilia, everybody is a warrior in hemophilia. I would call all of you as warriors. I feel proud to tell you that I am also one of the warriors who has struggled to come up. 40 years ago, I started doing hemophilia work for the past 40 years. I didn't know head or tail about hemophilia. I gradually learnt it from patients, went on further to get help, and I thought community work is most important for hemophilia, because whenever anybody asks me, how many patients you have? I say I don't have patients. I have 350 families under me, because hemophilia means it's a family disease and everybody is concerned, everybody is involved. So you have to think of the families. That means community comes in. I was also working in a medical college. Then as I went on, I realized without going into the community of hemophilia patients or families of hemophilia patients, helping them community-wise, it is not possible to help hemophilia. We have progressed a lot now. I am very happy, because from no factor, from then plasma, then cryo, FFP, blood, now we have come to prophylaxis. Something that is very commendable, except that one hitch is there, that the price of prophylaxis is high. So we still have to work. It's not enough. We just sit back and then think of our glory of the past and glory of the present. We have to work further for our hemophiliacs, how to prevent hemophilia during pregnancy, how to diagnose hemophilia in women, because now there are a lot of women suffering from bleeding disorders, include also the other bleeding disorders, and have them in our community, help them also out, so that we will progress further, and then there will be a time when there will be no hemophilia in India. I wish we could have that. Still, it is not the same. We say one treatment, one country. Do you think everybody gets equal treatment? You yourself think of in your heart and think about it. Does everybody get the same treatment? Does everybody get factor immediately? To some extent, yes. When we had no factor, to yes factor. Now we have got factor infusion for everybody, but still we have to progress. India is a very large country where we have to do much more. Somebody felt jealous that I got Padma Shri. It was, by the way, I did not I did not ask for it, I did not apply for it. I was nominated for it. From our state, I was nominated for my work in hemophilia. I did not apply for hemophilia. I did not think of applying for a national award. Likewise, there are many of you who are doing community service. You may not be a doctor. You, right now, another doctor who's a hemophiliac himself, Dr. Suresh Anagawadi has got, I am feeling very proud about it, that a person who has struggled to come up in life, who had nothing when he was from a hemophilia family, where he saw his uncle die, he came up and then he has produced such immense work. So I am very proud of him. It's unfortunate that he is not able to be here today, but still we have to think about him. There are many more people who can apply, because now a national award does not mean you have to be high up in the cadre. Even a common man, a simple man who has worked for a particular cause with sincerity will be able to have a national award. I thank people on the dais for giving me this opportunity to talk to you. I'm extremely proud of all of you for all the work done, for all the groundwork which is being done, which was done, which is being done, and which will continue. And I'm sure all of us next year will have further advancements. I feel that we impress the government of India to produce all the factors, then the prophylactic factors in India, so that everybody can benefit from that. This is what I told Modi ji when I met him. Personally, I told him, I want all the patients. I dedicate my award to all the hemophilia patients, hemophilia community. I didn't say patients. I said hemophilia community, that means families. Hemophilia community, and everybody must get their treatment. If it's produced locally, then we'll be able to give them proper treatment. So I request you to think about it and proceed with it. Thank you very much for giving me an opportunity. Thank you.
Thank you, ma'am, for your insightful and inspiring words. Now, I would like to request Dr. Hina Tabassum, ma'am, to please grace us with her few words.
Thank you so much, and I would like to begin with appreciating the organizers for having me here. It's truly heartening to see the sustained efforts of Hemophilia Federation of India in bringing much needed attention to still under-focused hemoglobinopathy, that is hemophilia, in comparison to other in its group. So in India, what I am learning is there are many patients who are still underdiagnosed, or they reach care very late. So improving awareness along with the access to treatment, for example, timely factor replacement, can significantly change lives. If we continue to align, as Madam has already focused on the community efforts, align community efforts, national programs and research, I am confident we can ensure that both diagnosis and quality treatment will reach patients across India, not just in select centers or silos. So I wish all the very best and success to the efforts from HFI and all the stakeholders who are present today. Thank you so much.
Thank you, ma'am, for your inspiring words. Now, I would like to request our Vice President Development, Mr. KVS Prashad, to please grace us with his words.
Namaskar, good afternoon. A warm welcome to you all to our IHC 10. Today, my session will be on empowering lives, enabling care, vision and mission of Hemophilia Federation India. अबाउट हमारा अशोक वर्मा जी के बारे में अभी हमारा प्रेसिडेंट बोला, फिर भी जितना भी बोले बहुत कम लगता है हमारा अशोक वर्मा जी के बारे में बात करने के लिए। HFI का विजन एंड मिशन, विजन है टू क्रिएट ए सोसाइटी वेयर पीपल विथ हीमोफीलिया एंड अदर ब्लीडिंग डिसऑर्डर्स कैन लीड हेल्दी प्रोडक्टिव लाइफ्स विथ डिग्निटी एंड इक्वालिटी। हमारा मिशन है to provide comprehensive care, advocacy and support to people with hemophilia and other bleeding disorders while promoting awareness, education and research. Key objectives: enhance access to affordable treatment and care, strengthen networking with stakeholders, government and healthcare providers, empower patients and families through education and support, promote awareness and advocacy for policy change, develop national guidelines of hemophilia and bleeding disorders, include hemophilia treatment products in national and state essential drug list, ensure access to diagnosis and treatment across the country without domicile restrictions. Our work: we have 400 STCs across India, 29,000 plus registered patients, awareness campaigns and advocacy efforts, training programs for healthcare professionals, patient support groups and counseling services. Challenges and opportunities. Challenges: limited access to treatment and care in rural areas, high cost of treatment, stigma, misconceptions about hemophilia. Opportunities: government initiatives and partnerships, collaboration with healthcare providers and industry, growing awareness and advocacy efforts. Call to action: let's work together to create a brighter future for people with hemophilia and other bleeding disorders. We invite you all join in our mission to empower lives and enable care. Thank you. Together we can make difference. Thank you so much. Thank you.
Thank you so much, sir, for your graceful words. Before the vote of thanks, I would like to make an announcement. Ahilya Nagar chapter from Maharashtra wants to facilitate our management for selfless work and empowering chapters. I request Dada Bhalekar to facilitate the team with mementos.
आज पूरा इंडिया में हेमोफिलिया के बारे में जो बहुत सारा काम किया है और कर रहा है और कर लेंगे, ऐसे अपनी HFI की जो पूरा टीम है, ये टीम के लीडर प्रेसिडेंट प्रेमरूप जी अलवा सर, हमारे STC सेंटर साई सावली मल्टी स्पेशलिटी हॉस्पिटल टाकली डोकेश्वर डिस्ट्रिक्ट अहिल्यानगर और हमारा हेमोफिलिया सोसाइटी अहमदनगर चैप्टर के तरफ से हम थोड़ा सा उसका ये HFI के प्रेसिडेंट सर को हम मोमेंट देकर थोड़ा सा सत्कार करते हैं। सत्कार करेंगे हमारे डॉक्टर भाऊ साहेब खिलारी सर।
Now, I would like to request our Vice President Finance to please grace us with the vote of thanks.
Respected audience, this is a remarkable event. Initiative for Hemophilia Care is being conducted for the 10th continuous year, so it has now become a decade old. Though Hemophilia Federation is 40 years old, this particular event has been conducted for the past 10 years, which is remarkable and notable in itself. This serves as a platform for the knowledge source and the knowledge sharing at the national level. Further, this marks beginning of the new year. So, I greet you all to have a wonderful and satisfying New Year. I thank all the dignitaries, especially Nalini Madam and the other chief guests, state nodal officers, experienced doctors, and representatives from all chapters across the country for having come all the way to participate in this event and make it worth remembering and a great success. I also thank the donors and the pharma companies without whose contribution the conduct of this event would not have been possible. So I specifically thank on behalf of all of you those wholehearted, kind-hearted donors. I also thank the management of Vishwa Yuva Kendra people who have helped us to conduct this program in a wonderful ambience and a pleasant atmosphere. Finally, I thank our CEO, Mr. Rajneesh Ranjan Jain, and all his team for organizing this event in a wonderful manner. Once again, I thank you all for the event, and I expect knowledgeable
and worth remembering seminars for the coming 2 days. Thank you once again.
Thank you so much, sir, for delivering the vote of thanks. With that, we now move to our sessions. Our first session is One Country, One Treatment, Shaping a Unified Policy Framework. I would like to request Dr. Naresh Gupta, Chairman Hemophilia Healthcare Collective of North, to please come on stage and start the session with need for national guidelines for hemophilia management.
Hello, very good afternoon. I congratulate my colleague Prem Alva for doing a great job for the hemophilia fraternity. He has been able to put the whole federation together in a more cohesive manner. And I'm very happy to be here to start with this session on One Country, One Treatment, which was the motto we created in, I think, 2011. We have been doing this World Hemophilia Day in commemoration in Maulana Azad Medical College since 2007-8. Now Dr. Sunita Agarwal has taken over the charge. I have given over the charge to her. She is doing it in a bigger manner. So that time we had realized that something that is not talked about in the rest of the world, there are many things that were not talked about by the World Federation and others. One of the things we realized was the patients with hemophilia must receive the treatment promptly. That's very, very important. I call it the golden hour, like we have the myocardial infarction attack, so you have the golden hour, so this is the golden hour. And the reason for that were twofold. One was we used to have patients coming from Nagaland, imagine. And he's the son of a pharmacist there, chemist who runs a private. So we wanted to do some programs there, but we could not. So he had to bring the son here. Imagine traveling by train, coming here, taking the treatment and going back. The other thing is more scientific, this is more social. And the scientific thing is the blood that gets into, I think, no, it is here. So it will come somewhere. 1 second, let me just put recent. What is the recent? And we are talking about need. This one, no? and we make it F5. So the other is this blood that gets into the muscles and joints, especially the joints, 85% are 85% are joints only, 5-10% are muscles. This blood is reactive. It does not remain a good thing for the body, it becomes a poison for the body. And that is why the hemophilia fraternity has seen that the joints swell up, what we call the hemophilic arthropathy. And sometimes they develop proliferating so much that it results in a tumor. We call them pseudo tumors. With treatment we see much less of it. But so that was a time when we had initiated that it should be doorstep care for hemophilia. And whether the person comes from Nagaland or from Delhi, it is the same Consolidated Fund of India. And we started with this one country, one treatment by taking the whole hemophilia fraternity from our college to Rajghat and taking a solemn pledge that we should promote it, 2011. So I'm very happy to be here. And another thing that we have done more recently, not in 2007-8, how many understand Hindi? No, we still have to see. So the another thing that we have seen is from 2007-8, when there was only one product that was available for the treatment of hemophilia, now we have more than a dozen. And it leads to a problem of which one to give, which one to take. It is a confusion in the minds of the patient. He gets all this information, the social media, multimedia, medical media, and the company media everywhere. The doctors also get information, including the journals and others. But the point that one has to remember is all these more than dozen products have actually evolved over a very short span of time. Hemophilia has been very fortunate. I've been very fortunate to witness it. Hemophilia care has gone up like that. If healthcare has gone like this, hemophilia like that. But with so many products, it became an issue as to which one to give, which one to choose. It became a bigger problem for those who used to procure the drugs. And since it was under the free treatment from all the state governments and the central government, it became a problem for the administrative officers, whether it is the hospital administration or the Department of Health Administration or the ministry administration. And that is where we thought we need some guidelines. Some guidelines that can sensitize everybody into what we are dealing with. What are all these products? Just because somebody says it is better than the other, it does not become the panacea. I mean, if it is like that, if one product is better than the rest should not stay on. Every product has their own place. And I'm sorry, I forgot to bring that booklet. 2023, we came out with the first national guidelines for, we call them, I'll show you here, if it is here, we call them the policy, protocols and procedures for hemophilia management. And that is the mandate that Mr. Prem Roop has given me to talk about, share with you for some time. These were the guidelines that we came out, and it is 14th December and we launched them and distributed. I think many of you who have been with us, you must have got it. We did it under the banner of Hemophilia and Health Collective. Now it makes it very easy for somebody to understand what hemophilia is. If you ask the products, the drug products that are being used, even a new trainee doctor will not understand all those products. So we made it very easy. I'm sorry, but this, I've taken a photograph. These are the contents, and this is how we have put into a tabulated form the different products. And actually it looks difficult from a far off place, but this categorization just gives a code to each one, and then it becomes very easy for you to handle. That code belonging to a group of the drugs, and then you go to the subgroups. And once you have gone there, then we have all detailed out things on different products, and we go to what we call decision making tables. Decision making tables does not go from product to the patient. It goes from patient to the product. So here we have to define the parameters of the patient. We give weightage, and it is done over a 3-page. You can see this is the second page and this is the third page, and it is done under different heads: hemophilia A with inhibitors, hemophilia B, and you know, that kind of a thing. And you come down to this. So it helped us in ourselves, in our group, and whenever we do these hemophilia conclaves, in bringing out that there is a need for these guidelines. And these guidelines have to be pertaining to our country. We don't want the American guidelines. I'll show you the American guidelines also, which doesn't work even in America 100%. You know, it's very poor kind of a response that you will see. So that is one thing that we learned. And the other thing that I want to share you quickly with you is that we have hemophilia. Now hemophilia is managed pretty well across all the districts, I would say, of this country, 700 districts. All the states and union territories, they do their job because health is a state subject. So we wanted to come out with some indices that you can use for comparison. That means we have a hemophilia body patient group now here in Delhi. You do these scales and scores and indices today, and then you see after 1 year, 2 year, 4 year, 10 years, how they are doing it. Also, you do these scores and indices today, and you compare them with another state or union territory. So it becomes a very good thing. Actually, we did this even before all these guidelines. This was also 2009-10. We have done a study on hemophilia in 6 developing countries. It is the largest study on hemophilia with all the data on detailed data on this, and we came out with this protocol for doing this assessing the burden, disease burden. So we have these scales and scores for diabetes, hypertension, coronary artery disease promoted by WHO, but we came out with this, and we actually presented it in European hemophilia hematology meet, and that is where it has stayed. So this is our involvement, on which behalf I am speaking about these policies, protocols and procedures. Just a word about the policies, protocols and procedures. All 3 terms sometimes are used interchangeably, but सबका अपना अपना महत्व है. Like we have in the parliament we make the law, then there you have the rules, regulations, and then you have to implement them. Similarly, when it comes to the management of a disease or patient group, we have the policies, we have the protocols, we have the procedures. So policies are generic. They give you a kind of a mandate. This is what you need to do. It provides the guiding principles of why we need to do it. Somebody says, we all used to face it. You know, this hemophilia, Dr. Gupta is eating away all the money. We have so many diseases in this country, and he thinks it's only hemophilia. He sees only hemophilia everywhere. They went to the court. They first went to the MS and then they went to the court also. I remember both, especially the Honorable Court of Delhi, telling them, Dr. Gupta is not taking away your money. You have money given to you by the departments. And to the best of our knowledge, you are not able to use that money in the whole year. You give back the money. If that money can be put to some good use, you should not think about it. Now imagine after 18 years, we still are in the same scenario. We are able to use the leftover money to the best use, and everybody is doing very well. So somebody had to give that mandate that you do it. That comes under policies. Now protocols are, you understand protocols very well because you see these protocols for treatment of hemophilia, hemophilia A, hemophilia B, protocols for treating with inhibitors, without inhibitors, and finally are the procedures. Procedures actually is not the lab procedure, But procedure by we mean the SOPs that we create, how you should use it, when you should give it, and that is where this book of ours, which we have given it out, and we have also put it out on our website, that decides and helps you take decisions, and that is why we have many of these called decision making tables. So it's important. So this is the reason why it is important, that it's important to do something. Consequences of not doing something is significant. I think it was somebody who went to Swami Vivekananda and asked, you know, I am confused, I really don't know what to do. He says, first you do something. The person's concern was whether it is going to turning out to be good or bad. I don't know whether I'll fail or I'll pass, or whether it will be a virtue or it will be a vice. He says, do something, then we'll talk about it. It is the same thing that we speak about when it comes to the psychology in hemophilia. We're going to have a national hemophilia conclave on 16th and 17th of May. We do it every year in May, so it's going to be in New Delhi. And one of the chapters, one of the talks we have kept is on this aspect, how to strengthen the mind of hemophilia. It's very important. It's very important. And that's where we talk about when you get depressed, when you get frustrated, when you don't know what to do, the best thing is to do something. You go out, take a walk, you go and take a shower, you go and play badminton, you go and play chess, you do anything. Once you start getting into that habit, that will get you out of that depression. Confusion about what is required, what is inappropriate, inconsistencies, questions, hesitancies, they'll all fall in place when we talk. So let us look at these three, we have looked at these three P's of the policy, protocols and procedures. Why do we need it? Now look at this. This was a very nice study which was published. So they looked at, so there were three heads, these guidelines and the protocols. One is medical consultations. Some doctor has seen you and given you advice. The second is clotting factor regimes that you use for treatment. And the third is compliance with the, the serological tests we do. That time all these new non-factors were not there. So it used to be inhibitors and other such things. So three heads you take, and the first three rows that you see speaks of whether they are complying with medical consultations, whether they are complying with the clotting factor administration protocol, and whether they are complying with the serological tests that have been advised. Or let's call it blood tests actually, because you could be doing CBC also. And it turned out, and the three columns that you are seeing there is the patient group. There were about 150 of them. How many? 128. The first column is those who survived, 128. Those who did not survive, 10. And what is the comparison? So you have these three parameters and how many fall under which group. So the first row says the persons who are complying. In the persons who were surviving, the majority of them, the compliance rate was 97%. Yeah? And you can see it was very high whenever one of these protocols was being followed. And all three of them have got a very high p-value. P-value means it is statistically significant. You can take it that it is a part of the result, the benefit result of survival is because they were complying to either the medical consultation or the treatment protocol or the diagnostic or the lab protocol. The down below it says whether they are complying to all three or 2 out of 3 or 1 out of 3. And you can again see those who were complying 3 out of 3 There were no deaths. So they all do well if you stick to it. It is easier for the administrators to understand. It is easier for the healthcare teams to understand. It is very easy for the newcomers to understand as to, we have to adhere to it. We are all very wise. It is only the foolish who thinks he is wise. The wise always think they are foolish. They still don't know enough. It is just this stupidity that we are looking around. If you make these and make anybody adhere, whether he thinks he is wise or super intelligent, it is good for everyone at all levels. So that is the point I am trying to make. And that is why we need these protocols, which are essential to achieve better physical, psychosocial health and quality of life. I will skip these two slides and I will come to these protocols. So the most protocol driven country in the world, I think, is the United States. They have the medical care which nobody can doubt. They have medical research which is so high and so deep, so widely funded that everybody looks up to it. Bethesda is the Makkah of medical research. They also have one thing where we have a lot of graduates, undergraduates and postgraduates going from here to US, and all our graduates when we were in AIMS as a student used to go to the US. One thing that comes out is in the US it is all protocol driven medicine, healthcare. And that is why these guidelines go into these protocols, rather policy protocols and procedures go into the guidelines at all different levels. So you need guidelines at different levels, and terminal level where you're giving the healthcare, that is what is dictating the healthcare in that country. They don't want to deviate. You might make a mistake, but out of 100, 99 times you will be normal or you will be good. So they had these different protocols and procedures at different levels. 16 health plans issued publicly were available. But what they found was, so these are all the charts, I will not go into the details of them. What they found was 1/3, 36% of the policies covered without any conditions. So that means you have a protocol and it is applied uniformly to whosoever is the person meeting those criteria or patient, it will be applied. Half of them were applied with conditions. That means it was not routinely allowed, but there was some conditional, you call it conditional approval for this. And 7% were borderline coverage and another 7 were mixed. $25 covered perioperative use for products not approved. 16 covered prophylactic use of products approved only for on-demand or episodic use. This is all about hemophilia we are talking about. And a plan covered bypassing agents for acquired hemophilia A. Acquired hemophilia A is a non-label, that means it is not an officially approved label use, and it was done it. So you can see that they have the guidelines, but the guidelines does not mean that they have to be adhered to in such a way that non-adherence, you will put them behind bars. You can't jail anybody because of something that they are doing it, because they are doing it with the best of intentions. So there are some steps that are required in policy development. We have gone through it, we have done it, and I think these are important aspects. And what parameters should go into the formulation of such guidelines? When I was showing those tables, decision-making tables, they were running, each one of them was running into 3 pages. They were covering many of these parameters, or rather we have brought out and made these slides based on those constraints, parameters, variables, and those have turned out to be very good because you apply a weightage also. For example, our country is very diverse. So we, in our Hemophilia and Health Collective, we have a professor from Jammu and Kashmir also. He comes forward, Sheikh Bilal, Professor Bilal. So we ask him, we had this problem of patient coming from Nagaland. He says, in our own state, everybody is like that. It is not Nagaland. Even if they have to come few kilometers, they have to spend a day, or sometimes they can't even come after spending a day because the weather is so inclement. So these kind of things also we have included as to the physical conditions, family conditions. Apart from the disease and patient parameters, there are many others that go into this. What defines the protocols management, whether it is the treatment based or it is the therapy based? I think I will skip it, even though it's a small thing. But treatment is very focused. What you are going to give patient is going to. Therapy is more generic, which covers a larger perspective. Do we make a common unified set of guidelines? So one of the things we have been saying is we should have uniform guidelines. How do we do it? 2023 we published these guidelines. Every year we are doing the National Hemophilia Conclave. We project them. And we ask them, is there something to be incorporated into this and something to be revised, something we have overlooked? And I am happy to share with you that now this year we are planning to come out with the new version of the updated version of the guidelines. Okay, so there are many ethical, social, cultural issues, but I will stop and conclude that guidelines are very important. Good guidelines are more important. It should not be quickly written out guidelines which can confuse everyone. Once there are good, properly made guidelines, they will help every stakeholders in hemophilia care. And it would actually help the one who is suffering, our hemophilia fraternity most, and it will also help the top level, the policymakers and the administrators, and in between the medical management, the medical superintendents, the head of the departments, the hemophilia specialists, the nursing staff, all of them would be helped. So I think I'll stop here. I might have taken a little more time to than allotted, but if there are any questions, queries or comments, you can share your views, please. Good.
I would like to request our CEO, sir, to please present the memento to Dr. Naresh Gupta. Now, I would like to request our next speaker, Mr. Ankit Panthari, Healthcare Strategy and Market Access Leader, to please present us with his presentation on reimagining hemophilia care in India, preparing for the next decade.
respected dignitaries, esteemed physicians, HFI and chapel leadership, my industry colleagues, ladies and gentlemen. It's a special occasion today as we are marking the 10th edition of Initiative on Hemophilia Care. When in 2014 this was conceptualized, there was one objective. It was a very simple objective, but yet very profound. That let's bring in all the key stakeholders in one platform, openly discuss the challenges in the hemophilia care, and collectively envision for the future of hemophilia care in the country. Since then, a lot of things have evolved. A lot of speakers have said about how we have moved. It is also a great time for us to take a pause and reflect as to how the decade went by, what we could achieve, and also more importantly, how to reimagine the future, how the future is looking like, or rather I can say, how the future should be looking like. So this is exactly what I intend to do in next 15 to 20 minutes to spend some time on this. I think there's a lot of progress which has been made. We should all be extremely proud of it. I was remembering 2014, we had about 13 to 14,000 patients identified for hemophilia. Now the number is about close to 30,000 numbers. I would also acknowledge that from a diagnostic point of view, still there's a lot to go. But overall, because of the work of multiple stakeholders, patient organization, improved physician engagement, and lot of work done by pharma companies, there definitely is improved awareness, which has led to also better diagnosis. I also remember the number of treatment centers back then was in dozens, right? We could simply count them, in our fingertips, that this is the center in that state where you'll probably go and get the treatment availed. So now where we have about 400 plus treatment centers is also a great progress. Wider treatment options. For a very, very, very long time, the only treatment option available was plasma-derived factors. And since then, the introduction of recombinant treatments, the AHL therapies, now the non-factor treatments, the portfolio is only increasing. And that also now enables our physician to treat the different patients based on their needs differently. Also, fortunately, we see growing adoption of prophylaxis. I again recollect those days where even speaking of prophylaxis to a policymaker used to do something very different, right? Suddenly used to get confronted with arguments about, but the public welfare is too large for more number of people. Why are you even talking about prophylaxis for few? Since then, there is a growing adoption, there's a growing consensus that yes, the standards of care in hemophilia is prophylaxis. And discussion have moved from why prophylaxis to how prophylaxis. And I think one of the most important thing which happened somewhere in 2014 was that from a center-led hemophilia care, we shifted to more programmatic approach, especially when National Health Mission took that project under their wings. And since then, we have seen a steady progress in this programmatic approach for hemophilia. So all in all, we have something to be tremendously proud of, something which we should look at with a lot of content. Having said so, when you are forward looking, we also look at the current realities of our ecosystem. And the reality is that the access is still uneven. Still, the standards of care or the level of treatment, whatever a patient is going to get, is primarily defined by where a patient lives, right? And that is something that needs to change. There are a lot of interstate variability. There are states who have gone ahead and provided care to the level of district hospitals. There are states which are still getting the treatment access confined to medical colleges. So we have quite a spectrum of the level of the care across the states. Since it is largely funded by government, the procurement processes, they are marred by long funding cycles, and oftentimes we still see those spells in the states where either there is limited availability of the treatment or there is no availability at all. And last year or so, we have seen that far more than last several few years, which goes on to say that there are still systemic issues which we need to look at, which still mar the hemophilia care today. There has been inconsistent adoption. As I said, there are few states which has really moved very quickly on prophylaxis adoption. They are actively going about pediatric prophylaxis, and there are still some states which are at the very early stage of even evaluating it and considering it. That ultimately lands for a layman patient hugely dependent upon where is he availing the treatment, where does he reside. And that, as an emerging nation, is something which you need to take note of and endeavor to change. Amongst all this uneven thing, I think there is one thing which all of us are strongly aligned on, and that is the intention. All the stakeholders, be it policymakers, payers, physicians, providers and patient organizations, and even pharma companies, I think there is no doubt that from an intention point of view, everybody wants upliftment of the ecosystem. Everybody is looking at the patient at the center of things and try to make attempts and endeavor to uplift overall quality of life. But we live in the real world, and real world is never easy. Real world is never simple. At the same time, we are also confronted by our own constraints. Look at the patient. They demand, and rightfully so, the best standards of care. It's none of their fault that they were born with hemophilia. And when the treatments are available, which can bring them their life to very close to a normal life, why shouldn't they? But the constraints are affordability, adherence, and access. The physician who strive for greater and superior clinical outcomes are constrained by what is available in their treatment center. Providers, they want to provide the comprehensive multidisciplinary care, but they are plagued by capacity constraints, infrastructure issues. Payers juggle between balancing the long-term financial sustainability and the cost effectiveness of various treatments. And policymakers, as I said, will live in the world of competing priorities. It's extremely difficult for them to weigh one over the another one. And pharma companies, which are again tremendously important stakeholders, they want faster adoption of innovation, but the constraints are the tremendous pricing pressure and the reimbursement and access constraints. So the path ahead is not really looking at one perspective in greater and acknowledging it more greatly than the other one. As we understand there's no lack of intent, I think the path forward is to recognize this constraint and make it a matter of more alignment. Build those systems where these perspectives are taken, and we drive those systems in a way that it takes into account all those constraints and they still move on. How can you best utilize this productive tension in this real life to make the better decisions? The fundamental shift is required. For a very, very long time, we kept looking at hemophilia as episodic in approach. You get the bleed, we simply make the treatment to subside those kind of effects and make the patient feel better. Even the ad hoc intervention with episodic prophylaxis management is also not good enough. We have seen when the care is continuous, predictable, and sustainable, the treatment outcomes compound. But when it is interrupted, the value depletes. There's an erosion in patient outcome. So it is extremely important then we look at longevity, the sustainability of the treatment. And another thing which is important is having those multiple treatment options. Professor Gupta spoke about many treatment options in the world today, in India as well. I think we live in a very interesting world today, and I will completely echo what he said, that what development happened in hemophilia in the last few years has exceeded the general overall healthcare progression. We have swiftly moved from plasma-derived treatment to recombinants through EHL. and now non-factor treatment as well. And when we have this conversation, this is not either an or conversation, it's an and conversation. We need today plasma-derived factors and recombinant, and EHL, and non-factor treatment. Because there are diverse patient population, no single product or no single class of product can address that unmet clinical need. I would also like to remind myself and all of you that we also live in the world of greater degree of uncertainty. Last years, we have seen the interrupted supplies of even plasma-derived factors. Hence, of critical importance is that we have a big portfolio which addresses not only the clinical decision making, but it also takes care of the supply related concerns if at all we were to face them. How the next decade will look like will depend upon really not optimizing the previous decade. We have to really look at redefining, reimagining the hemophilia care. Those of you who have been in this journey for quite some time would agree with me. There was a time when even to look for sustained funding of any kind looks so delusionary. We never could have hoped that it will become a program. At that time, it was so difficult to even envisage that there's something called National Health Mission who will be almost taking over this program and to ensure that there's some kind of sustainable funding, in the country today. Similarly, today we have to think big. I can clearly see more number of patients getting diagnosed, with more physicians who are now getting educated from medical colleges, who have the first-hand experience of handling hemophilia, whose awareness is far more heightened about symptoms and how to diagnose the disease. This trajectory will continue to flourish. And as we'll see antenatal, prenatal and preventive measures, there will be all the more intervention coming our ways. Patients and stakeholders will demand highest standard of care, rightfully so. We should not settle for anything less than that. We all know it's a journey. Nothing Rome was not built in one day. Same is the hemophilia, but that aspiration, that vision must be there. And we'll see that growing demand more articulated in the form of patient voices and other stakeholders' voices. As I said, the emerging therapies are knocking the door very fast, very faster than expected. I became so happy today when I see that there's EHL, not one but several companies. Then there's non-factor treatment. We have seen imicizumab coming in the last few years, then concizumab now, and fitusiran shortly. It's a great time from the emergence of therapies. Having said so, what will that create is a great abundance of choices to physician, but that will not take one challenge away. And that challenge is, how do we access these treatments? We all know they will come with the price tag, rightfully so, and we have to design systems which do not look at how we are procuring so far, but we look at how do we access this treatment going forward. And for that, I believe we need to be very open to innovation. In the world today, there are lots of models which have proven, which are there, existing, which have made accessibility of this kind of novel treatment possible. We are moving from cost-based procurement to value-based procurement. The pricing must be determined by the value it adds, simply not by per IU or per gram or per ml. That notion, I believe, will be over and will make significant progress in this decade. There are many models, to name a few: outcome-based pricing, annuity-based pricing, risk pooling between manufacturers and the government. There are many of them, and I'm sure the stakeholders here are taking note, and they would like to bring those in their conversation with relevant stakeholders so that they are adopted and acted upon. All in all, the programmatic approach to hemophilia must now evolve to a very well-oiled machinery system where it is ensured that the care is not dependent upon where the person lives, but highly equitable in nature. There has to be somebody, and I'm sure there are agencies, who look at the national level of care, not fragmented the way X district hospital managing or the Y state is managing. So from access, which I think we have traveled a long way from an access point of view, how sustainable, how continuous the treatment are is going to be very important, from fragmented care to integrated care, and from cost mindset to the value mindset. That's how the next decade should look like. And when I look at the way forward, we should have more stronger, predictable funding mechanism. If there's one element which is the backbone of how the care will evolve further, it is this piece. How much, in which ways, on what terms are we going to provide this kind of funding mechanism for a patient to be able to access the treatment? Better coordination among stakeholders, and that is where the program, the platform like IHC plays a tremendous role. We need to be very honest, brutally honest about our conversations here. We must applaud what we have been doing, at the same time be critical of what lies in future. Unless we acknowledge the gaps, the shortcomings, we'll never be able to make remedial measures. So that coordination, that openness is extremely important. And preparation for future therapies, as I'm repeatedly articulating, just the product being made available does not mean. A product acts or therapy acts when they are available to patient on a sustainable basis. We have to continue looking for them. And the admission of that approach that hemophilia is not an episodic management, it's a lifelong care, lifelong comprehensive sustainable care. Ultimately, our objective is very simple. We want to move away from the standards of care basis where the patient lives. It is very simple, I repeat. It's equitable, high quality care for every patient, everywhere. Thank you so much. Wish you all the best for future sessions. Thank you.
Thank you so much, sir, for your presentation. Now, I would like to request our president to please come on stage and present the memento. Our next speaker was Dr. Shakila from National Health Mission Karnataka, but unfortunately she missed her flight. So we'll be presenting her video. Along with that, our President Premrup Alva sir will also be speaking to you. The topic is Karnataka Policy on Prophylaxis Kusuma Sanjeevani.
Sorry, I'm playing a dual role right now. I also represent Karnataka as a technical committee member of the state blood cell. Okay, unfortunately, our state blood cell officer had missed her flight. So it would be nice if she presented. So I don't have a presentation, but there was a video form created by the government for the program of launch of prophylaxis. I'll play that, and then I'll talk about few things which we did in Karnataka. Can I have the video, Rohit? just to add a few points of the Karnataka efforts. So as you know, it was the first state in 2005 to provide any kind of a treatment. From 16 onwards has been a life-changing moment for all of us in the community when NHM, Government of India, started supporting us through the PIP. So forever, Karnataka functions on a 3-committee system where there is something called a needs committee, then there's a technical committee and a procurement committee. So the needs committee does a data-based, district level data-based requirement, and procurement is done by the technical committee on how much of factor 9 has to be bought, how much of one Willy brand has to be bought. What Dr. Naresh Gupta was talking in his presentation is a big confusion as to what product, how much has to be bought. Unless you have the data, and I'm so glad that the Government of India, one of our requests was to add hemophilia in the sickle cell portal, and they have added it. So now all we know that our PIP amounts will be based only on the data which we put up. I'm not really very worried about that I'm not sure how many state program officers are feeding in data, including my own state of Karnataka. Okay. But however, in Karnataka, they do have something, we have every district data, and based on that, the procurement happens of factor 8, factor 9, and one Willy brand. And then distribution happens at the same time. Now came a new era of non-factor therapy, which is a game changer, and this is the prophylactic and this is the way forward. So the state government decided to provide non-factor therapy for 1,000 people. Now the challenge was, who is the 1,000? How do you derive at the 1,000? Why is one kid getting it and why not the other? The technical committee sat down and did a SOP saying that first category of people who will be getting non-factor therapy prophylaxis is anybody and everyone who has had a life-threatening bleed, like an IC bleed, the GI bleed, or any psoas bleed, anything which has been life-threatening. Okay, some of them have had spinal bleeds, some of them have had neck bleeds, so they are covered. So in this category, we had something like 97 people. And then the next category was pediatric, below 18. There were around 470 people in that category. And then was the third category of annual bleed rate. Okay, so above, okay, now this became again a tricky. So what is the annual bleed rate? How many bleeds is okay? So normally internationally we say 3 bleeds in a year is acceptable. Okay. So then it became 6 we debated on. Finally, the government of Karnataka settled on 10 annual bleeds. Anybody who has had a data of 10 annual bleed in the government system, they are entitled to non-factor therapy prophylaxis. So and a clear-cut SOP had been done, and a technical committee of 3 government doctors receive the data of each and every domicile person in Karnataka, and with the one of these 3 categories I mentioned, proof, and then they are enrolled into the program. And this was launched very recently by the Health Minister and the Deputy Chief Minister. And I think one more thing which I would like to add is, in the state, like I said, I represent Bangalore chapter here, and I'm a part of the technical committee. So it's very good that the state has heard the voice of the NGOs. There are 8 chapters. All of them play some kind of a role, and especially in an annual training program which we conduct, all the chapters are present with all the district doctors. Thank you so much.
Thank you so much, sir. With that, we now move to our next session. Our next session is on prevention, data, and the economics of care. Our next speaker is Dr. Rucha Patel ma'am, ICMR, Mumbai. A cost effectiveness analysis for hemophilia treatment in the Indian context.
So good afternoon. I would like to first thank HFI to invite me to give a lecture or to talk on such an important topic, that is cost effectiveness analysis for hemophilia treatment in the Indian context. So just in a gist, very quickly, we know that hemophilia treatment, as sir also said, has improved amazingly. Like healthcare, as he said perfectly, is like this, but hemophilia care has just upped the scale when it comes to treatment. Because once upon a time it was whole blood and platelets, FFP, etc. Then standard half-life. Now we have extended half-life. We have non-factor therapy. And that is why the main issue with all these beautiful therapies is the cost. So I'm going to talk about the cost effectiveness by telling you a story which is based on a true story, and then we can talk about all the other drugs. So it started with the non-factor therapy emicizumab. So I'm not trying to only give importance to one drug. As the other sir rightly said, we need all the drugs in the market. But this is the story of this drug. This drug came to the market and it had its superiors over all factors, etc., because it was subcutaneous. You had to give it only once in a month. And finally, our patients, our hemophilia friends, are now having 0 bleeds. All the clinical trials showed that 90% and above patients had 0 bleeds. Main problem was the cost. The standard dose emicizumab prophylaxis came around 24 lakhs for one patient who was 50 kgs and only for 6 months. Not affordable by our government. So several middle income countries decided, let's just lower the dose and see what happens, with one agenda in mind or with one principle in mind. Now, factor VIII prophylaxis, as you all know, it is defined such that you convert a severe patient into a mild or a moderate range. That is, you want to maintain the factor VIII levels of 3 to 5 IU, and higher is better because these hemophilia patients bleed less. Standard prophylaxis with emicizumab leads to a factor level of 10 to 40%. So even if you halve the dose, it would still be in the category of 3 and higher, and that is why we went ahead with the low dose so that many patients could get the drug. And even if we achieved 70% efficacy, we were still good with that. What happened is in 2023, our retrospective paper came up and we showed that the low dose emicizumab resulted in 0 bleeds, way better than the low dose factor VIII prophylaxis and almost equivalent to the standard dose. This led to an impact that is internationally. We even presented it in ISTH, in WFH, and immediately 100 patients all across India were put on the low dose, and even international RCT was started because of this. Coming to the cost. Here I am highlighting only the drug cost. Only the drug cost for 6 months for a patient of 50 kgs is around 5 lakh rupees for low dose emicizumab treatment. For standard dose, it's 12 lakhs, and for factor VIII prophylaxis, it ranged from 4 to 7 lakhs depending on the factor which you are using. Now, many, as I said, other also all case reports, etc., they were published, but to change the policy, at least in ISTH, we were told that it has to be a randomized controlled trial. And that is why we initiated this in 2023. I am happy to share that it is now done, and soon in 1 month it will be published. And basically we put a proper randomized control trial, 15 patients on low dose, 15 patients on standard dose, and what you can see is beautiful results. That is, the low dose is almost equivalent to the standard dose. And the HGHS score, the quality of life, we are monitoring all of this with pictures, and everything is looking beautiful. We are monitoring it with the drug levels, with the ROTEM analysis. So each and every aspect in the RCT is being done. And this also got its international recognition and even in papers. And what this created was what is the main topic of today. What happened is some state, I think it was Punjab state, said they wanted to get emicizumab in their state for the procurement, etc. But the state was not allowing, so they raised an HTA. This is Health Technology Assessment. Now let me just give you a gist about this for those who don't know what this is. So there is a DHR, Department of Health Research, under which this HTA committee sits. It had started in April 2017 as a pilot, but now has grown into a full-fledged department, that is a proper HTA team. And the main aim of this department is to analyze health technologies, medicines, devices, health programs, all of it. They see the cost effectiveness, they see the clinical effectiveness and equity issues, with the main decision to help quality healthcare by reducing the cost and seeing what is good for the government to procure. So here is where suddenly what happens. So this is the entire hubs, the resource centers, it is all on the site. This is the main team, our DG ICMR, who is the secretary for DHR, heads the HTA, and basically anyone can apply. A state can apply, a central government can apply, an innovator can apply. And if the committee thinks it's a good initiative, they do the HTA treatment. So this is how this story started. Health technology assessment for emicizumab was asked by a state. It was done by the DHR team. What was done was standard dose emicizumab prophylaxis was compared to the standard of care at that point in India, which is on-demand treatment and low-dose factor VIII prophylaxis. When this was done, and especially I want to highlight the last part, it was done only in hemophilia A patients without factor VIII inhibitors. When this was done, they claimed that there was superior clinical effectiveness. However, it is not cost effective and it cannot be supported by the government. Luckily, NHM gave this letter to ICMR asking them inputs on how to modify this or how to help this drug go ahead or how to reduce the cost of this drug. Luckily, since we were doing the lower dose, we met with our DG and we told them, why don't you do a low dose emicizumab prophylaxis for HTA and see whether the government can afford low dose. And for this, what Sir said is, I need a meeting with everybody to see whether this is worth doing it or not. And a team on 12th June 2025 sat in Delhi headquarters with all the experts, Alok Sir, Chandrakala ma'am, Bilal Sir, everyone. We had the DHA HTA team, we had the JIPMER team who are the economics people who do all the maths, etc. Our team from NIH, the NCD team, and we had HFI also with us. And we had a good 1 hour, 2 hour discussion on this. And the main point of this was do a pooled analysis of low dose emicizumab and provide it to the HTA team, and the HTA team then would further do cost analysis and the low dose HTA assessment. And we were given a timeline of 3 months to do this pooled analysis. So the main goal of this meeting was ICMR will write a letter to NHM and include emicizumab in the essential drugs if it is cost effective according to the HTA studies. Now, pooled analysis. What is pooled analysis and why? Basically, all of us are doing amazing works. The clinicians in India are amazing, hematologists are amazing, but they do not publish. So we did not have good amount of published papers on low dose emicizumab for the HTA team to take the data and do the HTA. So pooled analysis was given to me and Dr. Hina, that is you contact all clinicians and get their data and pool it and give the data to the HTA team. So this is what we did, and the HTA team was told to do a cost threshold analysis, a low dose emicizumab prophylaxis versus the standard of care for hemophilia A patients without inhibitors and for hemophilia A patients with inhibitors. So for this, myself and Dr. Hina contacted 72 emicizumab users and 38 said yes, we would participate. We sent a basic Excel to them and we told them please fill the data and send us all the patient data. And happy to say we got from 15 centers the entire set, and we got a beautiful number of 773 patients, 287 on standard dose, 322 on the low dose, and 164 on even a lower dose. And we have analyzed the results, and beautiful results. Again, this showed that the low dose was almost equivalent to the standard dose, that is 0 bleeds were obtained in standard dose and 0 bleeds were seen in alternate dose. In the very low dose also, this is very good data because though the bleeds are there, it's just 0 to 1 or 1 to 2. That is also good for certain states. HTA policy briefs. So this was not done only based on the cost. We had meetings every 3 times in a week on Zoom with all the clinicians and with the HTA team. What all was taken into consideration? The cost of the drug. If the patient is on factor VIII prophylaxis, how many bleeds he would have? If the bleed is there, how much dosage of factor VIII and FIBA and Novo-7 would they have? If it's hospitalization, how many days it would be hospitalized? We all know that when the patient is on emicizumab, the hospitalization days reduce, the factors and etc., the dosages reduce. All of this was considered in the modeling and it was kept separate for patients with inhibitors and without inhibitors. And finally, the policy briefs were out, which showed very good data. So this is the policy brief for cost effectiveness of emicizumab with patients with inhibitors, which showed that, so this is all the modeling etc. that an economics person can more share, which you people may also not want to hear. But basically the end result of this was that the lower dose emicizumab is a cost saving strategy, and only 0.3% of the annual NHM budget of a district is required for this. So why not? Now it is not only restricted to patients with inhibitors. Even without inhibitors it was cost effective. The only difference is it is cost effective, and 1.63% of the annual NHM budget would be required. So these two policies are going to be out soon with the NHM. It is right now at the DHR state. But DHR, what they did is they had an adopt Zoom meeting where all the stakeholders, I think most of you were there for this meeting because everyone was invited, and mainly the main people, target audience was policymakers, procurement agencies, state health agencies, and this is what has happened. So everyone knows these policies, but I know everyone wants proof and everyone wants this policy online so that they can use it. DHR has also replied to the NHM letter is what they have said. And this is where it ends from ICMR side, so it is yearly going to come into play, and hopefully all the states can procure it at a lower, meaning as such with the low dose given. Not only that, the pooled data got recently accepted in ISTH for an oral presentation, and soon we will be publishing this too. Now, HTA is not only for drugs, as I said, it is even for diagnostics. So we have our point of care test for hemophilia A and von Willebrand. It was even done for that. So HTA can be done for each and everything, and since this is a government document, I think states can use this for procurement, etc. And that is where I end this talk. This can be done, as I said, we've done it for emicizumab. This was the start. The next in line are EHLs. The next in line would be concizumab. So but it has to be used in the Indian scenario to do the same. So I would end it by saying thanks, because in this many people were involved. You can see all of them, Alok sir, the clinicians, Hina, Chandrakala ma'am, the HTA team, each and every, this was a unity of n number of teams working together to make this happen. Thank you.
Thank you so much, ma'am. Now I would like to request our Vice President Finance, Mr. Vaikuntham, to please come on stage. To present her with the memento, and then she will also have the next session, which is on genetic counseling and prevention for hemophilia.
Okay, so from directly economics and drugs, I jump to genetic testing, prenatal and antenatal test. So the topic is genetic counseling and prevention of hemophilia, which I think till date, no matter how beautiful the drugs are, because still it has to be provided by the government for majority of the patients, this is still happening, and that is why it's an important topic. Not only that, we know that nowadays carriers finally are getting more attention. They bleed, they need to do their carrier testing and factor levels for themselves. So this is what I'm going to touch upon in this lecture. So what is comprehensive hemophilia care? Yes, you have the laboratory diagnosis, you have the treatment, you have surgeries, you have physiotherapy, but along with that, a very important part is the genetic counseling and genetic diagnosis. Just in a gist, hemophilia is an X-linked recessive bleeding disorder. Now this is very important because here is where we know that the males get affected and the females are carriers. Okay, and basically the manifestations, carriers, now once upon a time, a long ago, it was just said that the females are just carriers, they don't have any issues, but this is false. Carriers also bleed. There is an ISTH redefined term where they are classifying women who are carriers as severe, mild and moderate, because now finally due to all these drugs we are shifting our attention from male hemophilias to carriers, which is very, very important. And even in India, this needs to start, and we need to even pay focus on the carrier females. So just in a gist, why is genetic counseling important? How you should understand the genetics behind this. So if a mother who is a carrier marries a unaffected male person, what are the chances of the children? If you understand this, it is very easy to make a decision whether you want to do prenatal testing or you do not want to do. So when this happens, 50% of their daughters will be a carrier and 50% of the males would be affected. When a father with hemophilia marries a normal non-carrier female, all the daughters are carriers, all the males are unaffected. Inheritance patterns. Now, this is the most deadliest combination, that is when a hemophilic father marries a carrier mother. Why? Because this is not usually seen. We never see a hemophilia female, that is both the X affected. It can happen only in such a marriage. So over here, 50% of the females would be carriers, 50% would be hemophilic daughters who would bleed as much as a male severe patient. All the males would be, 50% of the males would be healthy, 50% of the males would be hemophilic. Now, why carrier and prenatal diagnosis? Very important, you need to know the possibility of transferring this gene and disease to the next generation. An option is termination of pregnancy. Again, this is a very family-based decision. It depends on religion, on ethics, on cultural barriers. So we are just providing the test. It is up to the family to decide whether they want to go ahead with this or not. Nowadays, with this era of emicizumab and non-factor therapies, there are many patients coming to us to do the antenatal prenatal, but not to terminate, just to help the family plan and prepare. So this is a new thing which is happening in India right now. It has been always happening outside our country. For females, it is very important to know their carrier status and factor VIII levels, as I said, because they bleed too. So all this knowledge is required, and that is why carrier and prenatal. Prevention. Identify carriers, give antenatal diagnosis to confirmed carriers. Now, my question is, if all the confirmed antenatal diagnosis, that is the affected fetuses, were terminated, would it lead to total eradication? Absolutely not, because we should know that hemophilia, 40% of the cases are sporadic. When I say sporadic, there is no family history, the mother is not the carrier, it is unfortunately that the kid is born with hemophilia. So that is why we will never get rid of this disease, it will always be there, but this is an option. It is called a spontaneous mutation. So many patients come to us and tell us there has never been a family history, why I got this. Unfortunately, 40% do have spontaneous mutations. How do we do it? Very important. We cannot do genetic testing directly. We need the phenotypic parameters, that is the coagulation report. So we need the factor VIII levels, the VWF antigen levels of the index case. Only once we have that, we can do the genetics. Why is this? This is a main question where clinicians get very irritated because they don't have the report and they still want to do the testing. Von Willebrand disease, as all of you know, have factor VIII levels also reduced. That gene is completely different from a factor VIII gene. And factor VIII gene is huge. So my staff takes 4 weeks to span that gene just to come to know that the patient is von Willebrand. That is why the basic coagulation test has to be known of that one index case. When I say index case, it means the hemophilia patient who has 100% the hemophilia disease. Then there are different types of mutation in hemophilia, and there's a strategy we use in our institute. That is, we know where, so inversion is there. 40% of our patients have inversions. So we first rule out inversions and then we go ahead into screening all the other exons in the factor VIII. Now looking at this chart, I hope the people who are here, especially the HFI groups, understand why it takes at least 4 weeks to do this test, because it is a large gene to screen. When it comes to hemophilia B, luckily factor IX gene is not that big, and that is why this is given earlier than the factor VIII gene. Now, when and who, most important. Who should be screened in the family for carrier status? There are 2 types of carriers. One is obligate. What is an obligate? Daughter of a hemophilic father. I had shown you the chart. A woman with 2 hemophilia sons. A woman with one hemophilia son and another relative in the maternal side, like mama or someone, who are potential carriers, sisters of hemophilic patients, cousins, aunts, all close relatives, all of them have to go through this testing. How is it done? If you know you are a carrier, now it is about prenatal testing. If you know you are a carrier or has a child who is hemophilia, as soon as you miss, this is a very important aspect which I want to tell you, as soon as the female misses her period or finds out that she's pregnant, they have to do a sonography report from a gynecologist and then call us, and what we need in this sonography report is the weeks. Based on this gestational weeks, we give an appointment because the test is done in 10 to 12 gestational weeks. Generally, directly the patient who are in their 17th or 20th week of pregnancy come to us, it becomes very difficult for us to give the report then. Now, a question. In a hemophilia family, if a lady has 3 normal sons, can she be considered as a non-carrier? Absolutely not. This is a myth. It is just a chance occurrence. Until you know that the lady is not a carrier genetically, do not assume anything. Do a test for this lady, especially if she wants the 4th child. So this is the pedigree again. Who are the essential family members required for carrier diagnosis? Now we need the hemophilia patient, who I keep telling index case. So someone who is sure shot having the hemophilia has to be there. The mother of that carrier, not necessary, but it is good to look at genetics, that is why we prefer it, and the female who wants to know her carrier status. Can only factor assays help in distinguishing carriers from non-carriers? Absolutely not. Please do not do this. If a female gets factor VIII levels 40%, 30%, do not assume she is a carrier. You have to get the genetic test. There is something called as acquired factor VIII deficiency too. So based on factor VIII levels, you can never decide whether a patient is a carrier or non-carrier. Do carriers have a risk of bleeding? Yes, they do have a risk, as I said in the start of the slide, and now we have to look into it. Can a carrier female present like a severe hemophilia patient? Yes, we have got 1-2 cases. This is called as X chromosome lionization. It is very rare, but because of this, what happens is a carrier female can also have factor VIII levels less than 1 and she can bleed as horribly as a severe hemophilia patient. That is why the factor VIII levels are important. What is the ideal time to get tested for carrier status? Any time is fine, but it should be done before marriage, or most important, before conception. Don't come to us without your carrier status once you're pregnant. It is always better to know your carrier status before the marriage. What gestation period is ideal? As I said, 10 to 12 weeks is the ideal period where this testing is done. But if you send the patients when they are already 17 weeks or 20 weeks, I'm telling you it takes 4 weeks. So it is very cut to cut for them if they have to terminate to get the report. We do second trimester diagnosis by 15 to 16 weeks. And then you have the cordocentosis, which no more we do because there's maternal contamination. So the best time is 10 to 12 weeks. We even entertain 15 to 16 weeks. These are the fetal sampling techniques. Are there any risk associated with the sampling procedures? No, in our experience, we did not encounter any procedure-related miscarriages. Western literature says a 0.8 to 1.6% risk. Can a carrier diagnosis, antenatal diagnosis report be kept confidential? Absolutely yes. We give this report only to the female. If the female is there and the male, that is the husband and wife, only they will get it. Not even the in-laws can come for the report. Carriers and prenatal diagnosis, practical issues. As I said, you have to understand the lab side. That is my side. It is a large size. There is heterogeneity in mutations. It's not like sickle cell and thalassemia where you know the mutations. So it takes time to get it. So you cannot give the sample and call after 3 days and ask, Madam, report ho gaya, nahi ho gaya. It takes time to screen it, and that is why we say 2 weeks at least. Can we know the sex of the fetus? Unfortunately, till date, this is the most famous question asked by all the patients, and the answer to that is absolutely not. How do we give a report? Yes, we claim this and we have no hiding in it. Affected means a hemophilic male. Unaffected can be a normal male, a normal female, and it can also be a carrier female, which we will not disclose. Once you give birth to the child, you can get the child for carrier test. Can the blood samples be sent by courier? Yes, only if you have proper coagulation reports of the index case. Yes, it can be sent. Otherwise, we prefer doing the index case testing at our center. Are there any misdiagnosis by DNA analysis? It is very less, it is just 0.1%. So now by sequencing, it has become way better. How to offer diagnosis? So many cases, there are families where the index case is has passed away. We can still do that, there is no problem, but the accuracy becomes low. That is it. So the chances of getting a wrong report from 0.1% increases to 1 to 2% without an index case. So here is where I would show off our institute. That is, we've been doing this prenatal carrier and genetic testing since 1997. Till date, we have done 615 index cases, 364 carriers and 251 pregnancies. And this is, that was through the RFLP technique, which had less accuracy. And from 2014, we are doing the molecular DNA testing. This is my team, the genetic testing team, who does all of this, who counsels, etc. So a big thank you to them. And this is where I end my talk again. Thank you so much.
Hello. Good evening, ma'am. This is Subhas.
Hello. Testing.
So, ma'am, I just want to know, you told that the index, although the indexed case is although passed away, then also you can do it. So what are the, ma'am, how much in advance we should plan for that? I just want to know.
So you want to do carrier testing or the prenatal?
Prenatal, ma'am.
Prenatal, as I said, the minute she skips her period and she gets the first sonography report, you need to call us. We want it in the 10 to 12th week itself, and we will call you and tell you which date you have to come to Mumbai and do the test.
For that also, ma'am, the samples can be sent to Mumbai?
No, no, it can, yes, because there's no index case anyways. Yes, it can be. It can be courier.
Okay, okay, thank you.
Lady sample and mother sample as well or not?
Preferred. Mother sample is not compulsory. It is preferred because we see how it goes through the family, the pedigree. But index case samples and the sister sample also will do. Yeah.
Thank you.
Done? Cost of which test? Carrier status. So carrier status, if I'm not wrong, is 2,500, and for every, now I'll tell you, in families, 3 sisters come. So for each extra carrier, we do charge 1,000 rupees for each carrier. Otherwise, for one family, it is 2,500 to 3,000 rupees. 6,000 rupees. Which does not include the CVS sampling. So the CVS sampling, we have another person who does that because you need an expert over there. So that is different charges. So for any patient who is below poverty line, they waive off, and even we waive off. Anyone who has the BPL card, we will not charge.
Excuse me, ma'am. It's regarding the previous presentation which you gave. Ma'am, in our state, now understanding and knowing that the gold standards are prophylaxis, we are giving extended half-life recombinant factor therapy. Now, with your presentation, I have come to understand that the gold standards are non-factor therapy in low doses. Is it correct, ma'am?
There is no gold standard. I will not stand here and tell one is better than the other. If you have EHLs, give the best dosage. That I think a clinician should say what dose. But even with EHLs, if you don't give very low dose and you give the proper dose prophylaxis, the patient is not going to.
Ma'am, in that case, how are we going to work out with the slogan of one nation, one treatment sort of thing?
No, one nation, one treatment. But as I'm saying, one treatment, I am not focusing on one treatment. All of it should be there in the market. Everyone has its pros and cons. It is based on the clinician and the patient what they want to take. and what is there in that state, I would say. But I would like Naresh sir to talk on that. Yeah.
Thank you. Very confident presentation. Congratulations. You know, we should be very careful before we set any new precedents. The knowledge already exists that we should take into consideration. Abemaciclib was the only non-factor therapy available for all this while. The concizumab has come in, but we still have to gain the experience. When emicizumab came in, if you look at the story of emicizumab, Midori Shima has written out, when the Japanese did this, they are the ones who did this. They gave it to normal persons also, and they gave it with 3 different dosages. You know, anybody who is doing study and they spend billions of dollars on study, any industry for high class drugs, they do take good care. I would agree, or I would imagine that they would take good care that they should not underdose the patient, because if it becomes ineffective, they will face non-recognition by the regulatory authorities. In cases of non-factor, emicizumab, concizumab, fitusiran, are all included. They also have to take care that they should not overdose it, because the complications could also lead to the same problem. So they have done it. And when we are stating that, let us say, you know, this is an old story. I think that severe hemophilia, let's make them mild or moderate, and they will do well. That has worked well for many years, and I think maybe half a century. But now for a decade or more than a decade, we know that the factor level does not tend to correlate with the bleeding phenotype. And that there are some who are moderate, but they bleed more than the severe ones. There are some mild also who will bleed. So the bleeding phenotype is one of the restrictions, which brings us to a point that when you are treating them, you must keep in mind the bleeding phenotype. A severe one may be such infrequent bleeder that a moderate one who is a more frequent bleeder would probably need more aggressive regular replacement therapy. By the way, I don't like this term prophylaxis, which I think is a misnomer. It should be regular replacement therapy, like we do in the case of diabetes mellitus, where we do regular replacement with the missing protein called insulin. So when you look at these types, the factor level is not the determinant, right? Factor level also is a determinant, but is not the determinant in all cases. The second thing that we have learned from the recombinant treatment therapy is that the factor level that we achieve, because there we achieve the factor level because we are infusing the factor, you can measure it. The factor level, if you go higher and higher, it does not mean that they will have zero bleed. Zero bleed also is a statistical misnomer, but we will not get into that. So that means it could not be stopping all the bleeds. And the third thing that we have learned is, even those who are not bleeding while on regular replacement therapy, even if they are not bleeding, they have something called the subclinical bleed. And those subclinical bleed could be damaging the joints, you know, on a continuous basis. So the point I'm making is, it is not this easy to take a call as Dr. Rucha is made out to be. You know, in our, you know, these teams and committees. I was asking Dr. Sunita, were you a part of that committee? She says no. So I said I was not alone who was left out. So when you look at them, it's a different concept. And also when it came to emicizumab, it is more complicated. I think she projected, because it has come out in some papers, that emicizumab will give rise to an equivalent of 10 to 40% of the factor level. That's what he said. No, it does not. Emicizumab does nothing to the factor level. Emicizumab, it is a wrong information that is being given, that emicizumab is equivalent to this. Because emicizumab is not a factor, it's a factor mimetic, it's a non-factor therapy, it is not raising it to that level. And if you say equivalent, it's very difficult, because I told you that a factor equivalence has gone away for the past few decades from this correlation. You know, the factor level determines the bleeding, has gone away, so emicizumab will also have a problem of this. So I think keeping all these in mind, when it comes to non-factor, it's a different domain. When it was a clotting factor, it was a simpler domain. When it was a clotting factor, we knew that we are giving it. But we realized that there were two restrictions. One, in a case of hemophilia, there was a limit to which we could raise the levels, not beyond that. And second, whatever level you raise, you will never achieve a zero bleed. So it's a little more complex, and that's why the guidelines that we are talking about, they also give rise to some reference to these, but they are more complex. So I don't think I can give an answer in this Hemophilia Federation of India meeting, because it's more technical. And that's where we need to sit down and create, and it will not be all or none, that I write one sentence and say, okay, this is the protocol for all such patients. It would be a parameter, like we said, decision making tables, which run into three pages, giving different variables and parameters, and then taking a call. But it is a very good drug, it's a very good drug, but we would not want to be seen that we are setting wrong precedents.
Ma'am, both the talks were fantastic. I have few questions. So first is, as you mentioned, that the low factor levels do not correlate with the, so we need to confirm with the genotype, that
Yes.
they're carriers or not.
Yes.
But is there any cutoff where we can just conclude that the female is not a carrier?
No, because we have carriers who have 60, 80, 100% factor rate levels, normal levels. So how can you conclude any cutoff? No. It has to be done opposite way. Once you do the genetic testing, a female should know her factor levels.
The second question is, so at the time of amniocentesis or CVS sampling, are we supposed to give any factor prophylaxis or factor concentrate to the female as to prevent the bleed? So basically when
No.
we say the female is a carrier.
No. Till date, none of our patients who have undergone have ever taken a prophylaxis or something like that, and they've all done well. Because they're pregnant, right? Already pregnancy is a hypercoagul, so it works well, it's fine.
And the third thing is, ma'am, when we have genotyped the female, the carrier, then when we have know the genotype, so in the fetus we are checking the same gene
Yes,
mutation.
that is why we need the index case. So what we do is, in the index case, we find out what the mutation is. That same mutation is seen in the females for carrier, and the same mutation is seen in the fetus.
Fair enough. Thank you. Thank you.
मैम कैरियर टेस्ट होने के बाद कैरियर टेस्ट तो नॉर्मल आ गई थी, लेकिन बच्चों तो हेमोफिलिक बन गया है। ऐसा कभी कभी होता है क्या?
स्पॉन्टेनियस म्यूटेशन की वजह से हो सकता है, बट इफ द कैरियर टेस्टिंग हुआ है तो कोई तो फैमिली में हीमोफीलिया होगा ना? कोई नहीं है।
नहीं, हेमोफिलिया है
ना, तो उसका कैरियर टेस्टिंग आपको वापस देखना पड़ेगा। इफ फैमिली हिस्ट्री है एंड दैट लेडी हैज
पूरा फैमिली का किया है, बॉम्बे में ही किया है।
ओके, मुझे या प्रेम को व्हाट्सएप कर दो, रिपोर्ट्स में देखती हूँ। Done. I would like to just conclude because of what sir see. I don't want you to this our motto. Okay, there are 3-4 different mottos. The motto is to get all the drugs in the market. It is not telling which treatment is good. So to get it into the essential drug list is one aspect. That is what we were fighting for. Which treatment is superior is not what we were fighting for. All treatments are superior. If you give EHLs at the highest dose, you will again get low bleeds. If you get emicizumab at the low dose, and what sir rightly said, yes, now see, even I agree with this. If Roche company has given a standard dose, it is for some reason. What we are thinking of is, we are seeing the right now, 6 months, 1 year, long term, if you go to see, those patients on standard dose may have better joints. On the lower dose, they may not have. This is something which you have to see in the future. But for right now, as I said, my motto as a government body is something is better than nothing. If things are in the market, then the clinicians can play with it and they can decide on their own what they want to give. But all should be available to everybody. That's it.
I think, this essential drug list, you are going to come to our national conclave and we're going to have a session on that also. Essential drug list has also been understood and misunderstood for a long time. Everybody, WHO has it, nation has it, states have it, hospitals have it, everywhere it is there. When we started Hemophilia 2007 and 8, we never bothered about essential drug list for hemophilia. And when it did, we used to have a rate contract. If it is approved for our hospital, any Delhi government dispensary could buy it. And we got into trouble because small dispensaries started buying clotting factor 8. What will you do? Maybe some patient has gone and says, Lelo. So we have to put a restriction that that will not be applicable for it. Essential drug list is a very important list, but I think when it comes to these niche products, you can't create an essential drug list. What is the purpose of essential drug list? If I create an essential drug list, I'm saying this will be available in all the districts and PHCs, or I'm saying it will be available on all the AIMS only? No. And to the best of my knowledge, there is also a notion that is, I don't know whether there is somebody from NHM here, because as they said, I don't go to these committees, so I can't raise these issues here. You are there, sir? NHM does not have it is attributed that NHM has an essential drug list where it should be incorporated. But to the best of my knowledge, they don't have a EDL. And EDLs are not meant for rare blood diseases or rare disorders, orphan diseases.
Sir, I am from Bihar. In Bihar, it is.
बिहार का नहीं, हम सेंटर की बात कर रहे थे.
No, sir, I am from Bihar.
Sir, if time permits, आप बताइए.
But just I want to know, before EDL, it should be included in NLEM, National List of Essential Medicine. Then only a state can include in their essential drug list of a state. So first it should be included in National List of Essential Medicine.
See, national list has become more dynamic now. There is no list that gets printed once and once for all. National level, what they are doing, I believe, is whenever there is a need, and there is a group that gets like infections, for example, they'll come out with. Okay, we need to revise it. Which one you want to take out, which one you want to bring it. But you can do it on a dynamic basis, real-time basis kind of thing. So we don't have an essential drug list which is in vogue until the next one comes in toto.
You are very right, sir. Actually, essential drug list is generally prepared by Ministry or Department of the Health, but NHM never prepares any essential. But the thing is that NHM gives approval on the base of national essential drug list, and these EHLs, recombinant and exogenous, these are not in national essential medicine list. The request is to include these drugs in that list, so that state can procure and give approvals to their procuring agencies to provide these medicines at least to authentic centers, not to CSC or PSC, but at least
I am not getting into that, because हम कोई लक्कर की लकीर, पत्थर की लकीर नहीं है. जो कायदे कानून बनाए जाते हैं वो इंसान बनाया जाता है, और उसमें अगर कोई कमी है तो वहाँ ठीक कर दी जाती है. आज की तारीख में अगर आप कहते हैं एक ड्रग जो है तभी दी जाएगी जबकि नेशनल एसेंशियल लिस्ट में है, हाउ कम कुछ स्टेट्स उसको दे रहे हैं, कुछ नहीं दे रहे हैं. एक ही स्टेट में कुछ सेंटर दे रहे हैं, कुछ नहीं दे रहे हैं, और सब सरकारी हैं. माइंड यू,
नहीं, the thing is that state can procure, but NHM cannot procure, क्योंकि NHM is guided by through national essential drug list, and ROP is based on what government of India approves. So NHM.
I'm not. That's what I saying. Essential, sir. आप सर बड़े सीनियर हैं, सर को बताने दीजिए. Dr. R.K. Nigam from. He has been connected with all these big agencies of the government committees.
As far as my knowledge is concerned, NHM is not giving essential drug list, one. And the rare bleeding disorders, they will never give, I think so. Because if there are, I'm not blaming anyone, but this is a system. If there are some big holes, albeit is at present is global. If it is in EDL, whether patient is there or not, they will procure and that will be deducted. That is the main fear of NHM people who are not giving in our state.
I am so sorry, but for the organizers, I need to close my own session. We can discuss this later on and then they can take it ahead.
Thank you so much, ma'am. With that, we now move towards our next session, which is Innovations in Care Industry Symposium. In this session, we'll be engaging in a very thought-provoking panel discussion on the topic of EHL therapy, exploring the many possibilities in real-world hemophilia care. I request Dr. Parul Bhatt to come on the stage as the moderator, and I also request the panelists Dr. Sudhir Atri, Dr. Varun Wafna, and Dr. Sunita Agarwal to please come on stage.
interactive session, and there is a already previous session we heard about that all the drugs should be available and it should be available for the all the patient. So treatment for equality, but there are some real world data also help you to understand what is the importance of choosing which drug to depending upon the patient's convenience, doctors real data experiences and the patient performance. So today we will have a small discussion with our three expertise on the EHL therapy, that is exploring the many possibility in real world hemophilia care. This session is going to be interactive, so you can also have your question to our panelists and this. Let us have some briefing. These are our panelists. As we know that why EHL factor 8 is a key difference between the SHL and EHL. There are two varieties are already available, but as we know the name itself suggests because it is a extended half-life, that suggests there is a half-life is more than 21 hours, whereas in short acting a standard half-life having only 11 hours. Prophylaxis is required fourth day of the every week or either weekly can be given, whereas in the alternate day in SHL, and 1% time of activity will be for EHL it is more than 6.5 days. So there is a double day, patient will have a more than 1% factor level in the body, and of course because of that the patient will have a perform well. In that case the median ABR will be in EHL will be only less than 1% in adult patient as well as in the pediatric age group as compared to the SHL. And of course the patient with zero bleeds are more because of the again the factor level will be always in the more than 1%, and because of that the target joint bleeds are also 100% will be covered. So these are all the things we know about it, but there is still sometime SHLs are available and EHL may not be available. So what to do and why to prefer EHL, that we can decide on, because of the regular replacement therapy is only and only can be successful when patient is adhered to the regular replacement therapy, and that can be achieved when there is a less frequent injections are given. So once weekly will be more tolerable, or adherence to the regular replacement is therapy is to be given. And most important, consistency in the regular replacement therapy is very very important, or we can say key to the success. As the duration of treatment increases, the more and more benefit will be there. So that all factors are prefer the EHL over the SHL. And also we know that EHL has having a mainly useful in the surgery also. They have been because of their blood level is always more than 1%. It can be safe to use in patient those who are going for minor surgery in form of tooth extraction, that is more frequently we are getting patient, as well as those patient may require any time knee joint replacement, intracranial bleeds, or may have intra-abdominal pain or thoracic surgery like a major surgery. In that case also the EHL is be preferred over the SHL. So because again I said it is been used both for the patient or the person living with hemophilia less than 12 years and more than 12 years. So these are the some advantages of the EHL therapy over the SHL, that is very well defined. There is no confusion about it. Of course the name itself suggests, and again it makes the severe hemophilic patient to at least moderate hemophilic patient, and so again the chances of the bleeding will be less. Looking to all this brief, and we have a huge experience at Gujarat using this EHL therapy. We would like to hear from this expertise at their state how they are using. So going to this panel discussion, first question I would like to ask to Dr. Sudhir Atri sir, that how do the patient perceive the reduction in infusion frequency with the EHL factor 8? Does it translate it into better adherence or quality of life? What is your experience at your place?
First of all, good afternoon to everyone. As you have already briefed about the EHL, and we have some practical experience with the EHL, and not for prophylaxis actually, but on-demand therapy in EHL. So definitely, ma'am, because half-life is much better, much longer as compared to SHL, though there is a less frequency of the injections received by the patient. And this is the first important part perceived by the patients when where the patient has to visit the clinic less. The less number of visits has to be performed by the patient actually. And not only the visits, even the quality of life as compared to the SHL, because trough levels are maintained for a long time, so there is a good quality of life is also achieved by the patients with the EHL basically. And then the ease of storage also with EHL. If we read the, you can say the package insert, SHL versus EHL. So ease of storage at the room temperature, it can be stored unpacked for 2 years and even with, you can say, for 1 month. So that is also the very, you can say, advantage of EHL over SHL basically.
Rightly said, sir. So anybody would like to share their experience regarding the EHL therapy? Any confusion regarding what sir said, that the adherence to the prophylaxis is very easy, as well as the of course because zero bleed we can achieve, joint bleeds will also be recovered, so there is a quality of life will be here. So that is why the one study results I am just putting on in front of you, that most of the patient, they have asked through the patient what is your satisfactory level. However, it is a clear cut, but let us have, this study shows that 76% patients, those who are having on regular replacement therapy, and 24 patients are on demand. But this 76% of the patient has given a, most patient will having a prophylaxis have a lower injection frequency, so there is a main reason of the satisfaction, because there is a lifetime treatment is required, and of course the single injection is matters, and patient receive this quality of life score improve from the 4.8 to 65.9, that is p value is very 0.01, so it is very very important. You know, stress level, there is a coming to the hospital, and caregivers pressures, and all these points are being covered under the quality of life score. So that is very very important. Ultimately we want to give the very best quality or as equal as the normal life. So flexibility of score at room temperature was also one of the key convenient factor for giving this satisfaction, and frequency of injection is also very easy. Storage, efficacy and quality of life of course will be with expired, that is factor 8 EHL is very very important. That helps the caregiver satisfaction also. So all over the treatment is very safe and very acceptable. That is what is our purpose is. We are able to provide all the products, but the patient acceptance is also, because there are so many knowledges from the Google and other patients review, and everything are with the patient, but the thing is the we have to be convinced the patient that these are the things can be, and these are the study results, but our patients are doing more better than 76%. I have a result in our center is more than 100%, having a 100% result. So our Indian patient, Asian patient are doing better than related to these studies. So yes. Mike.
Recommended the EHL actually to the state authority also basically. That should be procured, EHL preferably.
Yes.
Routine.
Right, sir.
Based on these factors.
Right, sir. So that is what is very important. We have to see the caregiver's satisfaction as well. So this is a competency of molecule that stands for. Now now I would like to ask Sunita madam that do you think that EHL offer a scope for individualization of the prophylaxis in your clinical practice?
Yeah, prophylaxis, EHL in prophylaxis.
Individualization.
Just wait.
That is also one of the factor to select this product.
Yeah, prophylaxis means the less ABR led. So we can individualize according to the Pathfinder trial 2, in which they have used the 2 doses, in which the 50 IU every 4th day and 75 IU every week. But 75 IU.
This is not display here.
75 IU per week only in 0 to 2 bleed in 6 months. So if the patient is having the less ABR, we can go for the once weekly, because factor level more than 1% remains at least for the 6 days. But if the bleeder is the patient is having the annual bleed rate more than 2 in 6 months, then you go for the 50 IU per kg. But it is the standard practice. But recently last week even in the WFH published a recent article in which the resource constrained countries, they have advised 10 IU per kg every 4 days and 20 IU per kg every week. Results are comparable when say the 50 and the 75, they have reduction in annual bleed rate less than 1, especially when they are used for a prolonged period. We have the 5-year data, 6-year data for that the annual bleed rate significantly decreased less than 1. Even there is a target joint resolution, and even the chances of spontaneous bleed in which the 60% around with the 50 IU and the 80% with the 75 IU. So we can individualize the, depending upon the annual bleed rate, depending upon the availability, depending upon the cost, and that especially in our developing country where we have to think about the resources. Then we can try, like we are discussing the low dose emicizumab, we can discuss the low dose EHL therapy in prophylaxis also. Already low dose SHL therapy is going on in many centers and results are comparable. It is not like that they are not effective at all. I am using for the last 3 years and the results are very good. Patients are quite happy. So we can individualize with the EHL also, and we can individualize with any factor therapy. I would say this.
Yes, rightly said. That is any dose you can individualize. One factor we use is at our center is what the activity, what job he is doing. Depending upon that also we individualize. If we have one fellow, he is doing Amazon delivery boy, you know. So he have to kick every time the bike and every time they have to rush. So in that case there are chances of joint bleed may be more as compared to other who is doing table job. So depending upon the workplace, where he is, what type of activity daily is going to do, that also one of the point we can decide. And from result you can see, you can use any 50 IU per kg or either 75 IU maximum to 100 you can go. That will give the result less than 1 bleed rates significantly reduced. So that tailoring of the dose is very important, and this is only the studies result, but the real world experience also shows you can increase or decrease this. So that is why same way for applicable for the emicizumab also, we low dose prophylaxis we are discussing. There is nothing to discuss. It is individualized. You can individualize whatever the patient metabolism, what is the patient status of the activity. It can be, dose can be increased and decreased. So that is very rightly said, madam. And this is not only the experience, but that also shows that again I said, that is the duration of the treatment increases, that again the more and more benefit when we get in both the dose, like a 50 IU, there 64% patient and 81% adult patient, and 75 IU achieve the zero bleed. Ultimately both will, duration is very very important, and how the duration, how your patient person with hemophilia adhere to your replacement therapy, that is what is the less frequent injection. That is very very important, because you have to tell your patient within 3 months he will ask you whether I am okay, I am getting some pain, but that is not true. Let him to take it a more longer duration and more benefit he will get. So our patient at our center, they are taking more than 3 years, having zero any type musculoskeletal pain, and bleeding of course any zero. So I think every panelist is agree that the duration is again same and very very important. And that is why the WFH has also been included in the regular replacement therapy, the various dose for hemophilia A and for B, that is a EHL, and we can tailorize according to the patient need. But there is a flexibility of dosing. That is what this slide is showing. You can have a flexible dose selection and can be depending upon the patient. So it is sometime it can happen like from private doctors or somewhere the patient brings the prescription, and if you are following some other guideline at your HTC, then the conflicts may arise. Some doctor has advised me you have to take this. So then the guideline will help you to explain to the patient that WFH also has a recommendation. Always medicine is such a branch, everywhere there is a guideline based practice is been promoted, and that will help to prevent the morbidity and mortality. The guideline is very very useful. However, the real world experience is of course useful, but the guideline will help us to prevent the morbidity and mortality, because it is again a real world experience. So this also says we can individualize the dose, and it can be different from each patient. So now question to the Dr. Varun Bapna, a very energetic hematologist from the Maharashtra, in which is involved in so many clinical studies also, and he's presented so many papers in the international platform in clinical management of hemophilia, where all you are use EHL factor. In your experience.
Yeah, ma'am. In the EHLs, we have quite lot data since last decade. We are having the data, as Gupta sir has already mentioned, for the factors. the data is more. So we are also using more of the EHLs on demand. Also we are using for prophylaxis. Also we are using. So mainly on demand. Also we are finding the results as with the single 20 IU per kg, as you have told, it's an individualized. Those are resource constraints we are giving, and what we see the trough levels also at the end of 24 hours, it's still maintaining close to 8 to 10%. So that was quite a good, and the results were happy with that. On the prophylaxis basis also, I think I have a data of last 5 years, but we are using it at 20 IU per kg weekly once only, and we have got a close to ABR is around 2 to 3, as 0 is not there still. I don't, I'm not using the full dose, so it might be less, but it is still 2 to 3 ABR is there. What is my data is suggesting for that?
So you can increase the dose, which we have practiced at our institute. That starting with the low dose, looking to this bioavailability in the blood, this factor assay, as well as the bleeding rate. We should achieve less than 3 bleeds per year. That is what is the purpose.
So what we do sometimes, we try to give twice weekly then. For those patients who have ABR more than 5 for these patients.
So basically there should not be any confusion, you know. The thing is that the less infusion is the main characteristic of the EHL, because it is a IV. So better is to use a 50 IU for weekly or something
weekly,
like
that is another option.
So ultimately the adherence is, as I previous slide show, the consistency of the treatment will give the better result. So you select such a dose that patient will adhere to the treatment plan. So that is one of the aspect.
Then we are using for, I think, breakthrough bleeds with non-factors therapy. We are quite comfortable with EHLs. We can use it. And one more about the temperature which we are discussing. I think the interesting thing is, if we have used the vial, if already we have reconstituted it, we can use up to 24 hours if we keep in the fridge. That is still the guidelines as per they are saying. So what we are doing is, sometimes today if we are used in second dose, if you want to give tomorrow, if you have half vial we have used, you can use the within 24 hours the second dose. So this is one more advantage what we are feeling.
Room temperature it can be stored. We have a good slide on that also. So
and one last what I think is target joints resolution. I have seen much better if we are compliant for these EHLs. If they are going with weekly dosing of as 20 to 30, 20 to 40 IU, the target joints is 3 to 6 months. We are seeing reduction up to 80 to 90% of the patients.
Right. That is what exactly the patients is requiring. That already damaged joint, when these products were not available, there is already the joint damage occurred, but there is a resolution is also, and it is a MRI proof also. So disability part is also reducing, percentage of disability. So again the consistency of the management treatment and the patient adherence to the regular replacement, that you have to select such a dose. So this is one perception is also that this is in body of hemophilia A patient or something like a B, there is a factor deficiency. The other pharma company may feel not good, but see there is a deficiency that is replaced, we are replacing. So it is more biological, you know. So again it is 1 point ahead to the other therapy. So again there is one advantage, that is when there is a need of the factor replacement, which is the deficient, we are able to supply to the patient. So this is what the conclude. Now again I go to the Dr. Sudhir Atri sir's question, that how do we improve the prophylaxis? Still there is we have more slide on this. Still the India is behind prophylaxis scenario, and that is what is your suggestion for policy maker, and how all we together should do this thing? Still we have to really do too much.
Madam, very, very tricky and pertinent questions. I will tell the reason vary from state to state actually, but one of the main limiting factor is the budget actually.
Right now you just tell me the India, at the India level, and then we will go to the state level. What at India level, what is your perception? Do you feel it is sufficient prophylaxis
No, it is not sufficient at all. It is just a minuscule of what the current economy or equal economy are being achieved actually. And there are various reasons for that.
Right.
Reasons vary from the state to state. Some of the states have good budgets. There are certain limitations, awareness about the disease. That is one of the important reasons. Then delay in diagnosis. Some centers are very good, some centers are not totally aware of this. Even the population is also not aware of it.
What do you feel?
The awareness about the disease, awareness about the diagnosis, and they prioritize the hemophilia treatment also. That is very important. The prioritization of the hemophilia, the development of hemophilia treatment center. There should be a separate dedicated budget.
Right.
Usually what happens, it is mixed with the common budget actually. And then the comprehensive care. And there should be the universal access of these factors to everybody, irrespective of this. So these are the few points actually, but to me actually I will still say manage the budget in state.
That is personalized like your state, but other panelists can also share their view. Okay, what it should be like Viksit Bharat or what XXXY we are thinking of, what is in your dream. Anybody from audience also can share their what it should be. It should be like that. Everybody should be on prophylaxis, or at least those who are having a target joint or moderate to severe hemophilia should be. Madam can also.
Ma'am, everyone should be on the prophylaxis. There is no doubt about it. Except in the mild hemophilic where the annual bleed rate is very less. But ma'am, it is the administrator, it is the clinician, and it should be the national hemophilia program, I would say, which should be applicable to all states, should be the proper national guidelines, which should be equally applicable to all states. It is not like the one state is getting better treatment, other state is not. The slogan is the one country, one treatment, and it is possible like we have achieved our targets in tuberculosis and HIV. If there is a national hemophilia guideline, proper budgeting will be there at the ministry level, proper dispensing of the medication to every state according to the patient's load. It will be there unless it is a uniform distribution, uniform allotment of budget per patient. It is not like the per state budget. It should be the per state, per center. Then we can achieve the goal of one country, one treatment. It should be at the Ministry of the Health. Like we have the already prototype in the DOT center, ma'am. We have the 565 districts and we have every medical college. Why can't it applicable to all medical colleges? They should provide the hemophilia treatment center of their locality. Then problem is automatically solved. I think so.
That is what the sir is already.
One dose, one product.
One everything and equality and the health is my right. Badda je sentences, all these sentences should be corrected. It should be for. Varun, would you like to say something?
No, ma'am. I think Gujarat and Rajasthan is only the highest.
No, at India level.
Consumer for the factors, I guess. Maharashtra we get only budget of around close to 50-55 CR.
Everybody is there agree that it should be equal for all.
Yeah, definitely it should be equal.
That is equality. That is at least I can.
So what happens usually? NHM gives the 50%.
Anybody wants to tell anything?
NHM gives the 50% of the budget and state has to procure 50%.
Yes. So HFI
usually
right now
Maharashtra don't give a single penny. What sir is here, and I think the other states like Gujarat or Rajasthan they get completely from state also. So it will become one. Treatment one nation.
Sir, would you like to tell? That is what the sir first lecture. That is say one treatment, one nation. Everything is equal for this.
There should be the proper referral system when they go from one state to another. We don't know when the last dose is given to them and which product was given to them. They are just roaming here and there. It's a difficult situation for the patients.
Right.
I know.
So how to solve it? How to solve it?
No, referral is a big issue, and I think we can keep talking about it. We have no referral. We have everybody who is a super, autonomous and know-all person. So one center, another center, they may not, sit together. Even if they sit together, I'm not going to be willing to follow somebody else. But I'm taking you away for a lighter moment because you probably are doing the maximum, as Dr. Varun said, care of the hemophilia.
Yes.
You have the maximum budget that is spent and most of it on regular replacement therapy, which I am happy that you have also adapted to it.
Thank you.
I just have a small query.
Yes, sir.
It just came to my mind. I was looking at this slide. So the annual global survey has been coming out.
This is very old also. I can add before you ask anything.
No, don't move it, don't move it.
But
so
there is an improvement in this.
No, 1 second. So 2019, there was a survey. 2020, this is done an annual global survey by the World Federation. And 2020, and actually it comes out a year later. So 2024 survey has just come out in October 25. And she has written all of them. 2018, 19, 20 data are all projected from India. Is that right? From India?
Yes, 9%.
Isn't it?
Only 9%.
But I was foxed by
9%.
this line. Data on prophylaxis not reported for 21, 22, 23, 24, more recent ones.
That is
When
what
we
I
are
am
saying
telling
that
you.
we are using more factors, why is it that somebody is not incorporating that
Reporting
data?
is still there is a.
No, we were reporting in 18, 19, 20 when we were using less.
Right. So I said it is a very old, but still there is. How many of from audience say that there is a still prophylaxis is lacking in India? All are not getting the replacement. Can you raise your hand?
Of course,
Let them to raise. They're the active
majority
participation.
are not getting it.
So then, sir, your responsibility is more that one nation, one treatment plan. We all together with you, sir.
No, I think the confusion about the prophylaxis is twofold. The whole scenario for hemophilia started from the state of Delhi, and I was party to the Honorable High Court, where the question came up that we will give the treatment and we will provide it. The question that was asked was, that was the Honorable High Court Chief Justice Dr. Mukundam M.K. Sharma, who will pay for it? And pat came the answer, BPL will give it free, the others will give staggered payment. I actually smiled out. He says, what happened, doctor? Why are you not happy? So I told him, this is the cost. And his thing was, even I can't afford it. Right? So the answer was very simple. We'll give it free to all. But when the order came out, and that time, mind you, that time we were giving only on-demand treatment in 2007-8. So it has come out that it will be given free to all the patients with hemophilia, BPL or non-BPL, when they come in emergency with a bleed. Right? Now, we have been silent because nobody reads the judgments. But when you technically look at it and tomorrow something comes up, we have to have a separate approval. I don't want that court should approve it, but administration has to approve it. And that's why I like Dr. Prem Rupalvachi. He came up with these guidelines that we need. Once the administration says we go in for the regular replacement therapy, then you are free. And once you are free, then you are free to use whatever dose you think is most appropriate. Low, sub-low, medium, high, whatever. That's not the issue. So my query is the administration across the 28 states and the 7 union territories, 9 union territories, do not have this kind of a directive that the healthcare providers in government departments should give the free regular replacement therapy.
Right.
And if this dilemma is not sorted out, we would remain like this. You know, let us save money, we are getting some, let's give half dose, or let's not give it because somebody will say, why are you giving it? So my say is, it is more of an administrative issue rather than the doctor's issue.
No, there is nobody, not doctors or not the patient, but of course the administrative and supply chain there may be different in the different state. But still we are talking at the national level, India level, we should have one thought that everybody should, we are still under treatment to our patient, we are not able to provide a regular replacement therapy in all those who are indicated patient. So we have to still to work together, and that is again a message that although prophylaxis delivers superior outcome for a person with hemophilia in India, broader and the more consistent adaptation is still needed. That is all we are already doing. Today we are together for this only, you know. Otherwise some doctor conference there is different thing, but still we all are together. So this is what one step we are ahead. Would you like to tell anything?
Sir, just I give you an example at our institutions. I have prepared the entire budget for hemophilia. That was around 10 crore rupees. There was straightway refusal. We cannot afford such a huge budget for your patients. Only 10 crore, sir. Only 10 crore.
So there is always a constraint supply, this thing availability and
Do they
but
give a
we have to
reason?
overcome. We have to overcome.
Do they give a
it.
reason? Sir, shortage of budget, total budget our institution is around 30 to 40 crore rupees, out of which 10 crore they cannot afford it.
So it's your institutional level that.
Yes, sir, institutional level.
Not
Because,
the department.
some of the hemophilic society person should go to the Vidhan Sabha and they raise the FAQ. We have that system that during this thing, the direct question can be asked, and that is really come out with some positive solution to represent.
Dr.
that
Cherry
problem.
want to say something, I think, from Dr. Cherry.
Yes, बोलिए madam.
That states, as the state government has envelope of the budget that is allocated to the health, and the hemophilia patient number is very less, and when they see it that only for this number of patients this much of budget is required, although it is life saving, we definitely go for it and fight for the patients, but the point is that there needs to be a creation of a special head under
Yes, yes.
NHM, a special head that treatment budget allocated to the state for procurement of these medicines for the hemophilia patients.
For all.
This column is there, then every state will be proposing, and
Right.
then NHM health will have to give. Although we this time we proposed about 70 CR for the
Okay.
whole state.
Okay, good.
Only for
good effort we can say.
only for 1,000 patients.
But you have done from your side a better.
Ma'am,
na?
but the thing is that there is the resource envelope for the whole
that is
state. and
we will
NHM.
represent to NHM that.
Yeah, that is
what-
the NHM has a
The
all the
HFI is
states
writing
have
na, all these things.
all
Are you
the
writing?
states have a ROP envelope, and when they see the envelope, they say that this much of budget only for this much number. So you really or even though the administrators and doctors and everybody over there also knows about it, but still the number of the patients and the treatment cost really going so high, and since when we are going to add up the non-factor therapy, we cannot stop the factor therapy. We are going to it is going to be addition, it is not going to be replacing, although it can be later on going
But
ahead with the things.
looking to the previous scenario, there is some improvement. Do you feel there is some
No, but the
improvement?
NHM has totally refused because they have a resource
but
envelope.
we will try for that as a together, like
Yeah.
and we are representing the NHM.
That
also.
is the major point over
Major.
here, that NHM should be
Show
added
this
from
slide.
the over
Slide.
here.
So
The
this
F-
is what the suggestion for a
head
doctor as a policy maker.
Yeah,
That is,
FMR
we
head should
have
be
to
created.
prioritize the hemophilia care within the national healthcare program. Allocate the dedicated budget. See,
Budget
this
head.
has been included.
No, ma'am, not only the budget. There should be budget head. There are different
Yes, yes.
budgets. When you see there is a blood disorders, so they say that you can whatever you propose, free drugs and diagnostics for the diagnostics for the lab head. But there should be under blood disorders. There should be a proper head. Just as for thalassemia, they have added this year for the key indicators that there is whatever screening for the screening of the patients for thalassemia and hemophilia.
Yes.
They have their indicators. So there should be treatment. How much treatment has budget has been spent on treatment. Second head
Right.
should be for the treatment, procurement of the medicines.
Right.
That head should be there. Then only dedicated budget will be going. And
So
then
what
the
do you feel?
sustainability
What do
will
you
come.
feel? Who should be the head of this? At your institute, you should be. Start from a small to bigger.
Ma'am, it is all the administrators.
So
and
start
I-
from yourself. That is what I
are
can
trying our
say.
level best.
First, we should start ourselves.
Ma'am,
There is
With
a
such vision
mismatch of
and
the
guidance.
budget. That is a one point.
Yeah.
Mismatch of budget in every state is a different. That
this
is a big thing. But NHM can be communicated for that, and that
No,
will
ma'am,
be.
NHM should be that they should give it. They,
They
should
should
put
give
this
it.
head.
Yes.
If they put this head, then it will be like everybody will be asking that why you have not demanded this. So they need, even if they ask for a smaller amount, they will need to give it.
So
So
for
when they
a-
start with a smaller raise can be there. If you don't give it, come it as a zero, then
Right.
they won't give it at all.
So that is one when we ask anything,
Yes.
then we our responsibility also increases, and that is what is generate and share the local real world data.
Yes,
So there is still registry is still lacking in some place. This is what the previous data in HFI is Dr. Premrup, Mr.
But the
Premrup is.
registry part is
So registries again we have to improvise.
Ma'am,
If
even
data
if
is there, then
ma'am,
again.
Ma'am, even if we are improvising the registry, but they have the National Sickle Cell Portal. the sickle cell part is going on till the subcenter level, till the peripheral institute smallest level.
Right.
It is already streamlined because of the point care testing.
Okay.
For hemophilia, we do not have point care testing.
Okay.
And for the sample transport and all the things, although we are working upon it, but still it poses a lot of differences, and because of that glitches in the portal, the registry is not complete.
Right.
We are struggling with updating the registry.
So there is a gap that we have to analyze and then correct it. So that is a good point you have shared, and I can understand your feeling. But this is what we are together today. We will definitely go ahead for this thing. But this is what actually the meaning of this session, the policymakers' view. So this is we know it is very important. So in contrast to real world hemophilia care, how does EHL factor 8 offer advantage in terms of temperature stability? Madam, you would like to say something for? So it is again
when
very
we are
easy to
using
use.
the standard half life, there is an always problem of storage. Patient cannot buy because they don't have fridge. There are multiple problems. But now with the EHL, they have the approvals for that. If the 2 to 8 degree, they can keep it for the 36 month. But if it is the 30 degree at the room temperature, we can store up to 1 year. And even if the higher, we have the different temperature at the different places in India. Now in Delhi, even at the 40 degree we can store 3 months, but it is not dissolved. Even after the dissolution, we can keep at the 2 to 8 degrees for 1 day and 4 hours at 30 degree room temperature at this time, even for the 1 hour. This is a bigger and the advantage EHL over the SHL, where the storage means a lot, especially for the home therapy. It would basically a step ahead. Ki patient will now be, we can convince the patient for the storage. So it is a bigger step for the EHL over SHL.
Exactly. So temperature is not to be strictly required if it is been. It is very at room air also, and at the same time it's not affect with individual lifestyle. के हमने freeze में ज राखू पड़से ત્યાં you cannot travel or something like that. So it is
Travel become very easy with these
traveling is
EHL
very
because they
easy.
can carry
So
now.
this is an additional advantage. Once you give the normal quality of life like a normal human being, again the socialization will be more, and then this is the factor will be useful. So again it is an additional factor for this. So again, Barun, would you like to say any more benefit for surgical patient, those who are on EHL, of course?
Ma'am, I think it is very easy to infuse, and then we don't have to monitor because trough levels are continuously monitoring, and the hemostasis is achieved very good. What we have seen in the data here, it is mentioned about 93.6%. We have also seen there is no any extra factor need to be given. What is my experience? If we go with the full dose also, then the trough levels what we initially used to monitor with the SHL, we don't have to monitor very frequently. What with EHL, what is my experience here? So overall for surgery also, it is much better compared to the SHL.
And it is true for all age group, that is also. And one again, this Pathfinder 8 study is very old, you can say, but again Indian patients are performing well with this drug. So again there is a more good result in both minor and major surgery, and very few patients require peri-operative replacement of more factor replacement. So that is a good hemostasis in a major surgery. That is a good point for this. So that is major surgical procedure, you can say any type like joint replacement, arthroscopic intervention, other orthopedic intervention and non-orthopedic. Everywhere there is a good response with this EHL therapy, both in more than 12 years of patient. And even having a major surgery, you can these results are also been found out. That is most of the 95.9% completion of surgery with a successful hemostasis. So this is also a big advantage of this molecule over the other, that there is no additional is required, and this is what exactly fear-free surgery, because as the lifespan is increases, the surgeries are going to come, and there is always we need such a product, and already the patient is already on replacement since long. replacement factor is required less during the surgery. That is also, so when you convince for this adherence for the regular replacement, this is also one of the important point that during surgery you will not require any additional dose. So these all are the advantages, you know, and that is why a article has been accepted in a curious journal and which has been published from my side. We have submitted, and this is an observational study at our Center of Glycopegylated Extended Half-Life Factor Prophylaxis in Hemophilia A and B, both at tertiary care center, and more than 50 patients have been enrolled in that. And you can see this accepted as well as it has been read worldwide. 445 articles has been viewed, 500 PDF has been so we are doing excellent. We are nothing to do less than that. That is we are not able to do it. That prophylaxis, that graph showing very 9%, it is not like that. We are doing most of the things, but there is a difference in the state to state. But and this is the key finding of our studies. There is a transitioning from the EHL factor lead to the notable improvement in the adherence as well as the quality of life of hemophilia A patient, significant improvement in both the health score, FISH and HJHS score, and reduction of the overall joint bleeds rates and from the baseline. And hemophilia A participant treated with EHL and factor rates show a significant increase in the number of the exercise and physiotherapy days. We have done everything. 7 days they are doing same exercise as the normal person, and 94.7% of the hemophilia A patient achieve the bleed resolution in 1 to 2 injection. If there is any bleeding is there, then replacement is also been treated very less injections. So this is a major advantage. So it has been accepted everywhere, and it is most of the US states also been download this article and they read. So what is the take home message is very clear that Experot enables strong sustained bleed protection with increased rate of zero bleed over a long term prophylaxis. Reduce infusion frequency with EHL therapy, improve adherence, satisfaction and quality of life, real world practice we see. And the flexibility of the dose, that is every 4th day or even weekly, allow the individualized patients centric prophylaxis without compromising efficacy. And temperature stability and the post reconstituted flexibility support the real life use. And Experot demonstrate a reliable hemostatic control in surgical setting as well, reinforcing the confidence across the clinicians. So this is what the EHL gives us the results. Thank you very much for active participation and both the participants. I think there is no more question and no confusion, at least. Always my view is that most of the conference sometimes there is a confusion, this is better or that is better. At least I can able to remove your confusion. Any final note would you like to tell? Anybody? Yes? Okay.
SHL sir, you are giving twice daily.
It is a
EHL you are giving once daily.
alternate day. We are
50%,
using
yeah.
for alternate day. So frequency of injections are more, sir.
And prophylaxis are doing every 4th day we are giving.
But basically, wherever we have used EHL, patient who is having
So
hemophilia.
you are asking on demand or prophylaxis, sir?
I'm talking about on demand.
On
even.
demand, okay.
If a patient has come with a bleed and he has been given a EHL dose today, next day again he comes over, my pain has not reduced, get me a second dose as well. That type of condition has occurred. And moreover, maybe doctors are using at the rate of 20 IU or 25 IU per kg body weight. What in SHL they used to do. So,
Sir, exactly the things are both are, however it is not comparable. The name it's the SHL has a low life, so it is 24 hours it disappear from the blood by and large. But again the metabolism of patient, their activity, that all will also differ. But EHL stay in the body more than 6.5 days. We have already in 50 patients which we have done is a this essay also.
when we are giving 100% to
No,
150%
50
level
IU,
rising.
even 50
50
IU.
IU is 100%, 75 IU is 150%.
Yes, sir. So in both cases, but they remain more than 1% in the body.
What is the need of giving above 100% level, ma'am?
Sorry?
What is the need of giving above 100% level raising?
No,
No,
sir,
it is
guideline
not like
says
that.
50 IU per kg on demand. On demand. For surgery, for prophylaxis, if you are using weekly ones, they have told for 75 IU per kg. Because what they have shown, madam has told up to 6 to 6.5 days, the trough level is above.
So whether you have compared the costing, that is 14 rupee per IU, there is hardly 6 rupee per IU. Have you compared the costing of the both the drugs?
See, sir, that is not a we have to look for. We have to look for the patient individualization. You know,
Ma'am,
Some
government is comparing that only, na? Ki, we have the budget of say 5 crore and for EHL.
To start
Sir,
with the low
these
dose.
were the trialed doses. Maybe it is used in the real world, but for the resource constrained country,
you
even
can
the
start with the low
WFH
dose.
advised 10 IU per kg every 4th day and 20 IU every 7th day. So it is the basically we need a long term data even on the low doses. We have the data of the 5 years with these doses on low. Maybe the low doses in future is more helpful for us, especially in India.
So individualization of this. Whatever the dose you want, but your patient should be symptom free, not only bleed free, but the pain is should be also disappear. So that is, and again the consistency. Ask your patient, if you continue taking more years, then more and more benefit will be there. So at that time, only symptoms we have to look for rather than the price and the dose. And what we are doing at our center is we start with 50 IU. If there is still some symptoms, we increase up to 60 IU, not going directly to 75. You know, some of these our studies patient are on 60 IU. Very few patient reaches up to 75. So there is always option of escalating the dose according the patient. So I think it is very interactive session. I hope everybody has been satisfied with this. Anything, madam? Okay. Okay. Mic ऊपर कर लीजिए थोड़ा.
Ma'am, if a patient is in amicizumab prophylaxis and goes for a joint surgery, because it is being introduced only now, so at that time they will need the factors only during the surgery part. So what will be the dosage or anything? There is a correlation or anything that has been seen.
Exactly in that case, if patient is having inhibitors, on emicizumab and inhibitors, then factor 7 is only the option. Fiba is also not been used. So only factor 7, but the dose will be not more than 100. It should be very less, like 50 or something. But for Fiba this. And if the patient is not having inhibitors and only on emicizumab, and however there are studies for emicizumab also. Okay, those patients already on emicizumab, even there is a traumatic bleed, it will be less as compared to those who are not taking. And during surgery also there are less chances of bleeding. And you have to replace the factor 8. And that dose is also, the WFH has already mentioned, it may be maximum up to 80, 60 to 80 depending upon the type of surgery. Can I go to back that? So this is the dose has been declared, guideline says. So this is what can you display on the board? So this is the dose, factor 8. And again, if you use EHL, there is less dose is required and more hemostasis you will achieve. Major surgery, minor though will not require in emicizumab. So we have to see the inhibitor level.
So in case of a patient with prophylaxis on amicizumab goes for a major surgery,
Yes.
so EHL will be a better choice.
Yes, EHL. Fiba should not be used. That is, we have to just take care. And the inhibitors are there, then factor 7 only can work. So another advantage is it. And again, there is anything else in this?
I think
But
we
good
also do
question.
the
Actually,
surgeries.
one point has been
Most
left
of the
out.
patient we initially try, if some are on prophylaxis with emicizumab, we go with less dose during surgery. It has a good hemostasis achieved. 50% पे काम अच्छा हो जाता है उसका. मतलब डोज की रिक्वायरमेंट बहुत कम हो जाती है.
So thinking a step ahead, we are not here to reduce the bleeding ABR or something like a joint bleed. We are now discussing the future complications, something like a major surgery, how the patient is getting benefit of this treatment. It is to be decided right now. What you are giving to your patient, future, because the lifespan is increasing. So that is what the goal of your treatment plan at your center, right? So thank you very much all of you audience and our panelists and of course the HFI for giving me this opportunity to experience my experience of our center. Thank you Mr. Prem Roop for inviting me all the way from the Ahmedabad. Thank you very much. Thank you.
Thank you to our chair and the panelists for such a rich and insightful discussion. I would like to request our Vice President Finance to please come on stage and present the mementos to the panelists and our chair. Our VP Finance to present a memento to our sponsored Novo Nordisk. I would like to invite Mr. Ritesh Ranjan Chaudhary and Dr. Muzammil Pathan to please receive the memento on behalf of Novo Nordisk. Take a short break for tea, and I request you all to please reassemble in 20 minutes as we continue with the next session. The tea is outside. There is this gate here. You can move ahead towards the tea area, please.
सभी अतिथियों से निवेदन है कि वो आके अपना आसन ग्रहण करें। धन्यवाद। Hello. As our next session is going to start, we request all the guests to come inside and take their seats. Thank you. सभी अतिथियों से निवेदन है ताकि वो आके अपना आसन ग्रहण करें। We request all the guests to come inside and take their seats.
I request everyone to please take their seats.
This is my granddaughter. She's very, she's 6 years. Yeah. But they look nice and they make it more unique also. Okay, this this goes off. And now we come with the other one called changing, है ना? ये वाला है, इसको कर देते हैं। हाँ, ठीक है। इसके ये कुछ फिगर से मैं बोलना चाहूँगा।
I request everyone to please take their seats as we are going to start our next session. Our next speaker is Dr. Naresh Gupta, Chairperson Hemophilia and Health Collective of North. He will be speaking on the topic prophylactic management of adult hemophilia A and B, benefits and challenges. I request everyone to please take their seats as Dr. Naresh Gupta will start his session. Thank you so much.
Good evening, welcome back. So I will start with this topic that has been given to me, prophylactic management of adult hemophilia. जैसा कि आपने पहले ही मेरे को सुन भी लिया होगा, I do not like the term prophylaxis for hemophilia. Prophylaxis, primary prophylaxis, when we say, we mean primary prophylaxis against measles, polio, hepatitis, cholera, smallpox, you know, those kind of vaccines that we use, that is primary prophylaxis. And then there is, of course, different subtypes of prophylaxis, but then in hemophilia, the treatment we are giving is similar to the treatment we give in many other diseases where proteins are deficient. For example, diabetes, that is the commonest, such a common disease. India is going to be the diabetic capital of the world. Usko jo hum insulin dete hain, we don't say we are giving it prophylactic. We say we are giving it a replacement therapy. Prophylaxis is not replacing something. Prophylaxis you are giving to somebody who is complete in themselves, but you want to prevent them from catching something, infection or something. Virus है, HPV का vaccine है. It's not that they have a HPV infection, we are treating it. It is they don't have it, we don't want them to have it. So hemophilia में जो protein deficiency है clotting factor 8 की, if we are going to replace it, we should call it replacement. This I have taken upon myself right from our training days also in AIMS, and more so when the matter was getting into the stage of the Honorable High Court. क्योंकि वहाँ जो डिस्कशन हो रहा था उससे ऐसे लगता था कि प्रोफाइलेक्सिस है. Now let me also tell you, when we speak of prophylaxis, vaccines are the greatest prophylaxis that we have ever seen. Many of you would have taken the hepatitis B vaccine, which I find is a very strong, very potent vaccine, which all hemophilia federation HFI persons should take. Must take, I would say. हमारा तो यूनिट में, मेडिकल यूनिट में, any resident, any intern, any student, any nurse, any paramedic, anybody who is working in the ward or OPD clinic would not be allowed to enter if they have not taken this vaccine, hepatitis vaccine. It's so good. But when I wanted this, it was not available. It was not given. हम नहीं देते हैं, vaccine नहीं देते हैं. So we had to actually start it from the Hemophilia Center HDCC, वहाँ से बना के देते थे, अब तो सब जगह मिलती है. There is a vaccine which is very effective for elderly called the influenza vaccine. Some of you are not in service, some of you are in government service. I have senior retired government officers, very senior level. After retirement they come and say we are not giving us the influenza vaccine. We would be willing to treat them into ICU and provide free care for that, but will not give the vaccine. Now the reason why I'm bringing all this discussion is, so when the court this case was going on and the term prophylaxis, which is used by the WFA, came up, they thought this vaccine is not something we need to give, because vaccine is something that we need to give to healthy persons, और उसके लिए इतना पैसा क्यों खर्च करें? One of the reasons why the availability of these medicines got delayed. The medicines were for regular replacement therapy. But the term prophylaxis hangs on, sticks on, and I just have it only to highlight that this is a term we see so frequently, and usually I cut it and write RRT, regular replacement therapy, because it is a secondary treatment that we are giving. Okay? Why do we need to give regular replacement therapy? Now with this introduction that I have given you,
it becomes very clear that in diabetes mellitus, we don't let them come to the emergency कि वो कीटोएसिडोसिस में आ जाएगा, हाइपरग्लाइसीमिया में आ जाएगा, तब हम इंसुलिन देंगे, है ना? It will be wrong. By the same logic, and that logic came up when Benting and Best came up with insulin in 1918. 100 साल से ज़्यादा हो गए इस बात को, तो इसको हमें समझने में देर नहीं लगानी चाहिए कि हीमोफीलिया को जो हम दे रहे हैं रेगुलर रिप्लेसमेंट थेरेपी दे रहे हैं ट्रीटमेंट के हिसाब से, so that nobody who is not a medical person or is suffering from a disease takes it that vaccine kind of a thing is being asked for by this hemophilia fraternity, and it might be costing too much. So regular treatment we are giving, regular replacement. Now how much do we need? Why prophylaxis? Because this is the right way. And how will you give it? Regular replacement prophylaxis has got a very basic science behind it. If you are giving an injection, repeat that injection 3 times the half-life. Insulin first कर लीजिए कि जो रेगुलर इंसुलिन होता है वो रेगुलर इंसुलिन इज 4 आवर्स, तो आप 4 घंटे में नहीं तो 6 घंटे 8 घंटे में उसको बराबर देते हैं. इफ द पेशेंट इज टू सिक यू गिव इट एवरी 4 आवरली. If the patient is not too sick, you give it every 8 hourly. But आज तो आप तो देखते हैं कि आजकल तो लॉन्ग एक्टिंग इंसुलिन आ गई है, लेंटे इंसुलिन आ गई है. लॉन्ग एक्टिंग इंसुलिन you can give once in a day. Now there are long acting insulins you can give in fewer shots also. Same is a story that I am going to just walk you through in few minutes in hemophilia. So we had this clotting factor protein deficiency, factor 8 deficiency and factor 9 deficiency for hemophilia B. If the half-life of factor 8 is 8 hours, तो हमें हर 18-16 घंटे में तो लगा देनी चाहिए. But because we are giving it in crisis, remember the diabetic ketoacidosis crisis? So on demand जो दी जाती थी उसमें we give it twice in a day for hemophilia A, clotting factor 8. And for B, which has a longer half-life of about 16-18 hours, we give it once in 24 hours. The total dose in 24 hours for both remains the same. So the question also would come up, since we are talking about this is one disease where we hold a massive congress on disease alone. There are very few, usually they are on the subject of cardiology, neurology, medicine, but this is probably one of those few which is a huge congress that's going to start tomorrow, day after. तो उसमें कितना केस है जिसको कि हमारे देश में इनकी ज़रूरत है. तो अभी डॉक्टर पारुल ने एक स्लाइड दिखाई थी, वो कितना प्रोफाइलेक्सिस मिल रहा है, 9% मिल रहा है. How do we know? We have very poor data. I actually was privy to the data of this HFI which was given to me on the direction of the Chief Justice. And I can understand जब शुरू का डेटा होता है ना वो इतना स्ट्रॉन्ग नहीं होता है. अभी भी आपको मैं दूंगा, ये जो स्लाइड है, ये जो एनुअल ग्लोबल सर्वे है, ये उसकी स्लाइड है. वर्ल्ड फेडरेशन कहता है कि हमें सब कंट्रीज से हमें डेटा चाहिए. 2019 में ये इन्होंने शुरू करा था. And this slide pertains to 2019. 115 countries responded to it, and they thought there were 157,000, 1.5 लाख हीमोफीलिया ए के मरीज थे और 32,000 हीमोफीलिया बी के मरीज थे. जो 2024 का डेटा था उसको कंपाइल करके रिपोर्ट बनाने में 8-10 महीने लगते हैं, साल भी लग जाता है. तो आई थिंक अभी अक्टूबर 2025 में वो रिलीज हुआ है. उसके हिसाब से 2025 में जो आया है, ये जो नंबर है एक 57 जमा 32, so it becomes 189. 189,000, 1,89,000. It has gone up to 2,71,000. ये ग्लोबल डेटा है. तो 2019 से, जो कि ज़्यादा समय नहीं है, 5-6 साल में, we have actually already made a jump of about 40%. इनमें हीमोफीलिया जो है आज की तारीख में, वो ये जो 150,000 है, उसकी जगह 224,000 है, 224,000 है. That means it is almost a 50% jump. It is not that they are increasing in number, they don't increase in number, it's only that we are becoming better in diagnostics and communicating on the numbers. But 224,000 हैं, ये सिर्फ हीमोफीलिया ए के हैं. उसमें अगर आप जोड़ेंगे 45,000 बी के, तो it will come to 270,000. So this is 150 plus 32, this is 225 plus 45. उसके अलावा कुछ केस ऐसे होते हैं जिसमें हम ये लिखते हैं अननोन टाइप, वो ए है या बी है ये नहीं पता है. ये पहले भी था, ये अभी भी है. और आज की तारीख में जो 2024 का है, उससे पहले जो रिपोर्ट आई थी उसमें 6,000 पेशेंट्स ऐसे थे जिसका कि टाइपिंग नहीं हो पता था. जो भी कारण रहा हो, इस बार जो है 1,700 रह गए हैं. मतलब वी आर बिकमिंग बेटर एट डायग्नोसिस. So if we are becoming better at diagnosis, we should be getting better at treatment also. इंडिया में कितने नंबर है? तो आपको मैं लेटेस्ट दे देता हूँ, क्योंकि इसके पहले जो इंडिया के नंबर आते थे, वो कुछ और थे. 27,687, 27,687. So let's say 27,500 केसेस जो हैं हमारे यहाँ हीमोफीलिया के हैं, out of 271, which is about 10%. So 10% of the world cases of hemophilia are getting reported from India, and our population I think is only about 8%. So we are not that bad. If you look at the overall, we are probably more than what we should be doing. 8% ka 10% we are reporting. The incidence of hemophilia is same globally. What is interesting is, in this October 25, the 24 का जो report है, इंडिया से जो inhibitor के cases हैं, they are only 669 in hemophilia A and 27 in B, which means ये 27,000 में से हमारे यहाँ 700 केस ए और बी मिला के इनहिबिटर के रिपोर्ट में, which means the diagnostics for inhibitor is lacking. And if diagnostics for inhibitor is lacking, whatever treatment you will give may not remain effective for a given patient. So usually when we had done our own cases, we had 3,600 cases, and now we have about 4,000 cases in MAMC and Loknaik Hospital. We had 8% inhibitors. So if 27,000 का आप 8% भी लगाएंगे, तो उसमें 2,000 केस के करीब आते हैं, 700 उसमें से डायग्नोज हैं. So these are all very interesting figures, and I think Prem Roop is always interested. He had asked me to speak last time on von Willebrand disease, which is a sister disease of hemophilia. Von Willebrand disease के जो केस हैं, hemophilia I told you is 27,500, right? Von Willebrand disease के केस जो हमारे यहाँ से अभी रिपोर्ट हुए हैं वो 1,000 है, जबकि they should be running into lakh. So the disease which troubles the ladies more, the girls more, we are practically not diagnosing. It's not, by the way, it's not true of India alone, it is true of the rest of the world also. It should be maybe multi-fold of hemophilia, maybe 100-folds, but that is not the case. Okay? So I think these figures I had just kept there only for this interest. Why do we need treatment, and why do we need prophylaxis? We need treatment because the bleeding occurs in the joints and muscles. So 80% is joints and 15% is muscles. 5% of the bleeding occurs in deadly areas. It can bleed into the brain, the patient could die. They could bleed into the chest and they would die. it could bleed into the retroperitoneum, they would remain incapacitated into ICU. So there are intra-abdominal, it can happen. In fact, we had a patient young man who was waiting for his turn at the ATM machine, and he was just waving it because it was hot day, and he touched his eyelashes, and that small hit with that ATM card made his eye go red. When he came to us, urgently he came, it was all red. He has developed what is called hyphema. Hyphema is not often recorded when we looked into the literature is as a hemophilia. So hemophilia, 5% cases are deadly. Now those are, you would also recall that those 5% cases that are deadly are actually not related to trauma. Joints are 80% because after the baby is born, starts crawling, starts climbing up, starts walking, starts playing, playing cricket, cycling, going to school, keeps falling. All the joints that can get injured lead to bleeding, because the bleeding in hemophilia can be traumatic or can be spontaneous. So trauma would depend on how much trauma they incur. So during childhood they incur a lot of traumas, and naturally if you crawl, the knees are the ones that are going to go. If you are playing, if you are working, it is the wrist and the elbows that will go, and ankles also get into this. So 4 of these major joints, especially, and hip also. So 4 or 5 joints, set of joints, are the ones that get troubled because of the incessant recurrent traumas that occur. लेकिन जो 5% केस हैं जो deadly हैं, उसमें head trauma could be there in injuries, accidents, but usually it occurs in the babies, the intracranial bleed, no injuries. Kippeletoma can be, you apply forceps. So the serious ones are the bleeds that are occurring spontaneously. What does it tell us? The traumatic bleeds would tend to become less as the age progresses in adults. They would be careful, they'll not. But the spontaneous bleed that was occurring even the day the child was born is something that is telling us that these persons are more prone to risky spontaneous bleeds. And that's why a child who is born and is having intracranial bleed is always put on regular replacement therapy, because he runs that risk. His body is made like that, his hemophilia is made like that, that he runs the risk of having a spontaneous bleed into serious areas. It's not that they will always occur, but this literature also says once intracranial bleed, there is a high risk of recurring intracranial bleed. So दो treatment हो गया, अभी तक हम regular replacement on demand करते थे. Now we are saying why we need it. So this is one of the reasons. The other reason is the bleeding in hemophilia that occurs in the joints and muscles is not very good. Blood is actually nectar. Amrit hai. Abe hayat. So long as it is circulating, so long as it is providing oxygen, taking away carbon dioxide, giving you glucose, anything. The moment it stops circulating, it becomes a poison. Bacteria, वो जो क्या blood bath अगर पे तो bacteria grow करते हैं ना, it becomes a poison. Now this spontaneous or traumatic bleeding that occurs in hemophilia in joints has been studied, and it is found to be very different from the bleeding that you see in trauma. You play soccer, it is different from what you see in rheumatoid arthritis, it is different from all other diseases. Everything has been studied there. One thing that has turned out is this blood starts a proliferative process in the joint. Joint में तो synovium है, so synovium hyperproliferate हो जाएगा, मोटा हो जाएगा, boggy हो जाएगा. So if you look at the joint, it will look boggy, and it will look boggy like the bogginess that also comes from the fluid in the joints. But when you see it on ultrasound or clinically also, it is thickening of the synovium because of that reaction that is set in. We call it hemophilic arthropathy. The same thing can occur into the muscles and other areas where this will proliferate and create a big tumor. It can be a tumor which can be half kg, 10 grams, 2 grams, 20 kgs, 30 kgs, 40 kgs, 50 kgs. We had a tall man coming who had a 40 kg tumor in his thigh. That tumor was so big that it compressed his femur and femur became like a pencil, and I used to worry every day, you know, your femur is going to break like that, but then the tumor was probably supporting it. We had to do his surgery later on. So the reason why I am telling you all these things is this pathology sets in the moment there is a bleed. The bleed would stop whether you give treatment or not, but the damage that it has initiated goes on day after day, weeks after weeks, and that is very destructive. It's not that one time bleed that will become all right and you would regain, because the nature, God has made a system that any bleed, whatever damages are there will be resolved. So it's not like that. Now these were the reasons why I say the treatment must be given in the golden hour when they come with a bleed. And better than that is they should not be allowed to reach that stage. That means you give regular replacement therapy. So regular replacement therapy, God forbid if they have a bleed, you give in the golden hour. And these were the instances, these were the studies, these were the signs that we studied when we started Hemophilia Center in 2007-8, that made us think on the lines of one country, one treatment. The boy who is coming from Nagaland does not need to keep suffering from the after effects of the bleeding occurring in Nagaland and coming to Delhi and going back. So these were the basic things, but that is the reason why we need it. So joint bleed, synovial inflammation, it is not only inflammation, I should be writing here inflammation and cellular proliferation. Recurring joint bleeds, so just like intracranial bleed tends to recur, this will also recur, be it the risk of trauma, minor trauma or spontaneous. And from there build up of breakdown products, there are very many things, there is ferritin including hypertrophy and synovial. The cartilage gets damaged, and that's the reason why they need a joint replacement. So if you don't give them regular replacement therapy, they are likely to need a much more much bigger surgeries of joint replacement, which much bigger requirement of the dosages. So you are actually saving on those costs if you give them regular replacement therapy. Now these are few of the slides that show the healthy joint. You can see the bones are there. This is the knee joint and everything looks good, but when you see it here there is it is getting uneven, it is getting stage 2 uneven, stage 3 it gets more destructive, and here it is deformed, and here you can see this is articular cartilages are practically absent. So there is a cushion cartilage, जैसे वो shock absorber होते हैं ना, so those cartilages have been eaten up. There is another interesting thing that I want you to note. So we all know it. You have known so much. What I am talking about doesn't need to be repeated. Regular replacement therapy in hemophilia management. There was this study that's very interesting study. The title that we have given could have come out from wherever. The US joint outcome study confirms that the potential long-term damage caused by a single or a subclinical bleed, right? But what it says is, which bleed is going to cause a long-term damage, we still don't know. If you read the next two lines, where it says clinically evident index joint hemorrhages did not predict the MRI findings in young patients at the age of 6 years. Even a single bleed, including a subclinical bleed, can lead to a long-term damage. So apart from the parameters that I have told you, it is also that one bleed, you don't know which bleed, could be more damaging than the rest. Another reason why we need regular treatment. So now we have actually sorted out whether it's a regular replacement treatment that is the right thing to do, or it is the on-demand. Regular replacement also would have some breakthrough bleeds. Then you need on-demand there. That is called an emergency treatment. On-demand is like the pacemaker which works on demand. They have taken this word from there. So this is what we are talking about. If you give a if you give a factor infusion, episodically it goes up and it remains up and it comes down within a day. It starts coming down within hours, and then it remains like that until the person comes again for the on-demand treatment and it goes up. Whereas if you are giving regular replacement therapy, before it touches the baseline, you have given the second shot, it goes up again, and then so there is a level which it achieves at the top, peak level, and there is a trough level. So if we can create a trough level by giving regular replacement therapy, which is in the interest of the patient, then we'll be happy. What is in the interest of the patient? We know as a general rule that severe hemophilics who are 60%, they bleed more. Mild hemophilics bleed less. Moderate bleed in between. But individual case, anybody can. So generally it is like that. So it came to common sense, as we heard in the morning also, Dr. Rucha was mentioning. If you can make this severe by giving regular replacement therapy, that they achieve a trough level, base level of 3%. Then we know they are moderate. If you can make it above 5, then we know that it is mild. So then we'll be happy. And that has thrived with the medical fraternity for 3 decades. That you make them mild or moderate and everything will be happy. 2 things happened. By the way, when we speak of hemophilia, out of all 100 hemophilias, 85 are hemophilia A, that means factor VIII deficiency. 15 are hemophilia B, that is 9. So when we say we are largely concentrating on hemophilia A, we are not specifying it. So when you have these hemophilics and you are treating them on a regular replacement therapy, then the baseline, if you take it about 3 or 5, you should be happy. But the real world experience showed it is not the case. For 2 reasons. One, it is difficult to achieve more than 5, 6 or 8% level, on a regular basis. There are reasons, because factor VIII, which is hemophilia A, has got a very good friendship with phenolubrine factor. These two always stay together. They are good friends, thick friends from school days. If factor VIII is low, VWF factor also goes down. It does not survive in the blood. If VWF is low, as in the case of a phenolubrine disease, then factor VIII goes down. So which one is going down from, you will not understand, but we know that it is a VWF that is regulating these levels. So there are 2 reasons. One is you can't take it too much, and the second reason is when you raise the level, we found that the bleeding does not become 0 at whatever level you do it. And I think it is the same thing we spoke in the beginning. If you have a moderate hemophilia, sometimes they could be bleeding more than the severe hemophilia. So the factor level is a general determinant, but it is not very specific determinant for the risk of bleeding. And that's why all the clotting factor replacement therapies did not bring in very good results, right? The clotting factor replacement therapies started from, let us go further now. Oh, what happened? Where am I? Okay, so the clotting factor replacement therapies started with plasma derived, because the factors were in 1980s. We could do this sequencing also, but until that time we used to purify this as a blood product, which is done by the industry, not in blood banks, and they were given these factors. And then we realized that the treatment is more complex, regular replacement therapy, than we thought. It is dependent on the age and weight. Age and weight and obesity. Because obesity is all fat. will not go into these details. Bleeding frequency. So those who are bleeding more should get more regular replacement therapy. They'll benefit more. If somebody is bleeding only once in a year, they may not like to take it also. Why would they not like to take it? Because if you are giving intravenous injection, they won't want 100, 150 injections in 1 year. And from our big data, we found that the average ABR, annual bleeding rate, in hemophilia is 11. That means they practically bleed once in a month. We had some patients who would bleed once in a week, more than 50 times in a year. Joint status, has it become damaged? If it becomes damaged, it is more prone to get repeated bleed. What we said, it can give rise to target joints. And it affects the adherence and the patient access and activities and whatever goals he might have. So the treatment was there, but we knew that it is not perfect. But that was not enough. Good things come with their own bad impacts. Nature is not that kind. Two things it led to more. One is the blood products were carrying some viruses. And the three major viruses that have created havoc, not only in hemophilia but on the mankind, are hepatitis B, viral hepatitis B, viral hepatitis C, and HIV. Right? B and C of hepatitis we have known for a long time. HIV we came to know in 1980s. 1980s. It started from the US, and US was actually brushing it under the carpet. They said, so the hemophilia fraternity got up and they said, we've been taking all these blood products. Why are we getting it? They said, no, it does not occur. In fact, HIV was not known as HIV. You know what was it known as? GRID. G-R-I-D. Gay-related immunodeficiency syndrome. So it was, this is your own doing, we will not get into this. It is not only in US, but in Scandinavia, 2 countries in particular, that got, this, they brought this into the main limelight, and it was accepted that all the hemophilics who were getting it had got it from the blood, and so also the rest of the population also, because the blood never was screened for HIV because we didn't know about HIV. So the HIV story was unfurled by the hemophilia fraternity. They forget it. They forget it because they have suffered it. And actually those who suffered it, they have died also. They are not the countries of Europe and US are repenting it, in the sense they are always sorry for this, because they know that something has gone wrong. Likewise, the hepatitis B and C have also been not dying away in the developed world. So we had these issues, and that's why I always say this hepatitis B is such a good vaccine, one should take it. How much of it is affecting the hemophilia fraternity? This was a big problem when we started in 2007-8. So we thought, let us do this study. So we had done a study where we took these hemophilias and we said whatever factor you could have taken or whatever injections you could have taken, whatever sometimes transfusions also were given because anemia is a concomitant thing. You just give us that history. So we did a research on that. Out of 100 cases, we found 1 B, 1 HIV out of 100, and 8 C, hepatitis C, because the C diagnostics was not that strong. So that is also improving. So by then, the risk of hepatitis B and HIV was coming down, right? So that was the other problem with the regular replacement therapy with the initial factors, which are blood derived factors. The third problem that they had was clotting factor is a protein, and you infuse protein into the human body. Body says it is not myself. Self non-self theory of Barnett McFarlane. that they recognize what is self, what is not self. If it is not self, they create antibodies. If a virus gets into the body, bacteria gets into the body, cancer gets into the body, they say, no, this is not my self. They create an antibody and they to kill that. So they didn't know that the factor that was being infused, where it is coming from, whether it is good or it is bad. They don't care. It is not me, it is not me. So not considering as a self, they created antibodies against it. The antibodies, we didn't know how much were they. But what would happen is, sometimes the antibodies that occur, when you give the next infusion, they will go and attack them as if they are enemies. So the next dose became ineffective. When the next dose became ineffective, we call them inhibiting antibodies, because they are inhibiting the next dose. There are many that are not inhibiting. They are lying in, low raging war. You stay on, we stay on, no problem. So these inhibiting antibodies were seen in nearly a third of the hemophilia A patients who were receiving treatment. Okay. So regular replacement therapy became a problem. And that led to the development of more products. What did it cause? It came up with recombinant treatments. No risk of hepatitis B, C, HIV. And you could create any amount of product that you need by recombinant technology. But then it still had to be infused every 100 days in a year or 150 days. Then came up these long-acting factors. We call them extended half-life factors. So the older ones were standard half-life, and these ones were extended half-life. So they came up. But neither one of them could give us very good results in hemophilia A. The extended half-life factor in B, hemophilia B, where the deficiency is factor 9. Now factor 9 does not have a friend like factor 8. So factor 9, you could raise it to 96 hours because there is no friend to bring it down. But in factor 8, it was more limited. So with all this, the non-factor therapies came in, and you heard quite a bit about it. And here we have this slide which says the low dose, intermediate dose, and full dose. So the dark blue is a comparator where you don't give anything, and this light blue is where you give full dose. It comes down to 1.2 bleed. Intermediate dose, it comes down to 2.8 and 2.9. These are two different studies. Okay. So I think you can see, you can take whichever one you like. I have told you the whole story, whether 1.2 and 2.8 is acceptable or not. We have already talked about these recommendations. There are these WFH is a opinion guideline that they have come out with, but we have come out with our own guidelines. Where is it? We have come out with our own guidelines. These are all the products that came in, and those guidelines we have publicized, given in print. They are available on our website. We have distributed, and they, as I was telling you in the morning session, I showed you those guidelines. They are very good, and the ultimate aim of treatment, regular replacement treatment in hemophilia, is not to remain at the baseline of survival, which is saying that prevent premature death, but to take them to normal hemostasis and normal life. If you treat them well, they lead such normal lives, the stories that you have seen and heard, that it is remarkable. And I think we should strive to give the similar life to majority, if not all, the hemophilia fraternity. I will stop here. If there are any comments, queries, I would be happy to take it, but I have been told that I have overshot my time, which I am used to, unless I hear some noise. Thank you. देते मेरे को, जल्दी बता दे, खत्म करना है.
Thank you so much, sir, for your wonderful session. Now, I would like to request our Vice President Development, Mr. KVS Prasad, sir, to please come on stage and present the memento to the representative of Sanofi, Mr. Nakul Verma. I request you to please come on stage and receive the memento. Our next speaker is Dr. Varun Vafna, Consultant Hematologist, Government of Maharashtra. He will be speaking on the topic From Bleeds to Prevention, Therapies and the Many Possibilities in Real-World Hemophilia Care.
लैपटॉप भी आई है. कॉल करो, कॉल करो.
Good evening to all. First of all, I really thankful for HFI and Prem sir for inviting me here. And it's again a wonderful evening. सब लोगों से मुलाकात वापस हुई है काफ़ी समय बाद. और आज कुछ टॉपिक डिस्कशन थोड़ा सा मेरा टॉपिक काफ़ी हल्का कर दिया गुप्ता सर ने अभी. तो आई थिंक थोड़ा सा मैं आगे वाले डिस्कशंस पे ज़्यादा पॉइंट करूँगा. मैं डॉक्टर वरुण बाफना कोल्हापुर महाराष्ट्र से हूँ. बेसिकली अभी यहाँ पे PWH हमारे पास ऑलमोस्ट क्लोज टू 550 प्लस पेशेंट्स रजिस्टर हो चुके हैं. उसमें ए बी और वॉन विले ब्रांड इनिबिटर्स का जो पॉजिटिव है, जो सर ने बोला 8%, हमारे पास 6% का डेटा है यूजुअली इनिबिटर्स का. और वी हैव अ कंप्रेहेंसिव डायग्नोस्टिक एंड ऑल द सेंटर विच इज़ अवेलेबल देयर. द इम्पॉर्टेंट हियर वाई इट इज़ कि लास्ट एक साल में हमने 32 न्यूली डायग्नोस्ड पेशेंट्स किए हैं. तो दैट इज़ अ इम्पॉर्टेंट थिंग कि जैसा मैडम जब बोल रहे थे कि पेशेंट्स कम है और बजट ज़्यादा लग रहा है, वो सब जगह का प्रॉब्लम है. तो हम सोचे कि लेट्स ड्राइव इट एंड आइडेंटिफाई मोर पेशेंट्स, क्योंकि पेशेंट्स है, पेशेंट्स बहुत है, लेकिन अपन पेशेंट्स तक पहुंच नहीं पा रहे, डायग्नोस नहीं कर पा रहे. टुडेज मेरा टॉपिक है फ्रॉम ब्लीड्स टू प्रिवेंशन, थेरेपीज एंड मेनी पॉसिबिलिटीज इन द रियल वर्ल्ड ऑफ हीमोफीलिया केयर. लेट्स बिगिन विद द हिस्ट्री. 2nd सेंचुरी में पहली बार जीवेश ने इसको टालमुड बोल के बीमारी बोली गई थी. इसको काफ़ी सेंचुरीज तक टालमुड बोल के चल रहा था. बेसिकली इट इज कॉल्ड एज एन रॉयल्स डिजीज. सभी को पता है रॉयल्स डिजीज. रॉयल्स डिजीज क्यों बोलते हैं इसको? क्वीन विक्टोरिया की फैमिली से वो इनहेरिटेड हो रहा है जब से. तो ये बहुत इंपॉर्टेंट था कि उस फैमिली में पहले कैसे हुए, पहले 2 फीमेल चाइल्ड थे, कुछ नहीं हुआ. मेल चाइल्ड हुआ, वो लोगों में सर्कमसिशन करते हैं, खतना कर बोलते हैं ना अपन, खतना करना. तो वो करने के बाद वो ब्लीडिंग रुक नहीं रहा था, दे एक्सपायर्ड. 2nd चाइल्ड हुआ, मेल चाइल्ड हुआ, उसका भी खतना किए, वो भी एक्सपायर हो गया. फिर इन्होंने सोचा कि कुछ तो इनको ब्लीडिंग का प्रॉब्लम है. तीसरे मेल चाइल्ड में उन्होंने खतना नहीं किया, सर्कमसिशन नहीं किया, तब वो चाइल्ड आराम से अच्छी तरह रहा. तब समझ में आया ये बीमारी कुछ रिलेटेड टू ब्लड डिसऑर्डर, जहां क्लॉट नहीं होता है ब्लड. काफी टाइम तक इसको बाद में हीमोफीलिया बोला गया था. फिर 1950s के बाद इसको हीमोफीलिया बोल के डिजीज डायग्नोस हुआ. हीमोफीलिया अपन दोपहर से देख रहे हैं, एक जेनेटिक बीमारी है जो अपन एक पूरे फैमिलीज जनरेशन से जनरेशन चलता है. इसमें जैसा बताया गया क्लॉटिंग फैक्टर्स जो बेसिकली है वो कम रहते हैं, डेफिशिएंट रहते हैं. इसके कारण क्या होता है, खून रुकता नहीं है. इसके कारण ये हीमोफीलिया और नॉर्मल में ये डिफरेंशिएट दिखाया गया. इट इज़ अ एक्स लिंक डिजीज. मेल पैटर्न में ज़्यादा देखने मिलता है, लेकिन फीमेल्स में भी काफ़ी देखने मिलता है. हमारे पास हीमोफीलिया के अराउंड 30 पेशेंट हीमोफीलिक फीमेल्स भी रजिस्टर्ड है. तो यू हैव टू आइडेंटिफाई देम. द ग्लोबल डिस्कशन जो सर ने बताया था, सर्वे में थोड़ा सा चेंजेस. अभी 2023 का जो सर्वे है, टोटल पेशेंट्स अराउंड 4,65,000 के आसपास है. उसमें से हीमोफीलिया ए, बी और अननोन जो बोला गया है 2,73,000 है. वॉन विले ब्रांड और अदर ब्लीडिंग डिसऑर्डर्स आर डिफरेंट. टोटल इंडिया में पेशेंट्स रजिस्टर्ड या डायग्नोस्ड जो मालूमात है दैट इज अराउंड 26,352. हीमोफीलिया ए, बी का डिस्ट्रीब्यूशन दिया है. वर्ल्ड का 10% ऑफ द पॉपुलेशन हीमोफीलिया का इंडिया में. बट ये सही लग रहा है आपको? एक्सपेक्टेड नंबर ऑफ पीडब्ल्यूएच इंडिया में इज क्लोज टू 1.23 lakhs. ये रिसेंट डेटा पब्लिश हुआ है. 1.25 लाख पेशेंट हीमोफीलिक्स या ब्लीडिंग डिसऑर्डर के रहेंगे जो पिकअप नहीं हो पा रहे हैं. इसके लिए जो इस बार का थीम है वर्ल्ड हीमोफीलिया डे का 17 अप्रैल को जो थीम है, डायग्नोसिस द फर्स्ट स्टेप्स टुवर्ड्स केयर. अपने को डायग्नोसिस वी हैव टू इंप्रूव, वी हैव टू इंक्रीज द डायग्नोसिस, वी हैव टू वर्क हार्ड. पॉइंट ऑफ केयर टेस्टिंग अभी डेवलप हो गया, ICMR ने डेवलप किया, लेकिन हिस्ट्री पे इफ यू आइडेंटिफाई टर्शियरी सेंटर नियर बाय हॉस्पिटल्स में वो लोग रेफर करके उनका वर्कअप कर सकते हैं. इफ यू इंप्रूव द डायग्नोसिस डेफिनेटली, इफ यू क्लोज टू जो दिख रहा है पिछले 5 साल में जो इंप्रूवमेंट हुआ, पहले 2019 का सर्वे में अराउंड 18-19,000 था, उसके बाद 26,000 हो रहा है. वो आराम से क्रॉस होके 50,000 1 लाख तक भी जाएगा इफ यू इंप्रूव द डायग्नोसिस. लेट्स बिगिन विद द स्टोरी. यहाँ पे काफ़ी PWH भी है, किसी के बच्चे भी हैं, और कोई सोसाइटी में जो काम कर रहा है, तो एवरीबडी नोज दैट हर एक की स्टोरी एक अलग अलग होती है. एक 15 साल का बच्चा आया था, रिकरेंट जॉइंट ब्लीड है, फैक्टर लेता है जब ब्लीडिंग होता है. मुझे पूछता है सर मैं ये कब रुका पाऊंगा, मेरा करियर क्या है. 25 साल का आ रहा है, राइट नी जॉइंट पे रिकरेंट बीट हो गया, ब्लीड हो गया, टारगेट जॉइंट हो गया, चलना बहुत मुश्किल हो गया, नहीं चल पा रहा है, मैं इसमें से बाहर निकल पाऊंगा क्या. दिस इज द एवरीडे स्टोरी व्हाट एवरीबडी इज अवेयर. एक पेरेंट बोल रहा है 6 साल का है, हॉस्पिटल जाने को बच्चा बहुत डर रहा है क्योंकि वो प्रिक लेने को अलाउड नहीं करता है, मेरे को अभी IV देने के लिए नहीं बोलता है. क्या कर सकते हैं अभी इस पेशेंट, क्योंकि ये तो बीमारी है, अभी इसमें से तो बाहर निकलना भी है अपने को। सबका यही प्रॉब्लम है कि मेरा बच्चे का या मेरा फ्यूचर क्या है इसमें, व्हाट इज द फ्यूचर, क्या ये बच्चे प्रोफेशनल कभी हो सकते हैं, कैन दे डू द गुड इन देयर लाइफ। आज इंडिया में वी डोंट हैव एथलीट्स ऑफ हीमोफीलिया एनीबडी, बट स्टिल दे कैन बिकम, हाउ वी कैन डू दैट। डिजीज बर्डन जैसा बताया गया, कुछ बच्चों के देयर इज अ जॉइंट स्वेलिंग, जैसे सर ने बताया बॉगी स्वेलिंग रहता है। डिजीज बर्डन क्या, ब्लीडिंग रेट्स फॉर दोज पेशेंट रिसीविंग ऑन डिमांड जो लेते हैं, यूजुअली ब्लीडिंग उनका ज़्यादा आता है, जॉइंट्स ज़्यादा खराब होते हैं। साइनोवियल जो सर बता रहे थे, जॉइंट फूक जाता है, बॉगी स्वेलिंग होता है, दैट इज दैट थिंग। फैक्टर रिप्लेसमेंट थेरेपी में लीड टू ट्रफ लेवल्स बिटवीन द डोजेस, वो कम हो जाता है, इसलिए सब क्लिनिकल ब्लीड या इंटरमीडिएट ब्लीड काफ़ी ज़्यादा होता है। सब क्लिनिकल ब्लीड भी बहुत लोगों को होता है, विच कैन लीड टू लॉन्ग टर्म जॉइंट डैमेज। जो माइल्ड मॉडरेट पेशेंट रहते हैं ये भी ब्लीड करते हैं, लेकिन हॉस्पिटल तक नहीं पहुंचते, क्योंकि वो थोड़े हल्का हल्का ब्लीड करके काफ़ी 10 साल 15 साल के बाद वो जॉइंट पूरे खराब हो जाते हैं। तो ये पेशेंट्स को काफ़ी टाइम पे वी नीड अ जॉइंट रिप्लेसमेंट दैट टाइम। ये ब्लीडिंग काफ़ी लोग अपने ओपीडी में, काफ़ी अपने आजू बाजू सेंटर में देखते हैं, काफ़ी भयानक ब्लीडिंग आता है, कहीं भी ब्लीडिंग आ सकता है। मसल ब्लीड बहुत कॉमन है, जॉइंट ब्लीड बहुत कॉमन है, ऐसे ब्लीड्स देखने को कॉमनली मिलते हैं अपने को। ब्रेन ब्लीड, स्पाइनल ब्लीड, जब भी ट्रॉमा लेके आए थे रिसेंटली, अपने में से एक डॉक्टर ही है, उनका बैक एक बहुत हो रहा था, एमआरआई पे भी वो ब्लीड इतना पिकअप नहीं हो पाया जल्दी, लेकिन बट भी वो नॉन फैक्टर थेरेपी भी था, हमने उसको ब्रेक थ्रू ब्लीड समझ के फिर भी उसको फैक्टर रिप्लेसमेंट किया, 3 दिन 5 दिन देना पड़ा, उसका बाद उसका पेन उसका कम हुआ। बट ये ब्लीड्स अपने को बहुत जल्दी पिकअप करने पड़ते हैं। जॉइंट देखिए पूरी तरह डैमेज हो चुका है, राइट साइड का देखते हैं, पूरी तरह जॉइंट डैमेज हो रहा है, टारगेट जॉइंट्स बोला जाते हैं। उसका हाथ पूरी तरह, एल्बो जॉइंट्स भी खराब हो रहा है, दे कांट लिफ्ट। ये बच्चे जो रहेंगे, हाउ दे विल राइट, एग्जाम कैसे लिखेंगे, तो दैट बिकम्स अ इशू नाउ फॉर अस। ये कैन वी गो अवे फ्रॉम दिस। ये ब्लीडिंग कहीं भी हो सकता है, मुंह में, हाथ में, मान में। सूडो ट्यूमर का जो डिस्कशन हो रहा था, जो ब्लीड होके उधर गट्टा ब्लीडिंग का तैयार हो जाता है, व्हाट इज द प्रॉब्लम देयर नाउ? द कंसर्न इज उसको अपने को ब्लीडिंग को वो बढ़ने के बाद उधर कुछ ना कुछ कॉम्प्लिकेशंस तैयार करता है, उसको ऑपरेट करके निकालना पड़ता है, तो होने देना नहीं है अपने को। तो फ्रीक्वेंसी ऑफ ब्लीडिंग इन डिफरेंट साइट्स, जैसे बताया गया, सबसे कॉमन क्या है, जॉइंट ब्लीड या मसल ब्लीड है, बट लकीली ब्रेन ब्लीड कम है इंडिया में। 1 to 2% ही ब्रेन ब्लीड मिलता है। जब मिलता है तब उसको अपने को ट्रीटमेंट 100% करके उसको बचाने की पूरी कोशिश करना चाहिए, दैट इज द इंपॉर्टेंट थिंग। जब ये जॉइंट ब्लीडिंग बढ़ते जाता है, यहाँ बहुत सारे लोग बैठे, उनके जॉइंट्स क्रोनिक आर्थराइटिस में कन्वर्ट होते हैं, साइनोवाइटिस बोला जाता है, पूरी तरह जॉइंट ये खराब हो जाता है। यहाँ पे सिर्फ अपने को जॉइंट रिप्लेसमेंट ही करना पड़ता है, दूसरा ऑप्शन ही नहीं है। तो जॉइंट रिप्लेसमेंट का कॉस्ट कितना जाएगा? 40-50 लाख रुपीस के फैक्टर्स लगते हैं, इनिबिटर रहेगा तो क्लोज टू 1 CR जाता है। तो दैट इज अ बिग चैलेंज, हाउ वी कैन अवॉइड दिस ऑल दिस। डिसेबिलिटी इन इंडिया, एक सर्वे किया गया था, ऑलमोस्ट 148 पेशेंट्स में देखा गया था, 9 PWH वेर विदाउट एनी डिसेबिलिटी, बाकी सब में डिसेबिलिटी मिला। 94% पेशेंट्स आर डिसेबल। नंबर ऑफ जॉइंट ब्लीड्स इन अ ईयर वाज मोर देन 6 ब्लीड्स ओवर ईयर, सर्वे में समझा। 75% patients may live only up to 30 years of their life, but there is a hope. Many PWH live normal life in many countries with the right therapy. To begin therapy में सब लोगों को पता है, we give on demand therapy में जो पता है, और एपिसोडिक ट्रीटमेंट पहले बोला जाता था। फैक्टर 8 सवेरे से डिस्कशन चल रहा है, SHL EHL। कितने लोग जानते हैं SHL मतलब क्या है? कितने लोग जानते हैं EHL मतलब क्या है? SHL दिन में 2 बार देना पड़ता है, EHL एक ही बार देना पड़ता है। इट इज एक्सटेंडेड हाफ लाइफ, जो बोला गया था कि दैट विल टेक कवर ऑफ 18 to 24 आवर्स, जो मैडम ने बताया था, पारुल मैडम ने। और स्टैंडर्ड हाफ लाइफ विल कवर ओनली 6 to 8 आवर्स to 10 आवर्स मैक्सिमम, इट डिपेंड्स ऑन द बॉडी टू बॉडी। बट इतने से ब्लीड से क्या क्या प्रॉब्लम हो रहा है, तो ये जो बच्चे थे, हमने इनको शुरू कर दिया कुछ साल पहले स्टैंडर्ड हाफ लाइफ के फैक्टर, जब हमारे पास EHL नहीं थे। हमने उनको बोला अल्टरनेट डे आके आपको लेना है तो आपका फ्यूचर अच्छा हो सकता है, तो वो लोग तैयार हो गए। डॉक्टर जो बोलेगा ऑलमोस्ट सुनेंगे, क्योंकि अपने को ठीक होना है। देयर वॉज अ होप, देयर इज डेवलपमेंट। मैं हमेशा ये बताता हूँ स्लाइड में, आप यहाँ से सब लोग बैठे हैं, ये सब बॉटल में से काफ़ी लोग गए हुए हैं, सब बॉटल नहीं बोल रहा बट काफ़ी बॉटल में से तो सब लोग गए होंगे अपने अपने लाइफ में, सब ने यूज़ किया होगा, बट अपने को वो लास्ट वाली बॉटल तक तो पहुंचना नहीं है पेशेंट्स का. तो दिस वॉज अ डेवलपमेंट ऑफ हीमोफीलिया ट्रीटमेंट इन आवर कंट्री. व्हाट हैज बिगन हियर? द बेसिक वॉज, जब पहले दिया गया था प्लाज्मा, FFP देते थे या क्रायो दिया जाता था. होल ब्लड पहले शुरू हुआ था, उसके बाद प्लाज्मा आया, प्लाज्मा के बाद क्रायो देने लगे, उसके बाद एपिसोडिक स्टैंडर्ड हाफ लाइफ प्लाज्मा डिराइव फैक्टर वेर अवेलेबल. देन वेंट टू द प्रोफिलैक्सिस, half life of recombinant plasma derived, then there came the prophylaxis of extended half life factor. उसके बाद डेवलपमेंट 2020, इसके बाद वी आर सीइंग नॉन फैक्टर थेरेपीज एंड अभी वी आर डिस्कसिंग ऑफ जीन थेरेपीज these days. Are we curing the hemophilia now? That was a concern. पहले we were only treating the bleeds, उसके बाद we were trying to prevent the bleeds, and now we are thinking of curing the bleeds. So these are the development of the science. This is because of the disease. ये science इतना develop हुआ है, इतने नए नए products आए हैं अभी. What is our goal? Basically to do the awareness between all the therapies available for the interior parts of the country. Doctors को, patients को, nurses को. Disability से बाहर होना है, bleeds को रुकाना पड़ेगा, और जो quality of life improve करना है, that is schooling, work and family should not get hampered. जो जॉइंट्स के बारे में सर ने बताया, दैट वाज वेरी इजी. जैसे सर ने बताया, बहुत अच्छा पिक्टोरियल था. इसमें समझ सकते हैं आप, पहला एक ब्लीड होने के बाद कैसा दिखता है, रिकरेंट ब्लीड हो गया तो उधर साइनोवियम का जैसा बॉगी स्वेलिंग आता है, तीसरे बाद पूरा साइनोवियम खराब हो जाता है, और लास्ट तक वो कंप्लीटली देयर इज अ लॉस एंड दैट लीड्स टू आर्थ्रोपैथी. एंड दैट इज अ स्टेज, लास्ट दोनों वाले स्टेज में यू हैव टू रिप्लेस द जॉइंट. इधर प्रोफिलैक्सिस भी रिप्लेस, रेगुलर रिप्लेसमेंट थेरेपी भी बहुत कम टाइम पे हेल्प करता है. These are only first 3 steps जहाँ पे we can revert the joint state, not at the last. This is from one of the patient जो 16 साल का, 15-16 साल का, जो बाद में स्टैंडर्ड हाफ लाइफ ले रहा था. उसका जॉइंट आप देख रहे हो, राइट साइड का पैर का पूरी तरह खराब हो रहा था. बट दिस इज अ राइट टाइम, वी हैव टू टेक हिम ऑन द प्रोफिलैक्सिस विद दैट. दिस इज द यूजुअल क्वालिटी ऑफ लाइफ ऑफ एनी हीमोफिलिक पेशेंट्स. यू कैन सी डाउन द लाइन, आप लोग को 4 पैर चल पे आना पड़ता है काफी लोगों को. यू हैव टू टेक अ सपोर्ट. दिस इज अ वेरी डिफिकल्ट सिचुएशन. तो वेयर वी कैन स्टॉप दिस विद द हेल्प ऑफ प्रोफिलैक्सिस, विद द हेल्प ऑफ रेगुलर रिप्लेसमेंट थेरेपी, इज दैट इज ओके. सो व्हाट इज आवर टारगेट बेसिकली व्हेन यू स्टार्ट द ट्रीटमेंट ऑफ प्रोफिलैक्सिस? एनी सीवियर ट्रीटमेंट हैज टू बी कन्वर्टेड टू द मॉडरेट, माइल्ड, बट नाउ इट हैज टू बी नॉर्मल हीमोस्टेसिस. तो सिर्फ फैक्टर रिप्लेसमेंट से होएगा कि नहीं होगा, वेदर वी हैव टू गो विद द नॉन फैक्टर थेरेपीज, दैट वी हैव टू जस्टिफाई नाउ. रिप्लेसमेंट थेरेपी, एज सर हैज ऑलरेडी डिस्कस्ड, बहुत अच्छी तरह बताया गया. प्रोफिलैक्सिस इज नॉट द वर्ड करेक्ट. जैसे डायबिटीज, थायराइड में कुछ हार्मोन्स कम हो जाते हैं, इसके कारण क्या होता है, अपन बाहर से इंसुलिन देते हैं, बाहर से थायराइड के ड्रग्स लेते हैं. उसी तरह अगर रेगुलरली फैक्टर लिया जाए, क्लॉटिंग फैक्टर्स बाहर से, तो इट विल बी हेल्पिंग यू, तो जिसके कारण वो ब्लीड ही नहीं होगा. तो दिस इज इंपॉर्टेंट ऑफ थिंग टू अंडरस्टैंड. देयर इज अ रेगुलर रिप्लेसमेंट थेरेपी. अगर जॉइंट ब्लीड नहीं होगा तो वो जॉइंट का रिप्लेसमेंट तक जाने की जरूरत नहीं है, तो ओवरऑल द कॉस्ट फॉर द गवर्नमेंट ऑल्सो विल कम डाउन. इट विल हेल्प फॉर फीवर हीमोथ्रोसिस, लेस आर्थ्रोपैथी, फीवर एकदम मसल ब्लीड्स. देयर विल बी डिक्रीज चांसेस ऑफ ब्रेन ब्लीड, हॉस्पिटल एडमिशंस कम हो जाएंगे, लेस फ्रीक्वेंट मॉनिटरिंग एंड लेस joint surgeries. What is the guidelines by WFH says? What is your treatment goal? To prevent and to treat the bleed. Prophylaxis is only the standard of care with the patient with severe hemophilia. Episodic treatment should not be considered as long-term treatment now. Definition of prophylaxis, they have told regular administration. Prophylaxis मतलब सबको समझना है, regularly लेना है. सवेरे से अपना दोपहर से डिस्कशन हो रहा है, काफ़ी अच्छा पैनल डिस्कशन में बताया गया था. रेगुलर लेना है, हफ्ते में 1 बार 2 बार तो लेना ही है, तब जाके वो प्रोफिलैक्सिस के डेफिनेशन में पूरा बैठेगा, जॉइंट्स खराब नहीं होंगे अपने. उसके बाद नए गाइडलाइंस वापस आए, PWH विथ इनिबिटर्स रहेंगे हीमोफीलिया ए के पेशेंट्स में. तो यू हैव अ गुड ड्रग एमिसिजुमैब, जिसको फैक्टर 7 वगैरह देने की जरूरत नहीं. प्रोफिलैक्सिस के हिसाब से एमिसिजुमैब रेगुलरली रखे तो वो प्रिवेंट करेगा ब्लीडिंग के लिए. दैट गाइडलाइंस हैव, एमिसिजुमैब हैज बीन प्रूव्ड इन नॉन इनिबिटर्स आल्सो नाउ. Injection concizumab is available for factor 9 hemophilia B with inhibitors and without inhibitors now. This slide was already discussed. ये बहुत पुरानी स्लाइड है. गुप्ता सर ने करेक्ट बताया कि we have to update this data. Only 9% of hemophilic patients are on prophylaxis from our country. 9%, सिर्फ 9% है. That is a really sad part. If you ask, मेरे सेंटर में अगर आप पूछा जाओगे, मेरे पास almost close to 60 patients prophylaxis पे है अभी 550 में से. तो almost 10 से 12% अपन बोल सकते हैं. लेकिन we need some more patients. That is an important thing so that the joint can be preserved properly. Prophylactic replacement therapy with standard half-life like recommended factor. तो challenges उसमें क्या आ रहे हैं? वो patients मुझे बोल रहे हैं, सर हम लोग हफ्ते में alternate day नहीं आ सकते, मेरी एग्जाम है, पेरेंट्स को कुछ काम आ गया. This is a common problem what everybody is facing. So breakthrough bleeds भी ज़्यादा आ रहे, सब clinical bleed बढ़ रहे, multiple IV excesses हो रहा है. वो बोल दिया मेरे को, छोटा बच्चा जो था 6 साल का, कि मल्टीपल IV एक्सेसेस हो रहे हैं, तो इंट्रावेनस इज अ मल्टीपल टाइम्स पर वीक. आई एम नॉट रेडी. दे आर नॉट रेडी. डिफॉल्टर्स आर मोर कॉमन. दिस इज अ प्रैक्टिकल व्हाट वी फेस. So there are the another drugs. Then we come with the extended half-life factors. We have non-factor replacement therapy and we have curative treatment options. So EHL का what was the guideline said? High trough levels on prophylaxis with 1%, patient can still experience breakthrough bleeds. Beneficial for prophylaxis by decreasing the frequency of injection by providing higher trough levels. जो देखा गया था EHL जो डिस्कस किया था मैडम ने ऑलरेडी एस्पेरॉक, एक दिन इंजेक्शन देने के बाद 6.5 दिन तक उसका ट्रफ लेवल 3 से 5% रहता है. मतलब अपन ने सीवियर से उसको मॉडरेट में कन्वर्ट कर दिया है. इफ यू हैव कन्वर्टेड टू मॉडरेट, द ब्लीडिंग चांसेस विल कम डाउन. सो यू नीड टू गिव द एक्सटेंडेड हाफ लाइफ. लेस फ्रीक्वेंटली है, हफ्ते में एक बार भी दे सकते हैं आप. दैट इज वेरी इजी. फिर वो आना है, उस पेशेंट्स को हमने एक्सटेंडेड हाफ लाइफ पे चालू कर दिया, तीनों पेशेंट्स को हमारे. अब खुश थे वो काफी टाइम तक उनका फैक्टर लेवल जो था एक्सटेंडेड हाफ लाइफ से अबव 1% मेंटेन रहने की कोशिश रह रहा था, बट थोड़ा ब्रेक थ्रू ब्लीडिंग था इन बिटवीन, बट इट वाज इंप्रूविंग. व्हाट वी कैन सी हियर, स्टैंडर्ड हाफ लाइफ फैक्टर बहुत बार देते ही ऊपर बढ़ता है, लेकिन 8 घंटे में वापस नीचे आ जाता है. एक्सटेंडेड हाफ लाइफ काफी समय तक रहता है, बट वो भी बाद में नीचे आ जाता है. तो यू नीड टू गिव इट रेगुलरली. नॉन फैक्टर थेरेपी एक स्टडी मेंटेन कर रहा था. फैक्टर लेवल सर ने बोला फैक्टर नहीं बढ़ा रहा है, वो मिमिक कर रहा है कि ब्लीडिंग होने नहीं दे रहा है. आपका ब्लीडिंग का लास्ट में कोआगुलेशन को थ्रोम्बोस तैयार करने के लिए हेल्प कर रहा है. सो बेनिफिट्स ऑफ EHL व्हाट वी हैव सीन, लेस क्लिनिक विजिट्स, IV वीकली वंस रहेगा, नॉट मोर, एंड लेस कम्बरसम. स्कूल का एब्सेंटिज्म कम हो गया. देन वी आर प्लानिंग टू गो फॉर सैटरडे. हम लोग उनको देना चालू करें. सेकेंड हाफ में स्कूल वूल खत्म करके वो लोग बच्चे आते थे हमारे पास. We started. More effective था prophylaxis. Sports activity वो लोग participate करना शुरू कर दे. It started improving. So what WHO has recommended prophylaxis with EHL clotting factor at sufficient doses and dosing interval to prevent hemarthrosis and spontaneous and breakthrough bleeds to preserve the joint function. So EHL prophylaxis has improved our physiotherapy, better joint score, reverses the target joint as we have discussed already, reduced with no bleeds, reduced hospital visits and was better compliant. मतलब patient regularly ले रहे थे treatments. But sometimes we have experiences bleed, जैसा सब clinical bleed या in between जो tail ending 5वें दिन 6ठे दिन के बाद थोड़े bleed हो रहे थे. मैडम ने जैसे बोला कुछ patient को हमने डोज बढ़ा दिया, कुछ patient को regularly देने लग गए थे. ये डेटा आया UK से भी. On prophylaxis भी थोड़ा थोड़ा bleed हो रहा है. बट माइल्ड पेशेंट का इंटरेस्टिंग क्या है, वी आर नॉट सीइंग दैट पेशेंट्स जो अपने 1,23,000 जो इंडियन पॉपुलेशन में मैं बोल रहा हूँ कि शायद रहेंगे, उसमें से माइल्ड ही रहेंगे ज्यादा. बट दे आर 53% ऑफ द मेल हैविंग 2 to 3 bleeds per year, and that leads to after 10 years the joint damage completely. CBDS registry had told people with hemophilia had 16 times greater arthropathy and 9 times higher arthropathy related to the hospital admissions. So how to identify these patients? सर ने पिछले वाले प्रेजेंटेशन में अच्छा बताया था कि MRI के थ्रू, लेकिन MRI करना कितना फिजिबल है, अपॉइंटमेंट नहीं मिलेगी जल्दी. MRI में कम से कम 20 से 25 मिनट अपने को उसके अंदर मशीन में रहना पड़ता है, तो दैट इज क्लोस्ट्रोफोबिक फॉर द मोस्ट ऑफ द पेशेंट. एंड कॉस्ट इज ऑलवेज अ कंसर्न. गवर्नमेंट में अगर फ्री में करना चाहोगे तब भी अपॉइंटमेंट के डेट्स नहीं मिलेंगे एंड इट इज बर्डन. सो व्हाट वी आर कमिंग अप नाउ, वी थॉट लेट्स डू अ स्टडी. तो वी हैव स्टार्टेड अ स्टडी ऑफ अल्ट्रासाउंड फोकस. किसमें करेंगे अल्ट्रासाउंड जॉइंट्स का? जब ब्लीड नहीं रहेगा, स्वेलिंग नहीं रहेगी. व्हाट वी आर ट्राइंग टू सी, ब्लीड नहीं देख रहे हम उसमें देख रहे साइनोवियम का थिकनेस कितना है. अगर साइनोवियम का थिकनेस बढ़ रहा है तो ये पेशेंट्स ब्लीड ज्यादा करेंगे. ये पेशेंट्स को प्रोफिलैक्सिस में लेना जरूरी है, माइल्ड टू मॉडरेट वाले पेशेंट्स. सो दैट इज आइडेंटिटी कुछ अलग करने को मिला. तो यूएसजी से वी वर ट्राइंग टू फाइंड आउट कि हाउ मेनी वी हैव स्क्रीन. तो दिस डेटा इज येट टू बी पब्लिश्ड फ्रॉम आवर साइड. तो दिस इज वेरी गुड. नाउ वी आर सीइंग विद द फैक्टर्स सब क्लिनिकल ब्लीड्स. किसी का अर्ली पिकअप करना है तो यूएसजी इज द वेट विद द साइनोवियम थिकनिंग. वी कैन से किसी का डोज बढ़ाना है, इंडिविजुअलाइज थेरेपी करना है, वी हैव टू मेक श्योर. अभी तक 100% नहीं बोल सकते, बट स्टिल इट इज हेल्पिंग. इट कैन रिप्लेस MRI, नॉट सेंसिटिविटी वाइज, बट डेफिनेटली इट माइट पिक अप अर्ली. दैट विल हेल्प अस. सो वो पेशेंट को बाद में क्या हो गया, सीवियर हीमोफीलिया है, एडमिटेड फॉर राइट आर्थ्रोसिस. ब्लड कलेक्शन पे उसको आईवी प्रिक पे लेफ्ट क्यूबाइटल वोन पे स्वेलिंग आ गई. अभी उसमें से एक बच्चे को स्टोरी चालू है अपनी. स्वेलिंग आ गई, कंपार्टमेंट सिंड्रोम हो गया, मतलब प्रेशर बहुत आ गया है. प्रेशर आने के बाद उसका मूवमेंट रिस्ट्रिक्शन हो रहा है, उसको ऑपरेट करना पड़ा. और ऑपरेट करने के बाद उसका ये हाथ था और उसके पेरेंट्स बोले मेरे को आईवी नहीं लेना है. अब क्या करेंगे? दिस इज अगेन अ चैलेंज फॉर अस. So we have to go with that thing there. So we have to try to find out. So these are the newer developments in last 2025 to 26 what we have seen. पहले 3 मैंने डिस्कस किया. उसके बाद जो ड्रग्स आ रहे हैं, एंटी थ्रोम्बिन, एंटी TFP है, जिसमें कॉन्सिजुमैब अभी इंडिया में अवेलेबल हो गया है, मार्स्टासिमैब अभी अवेलेबल होगा, फिटोसिरॉन इज अंडरगोइंग, इट विल ऑल्सो कम. Factor 8 mimetic is available since last couple of years with us. That is helping us a lot. Emicizumab. And then last is our gene therapy. So these are the different mechanism. We'll not go in technically detail of it. Every drug works in a different pattern. एक TFPI इनिबिटर से काम कर रहा है जिधर अपना at the end of the goal is only last में fibrinogen to convert fibrin और इधर clot करने के लिए help करना है. Factor 8 is a mimetic. तो ये लोगों को इनिबिटर्स का भी डर नहीं है अभी अपने को, क्योंकि we are bypassing all these things. So that is the beauty of this all newer molecules. Emicizumab, it's a humanized bispecific monoclonal antibody. It restores coagulation by bridging with activated factor 9 and factor 10 to replace the cofactor function of missing activated factor 8. It can be administered subcut, long half-life, weekly once, 2 weekly या 4 weekly भी अपन दे सकते हैं. So this is helping in the protection of the joint. This is their guidelines, weekly 1.5 या bi-weekly 3 या every 4 weekly 6 mg per kg. But the problem is now the cost was more, so ICMR has projected for a low dose. Even we are working on the same thing, but we cannot say it is a guidelines. It's a tailor-made therapy. But bleed ho gaya to you have to be very cautious with this drug. Okay, I'll take 5 minutes more. Concomitant therapies. इसके साथ जब when we were on the emicizumab of the low dose, 62% of the patient में we didn't require any bleed, didn't happen. और factor 8 लगा 25% of patient में. That was only because of most of them were traumatic bleed and less were spontaneous. And bypassing agent which were inhibitors we have used around 13%. You can see that drastically improving, decreasing in the bleeding rate of this patient with even with the low dose. Then the rebalancing therapy, as we told, we'll try to discuss concizumab, that is anti-TFPI monoclonal antibodies. It helps in neutralizing factor 10 and tissue factor, and that activates your factor 10 directly and helps in the clot formation. The result is a stable clot formation. You can see here, and that drugs help. The beauty जो natural anticoagulants है उसको कम करने के लिए help करता है. We'll not go in detail, I don't have much time. Concizumab overview, they have shown again the bleeding rate, annual bleed rate has drastically come down. Even we are doing clinical study on the same, and we have seen the spontaneous bleed has come to less than, ABR is less than 1 to 2 only, and the traumatic bleeds were 2 to 3 in that, and the factor required in between was very less. So this was a study, we will not discuss in detail. Again is the marstacimab. This was again phase 3 basis trial. They have also shown 92% decrease in the annual bleed rate has been noticed in this also drug. So these are the non-factor therapies which are helping us a lot. So coming back to our patient, this patient, uska हाथ ये हो गया. Now he got admission into MBBS. अब ये MBBS में आ गया. They have come requested, sir, we need some factors, good thing. तो नॉन फैक्टर पे इसको शिफ्ट करने के बाद फैक्टर से नॉन फैक्टर ऑन रेगुलर प्रोफिलैक्सिस, एंड इसके अभी सेकेंड ईयर में ही इज डूइंग क्वाइट गुड. इसका एग्जाम्स में कभी भी इसको प्रॉब्लम नहीं है. लास्ट 2 years में एनुअल ब्लीड रेट वाज लेस देन 1 to 2 ओनली. वी हैव अनदर पेशेंट अमॉन्ग दैट ओनली. यू कैन सी हियर, पहले उसका ब्लीडिंग रेट कैसा था, उसको पैर से चलना भी बहुत मुश्किल हो रहा था. उसको जब रेगुलर फैक्टर रिप्लेसमेंट में लिया गया था, कुछ 3-4 महीने बाद काफ़ी इंप्रूवमेंट दिखा. फंक्शनल इंप्रूवमेंट अराउंड 50% 60% तक दिख रहा था. एंड देन आफ्टर 7 to 8 months ऑफ थेरेपी इट इज़ एब्सोल्युटली ऑलमोस्ट ही इज वर्किंग फंक्शनली, एकदम नॉर्मल जैसा हो रहा है. ही इज परस्यूइंग CA हो गया पास हो रिसेंटली लास्ट ईयर. सो दिस आर द थिंग्स basically that we should be looking that our patients are improving or what. Last to not but the least, we are in a gene transfer now. India is also developing. Dr. Alok Srivastava sir might come in another 1 or 2 years for the therapy of the gene therapy. That will be curable option. और शायद उसका cost के कारण is a big concern for us. So these 3 things to understand. replacement में अपना EHL SHL में bleeding treatment and prevention के लिए it is very good. But concern is again the IV route. नॉन रिप्लेसमेंट थेरेपी में ब्लीडिंग प्रिवेंशन ओनली करेगा. एक्टिव ब्लीडिंग में नॉन फैक्टर काम नहीं करेगा. दैट इज यू हैव टू मेक श्योर. सबसे बड़ा एडवांटेज है सबक्यूट है, आईवी देने की जरूरत नहीं है, एंड इट इज इफेक्टिव इन इनिबिटर थेरेपी ऑल्सो. जीन थेरेपी ओनली 1 time ट्रीटमेंट रहेगी एंड इट विल ऑल्सो हेल्प अस अ लॉट. हाउ टू इंटीग्रेट वी विल नॉट गो इन डिटेल. दिस आर द फ्यू एडवांसेस. आर्टिफिशियल इंटेलिजेंस, मेडिकल डिवाइस, अल्ट्रासाउंड वी आर ट्राइंग टू यूज. Digital health, we have developed our own app at Kolhapur so that all our patients are getting registered. वो आने के पहले ही, ब्लीडिंग के पहले ही वो ऐप पे रजिस्टर कर देते हैं. तो जब तक पहुंचते हैं तो जो टाइम है नीडल का और वो ब्लीडिंग का जो हमारा लेस देन 30-40 मिनट्स रहता है, पेशेंट को तुरंत फैक्टर मिल जाता है. वी आर वर्किंग ऑन सम बायोमार्कर्स ऑल्सो एंड अंडर रिप्रेजेंटेड पॉपुलेशंस वी आर ट्राइंग टू फाइंड आउट दोज को कोई ब्लीड करेगा. एंड दिस आर द डिफरेंट therapy, psychological, social impact on the hemophilia. Always think different. And last take home message, prophylaxis is no longer optional, it's a standard of care. Zero bleed should be the goal always. Early initiation in childhood is a critical. Prevention is better than joint replacement. EHL factor and non-factor therapy is a transforming care. Emicizumab, concizumab are effective, convenient and game changer. Upcoming are fitusiran and marstacimab. Access plus awareness is a transformation. Future direction, factor free prophylaxis plus gene therapy, that will be the curable. And India's priority, we all are here for that. Patients deserve near normal lives. This is our first goal. Ensure equitable access. जो मैडम बोल रहे थे सबको one treatment one nation में जो होना चाहिए. Strengthened HCG and early diagnosis. Thank you very much for your patience listening. And now time has come to change this picture. Change from not disability free but bleed free hemophilia in India. Thank you.
Thank you so much, Dr. Varun Bafna sir, for that fantastic and engaging PPT and the entire presentation. कितने लोगों को PPT बहुत engaging लगा? Please raise your hands. It was right. तो ताली जो हम बजाते हैं, we do the claps, right? तो इसमें 2 प्रकार होते हैं. Okay, let me complete. हम करेंगे. It is crime to stop somebody like Varun Bafna sir speaking, and I had to do this because time constraint थे, तो मुझे करना पड़ा कि सर हमें कट शॉर्ट करना पड़ेगा. But I feel that is absolute crime. पर हम नेक्स्ट टाइम सर इसकी भरपाई करेंगे. मैं कह रहा था कि क्लैप करने के 2 प्रकार होते हैं, तो हम वो दोनों प्रैक्टिस करेंगे अभी. फर्स्ट इज हाउ टू नॉट टू क्लैप. ओके, एवरीवन इज एक्सपर्ट इन नॉट क्लैपिंग, सो लेट्स डू द हाउ टू क्लैप. कैसे करते हैं क्लैप? So everyone knows how to clap, and same energy, same vibe अभी हमें थोड़ी देर और रखनी है. हम सभी का एक सपना होता है, ड्रीम होता है कि we should have a very comprehensive care to be available in all our HTCs. वहाँ पे tertiary care हो, वहाँ पे हम चाहते हैं multidisciplinary team हमेशा available रहे, and that is very important in all the HTCs. I believe we all somewhere want that in every hospital to happen. And now our next speaker, Dr. Akshay Lahoti sir, MGM Medical College from Indore, is going to enlighten us on the same topic कि ये कैसे होता है. So over to Dr. Akshay Lahoti.
गुड इवनिंग एवरीवन. आई एम अवेयर कि हम लोग बहुत शॉर्ट ऑफ टाइम है. आई विल नॉट टेक मच टाइम, एंड स्पीकिंग आफ्टर डॉक्टर वरुण बाफना इज एक्चुअली समथिंग आई नीड टू लुक अपॉन. सो वी हैव ऑल हर्ड अबाउट द ट्रीटमेंट ऑफ हेमोफीलिया टिल नाउ, बट देयर इज समथिंग मोर apart from factor administration, treating the patients with the factors and non-factor therapies. So first of all, I would like to thank HFI, Mr. Prem, and this conference for inviting me over here. And I am working in Indore as an associate professor at MGM Medical College. So yes, we are not having a nodal center over there, but most of the hemophilia patients do come over there for tertiary care, and we do admit when the complications in the patients are there. So one condition, but many needs. It is not only the factor therapy, but yes, we need to look apart from the factor therapy what the patient needs more. So this will be the flow of my talk, where I'll conceptualize the need of these multidisciplinary team. Understanding hemophilia, we have all understood now. What is a single specialist view, which I do over there? Multidisciplinary team, what we are lacking over there, and what are the benefits, what are the challenges, how can we make it more impactful. There are few cases to highlight the role of MDT, and yes, the advancing hemophilia care. So to conceptualize, probably we need to counsel our administrators that yes, this HTC is very important for the hemophilia care, and how do we do that. So when we see the general hematology care, that a single hematologist taking care of the hemophilia patients, so then there is a fragmented specialist referral. So obviously when I see a patient of hemophilic arthropathy in my clinic, I don't know that which orthopedician do I consult, whether that orthopedician will understand the need of that hemophilia patient or not. The physiotherapy department will understand what I am telling, that you need to take care of this patient, and which we all know that when we see a patient of hemophilia, we all are aware that how much factors are we supposed to give. But how do we care about those, the hidden arthropathies or the hidden emotions of that patient, the social stigma of that patient? How do we create the recreation for those patients? So these are the important part of the MDT, multidisciplinary team. So that is what the focus is of comprehensive HTC care, where there is a centralized multidisciplinary hub. The hematologist, the physician, the pediatrician, the orthopedician, the physiotherapist will sit under one roof, maybe in a week, maybe in a month, but yes, there will be the decision making capacity for those patients. So we are not confused where do we refer to. Treatment approach, it is not reactive, and we have all understood that prophylactic hemophilia care is the need of the hour, and it is what is required for every patient. Factor utilization, probably it is optimized when there is an HTC care, because your nurse will emphasize on the regular follow-up for that patient, probably we all sitting in our clinic won't be able to do, but when we have a dedicated nurse, they will be calling the patients again and again, and probably they will be a proper follow-up for that patients. Patient role, so patient is the epicenter, it is not a passive recipient. He knows, he understands, he is educated, and that is why he will have the power, or he will be an active member in this STC care. So when we want these STC to establish, we want to counsel our administrator that this is a cost saving approach. So that is where they will come into picture and they will tell, okay, create it. So why? So the cost saving criteria, because when the patient bleeds less, the factors utilization is less, the emergencies are less. So probably your 90% of the cost is because of the clotting factor replacement therapies. अब जब वो cost कम होगा तो obviously your economics goes better. So we have all understood hemophilia. It is a bleeding disorder, X-linked disorder. Males and females both can get complicated, and we have similar bleeding episodes, joint damage, life-threatening risk. We all do not want these in our patients, and that is what the goal is. So beyond the blood, the holistic impact is physical, obviously joint damage, psychological. So patient do get emotional, they have anxiety, depression, emotional strain from living with an unpredictable lifelong complication. This needs to be addressed. They have some social problems again because of the social stigmas, activity restrictions. They are not able to get a proper schooling, and obviously the economics when they do not get jobs. So these are the problems which are beyond the factor replacement therapy, and we need to take care of these aspects together. This is a silent damage, joint damage. We have all understood this. The traditional approach. So when we are sitting alone in our clinics, so this is what a single hematologist or a physician is doing. They have a crucial role. They diagnose hemophilia, they prescribe the factors or non-factor replacement therapies, but again there is a limitation. So incomplete patient picture. I know that I can give the factors, but I don't know how to treat my joint. I don't know how to take care of my emotional patient. I don't know how can I get a job for this patient. So there is a limitation. Fragmented care, again, the patient compliance is poor, the patient's follow-up is poor, so there is a fragmented care. And there is critical gaps, overlooking mental health, rehabilitation, social support, which can significantly affect the patient's quality of life. So there comes the role of MDT. What is an MDT? It is a focused, pooled expertise people who are working together as a collaborative unit, and they are working in concert to deliver the full spectrum of care of a patient needs. It is patient-centered, obviously, and these are the core MDT people for hemophilics. So a hematologist or a physician or a pediatrician, one, a hemophilia nurse, obviously, a physiotherapist or a social worker and a psychologist. So these are the four core member of the MDT hemophilia. The other members which we require maybe once in a week or a month, an orthopedic surgeon, a pharmacist for the complicated cases where we need to give some ITI therapies or some newer therapies which we are unaware, the dentist probably in the growing age group, the anesthetist and the PMR physician, and obviously the two more important people over here are the pathologist and the geneticist in these specific cases. The patient is not just a subject of care, they are a distinct core member of the team engaged in shared decision making. So the patient and family are an important member of this MDT team, and they need to be educated so their compliance and the follow-up is better. The benefits of unified front. So there is less bleed frequency because of the regular prophylaxis, regular follow-ups. There is less hospitalizations, again because of the lesser emergencies. They have better joint health because of the regular physiotherapy, regular prophylaxis of the therapy, regular follow-up, and treatment adherence because they know there are many people in the team who are taking care of these patients. So yes, holistic approach to a well-being. So MDT model recognizes that managing hemophilia means caring for the whole person, and it is not just the coagulation profile. And this is a lifelong care continuum, and we need to understand whenever the patient is traveling from birth to childhood to adolescence and to adulthood, the demands of each age group is different, and we need to focus on the different aspects when the person grows in age. So the necessity of a MDT approach in hemophilia care is well recognized globally. What are the challenges of an MDT care? So the scheduling complexity. Coordinating appointments across multiple specialists creates significant administrative and logistic challenges for both teams and patients. So yes, this can be sorted. Probably we can take that group of doctors for a single day in a week or in 2 weeks or a month in a specific day in a specific hemophilia care center. The second is the geographic barriers. Patients in rural or underserved regions may lack access to the full spectrum of MDT specialists. Obviously, in the district hospitals, we don't have the facility of all these people. So probably there is a hierarchy: primary healthcare, secondary healthcare, tertiary healthcare. So these things can be taken care by the tertiary care centers once in a month. Resource constraints. Not all healthcare settings have a staffing, funding, or infrastructure. Probably these can be incorporated from the administrative level. Patient-specific factors. Their patient differs widely in their readiness and capacity for self-management. The MDT must adapt the approach to meet each individual where they are. So how to overcome this, we'll discuss in the upcoming slides. Inhibitor complexity. Patients who develop inhibitors, especially when surgical intervention is being considered, they need to be treated in a different way. And tailored team composition. No two patients are alike, and we know that. So how do we deal when the patient is coming from the remote areas? Probably we need to tie up between the physical and the hybrid model. So there is a hybrid model where we can discuss about the online and the offline things. Few things can be done in-person visits, and the few things which can be educated, monitoring and follow-up of the well-being can be done from the virtual touch points. So there comes the role of WhatsApp, webinars, or the Zoom calls with the patient from your nurse. Personalized delivery tailored to disease severity, patient preference and provider capacity, flexible by design. So hybrid care models may provide an opportunity to overcome these challenges when the patient suffering from hemophilia cannot come from the remote areas to your place. So obviously they can be counseled or they can be educated remotely on an online module. Maybe 3 visits, once in a month he can come back to your center. So when the MDT comes, there is an improvement in the overall patient well-being, which we can understand through these 2 short cases. First one, a young adult with severe hemophilia experiencing recurrent joint bleeds and progressive arthropathy. So now hematologist will give optimal replacement therapies. Now there is a role of physiotherapist where he has developed some targeted strengthening and mobility exercise program for that individual patient. An orthopedic surgeon will assess if there is any requirement, the surgical intervention will be done. And psychologists obviously it provide evidence-based coping strategies for managing chronic pain. So these are the 4 different aspects which a single hematologist or physician cannot take care. And the outcome is there is significant reduction in bleed frequency, measurably improved joint function, and enhanced quality of life, which is achieved through coordinated MDT action team. Second is a patient who has developed inhibitor, where you need a pharmacist because you need to give him an ITI therapy. A hemophilia nurse delivering intensive education to the family on ITI protocols and home infusion techniques, because these ITI protocols will run for 6 months to a year, and there how we will be able to monitor those patients frequently. Pharmacists who can develop more complex high frequency medication regimen with precision and vigilance. So we need the help when we are treating all these complicated cases, and not a single person can do all these things. So the road ahead, that is the concluding slide, that embrace the MDT is not optional, it is the recognized standard of excellence for comprehensive hemophilia management. Open communication and shared decision making between specialists and patients are paramount to successful outcomes. Virtual and hybrid models extend the reach of expert care to patients regardless of geography or circumstance. And patient centricity is always there. We all are working towards the betterment of the patient, and we need to take care of all these parameters that the patient is not able to come. Obviously a patient who is having arthropathy or an acute bleed, it is difficult for them to come daily to your hemophilia center to get the factors, and this is a very much inhibitor for these patient care. So probably some home care techniques, some something where we can do some virtual things where we can tell them how to administer factors at their home. So power of many, transforming lives one team at a time. Hemophilia is a complex, but with the right MDT team, every patient has the opportunity to live a fuller, healthier and more empowered life. It is more than a bleeding disorder, and this is the summary slide where we can see that on one part we have a specialized HTC center, and where the other part we have an outside general care, and this is me probably sitting in my OPD where I'm confused that how to coordinate with the different people at the same moment when the patient arrives in my OPD, who is filled with more than 50 patients. But probably in an MDT team we are more synchronized, we are more effective when we are treating a patient of hemophilia. So higher risk of hospitalization when we are uncoordinated, probably 70% higher mortality rate outside HTCs, 40% increase in hospitalization outside HTCs, and this will probably lead to long-term costs and poor outcomes, which can be modified when we have a poor, well-coordinated picture. Thank you for your patient hearing.
Hello. So thank you so much, Dr. Akshay Lahoti sir, for that kind presentation, and it was very informative. Now we proceed to the last day of our session, that is panel discussion. तो अभी मैं इनवाइट करता हूँ डॉक्टर लखन पोसवाल सर, JLN मेडिकल कॉलेज अजमेर, गवर्नमेंट ऑफ राजस्थान, डॉक्टर बिलाल अहमद सर एज अ पैनलिस्ट, GMC श्रीनगर, गवर्नमेंट ऑफ JNK, डॉक्टर रविंद्रन, ब्लड बैंक ऑफिसर सालेम, गवर्नमेंट ऑफ तमिलनाडु, डॉक्टर जसकिरण सिंह भसिन, नोडल ऑफिसर ICHH लॉर्ड महावीर सिविल हॉस्पिटल लुधियाना, डॉक्टर KB Yadavarpan Reddy, HOD RIMS Kadapa, Andhra Pradesh. And this panel discussion is going to happen on the prophylaxis in the Indian setting. I would like to give memento to Dr. Akshay Lahoti sir. I request our CEO, Mr. Rajneesh Jain, to kindly hand over to him.
Excuse me, am I audible? वैसे तो बहुत कम लोग बच गए हैं, बट जो भी बचे वो जाग जाएं, ठीक है? सो एक चीज़ कर लें, सभी एक बार खड़े हो जाएं प्लीज़, ठीक है जी? एक बार खड़े हो गए, अपनी स्ट्रेच कर लेते हैं, एक बार स्ट्रेच कर लो, सभी जाग जाएंगे, ठीक है? लास्ट सेशन है, ठीक है? थोड़े टाइम लेंगे बस।
अपना फिजियो हो गया है अभी। This is a token of gratitude from the Hemophilia Federation India. Cameraman, please take a picture.
So good evening everyone, it's the last session. You must have seen all the senior and experienced speakers, Dr. Parul, Dr. Naresh Gupta, but your youngsters have also done extremely well. Dr. Bapna and Dr. Lahoti. So everyone tried to impart as much knowledge and share the experience as possible. और सभी को आपने देखा कि ये यहाँ से कह के हटाया गया कि साहब बहुत हो गया, टाइम आपका हो गया। तो इस पे मैं एक मिर्ज़ा गालिब का एक शेर सुनाना चाहता हूँ आपको कि हज़ारों ख्वाहिशें ऐसी कि हर ख्वाहिश पे दम निकले, बहुत निकले मेरे अरमान लेकिन फिर भी कम निकले। तो पूरा टाइम लेने के बावजूद भी इतनी नॉलेज शेयर करना चाह रहे थे सारे स्पीकर्स, जेन्युइनली, कि टाइम उसके लिए नहीं मिल पाया। सो दिस इज बेसिकली lot of discussions have taken place on prophylaxis, and as all the speakers have emphasized, prophylaxis is a standard of care for hemophilia patients, A as well as B. Now what are the practical experiences and what are the practical difficulties in implementing this standard of care
that is the topic for this panel discussion. And let me introduce my esteemed panelist, Dr. Bilal Ahmed. You everyone know, is a very senior hematologist working for hemophilia. I have met him many times in the IHCs. He's from Srinagar, J&K. And another panelist is Dr. Ravindran. He is a blood bank officer in Salem, government of Tamil Nadu. Then Dr. Jaskaran, who was now practicing stretching exercise. Dr. Jaskaran Singh Bhasin is a nodal officer of ICHH, Integrated Care for Hemoglobinopathies and Hemophilia. Yeah. Lord Mahavir Civil Hospital, Ludhiana, Government of Punjab. And then Dr. K.B. Yadvinder Reddy, he is HOD of Medicine at RIMS, Kadapa, Andhra Pradesh. So one is a pediatrician dealing with hematology and hemophilia care, and then a physician, then a pathologist, and blood bank in charge. So we have a full spectrum of the experienced people. Now my first question goes to Dr. Bilal Ahmed. इतना सारा प्रोफाइलेक्सिस के बारे में बात किया. प्रोफाइलेक्सिस देने में आपके जो गवर्नमेंट ऑफ जम्मू एंड कश्मीर, नाउ यू हैव ए सेपरेट स्टेट, क्या पॉलिसीज, व्हाट आर द पॉलिसीज एंड व्हाट इज योर एक्सपीरियंस इन इम्प्लीमेंटिंग, हाउ डू यू गिव प्रोफाइलेक्सिस टू द हीमोफीलिया पेशेंट्स?
एक्चुअली जो हमारी यूटी ऑफ J&K है, तो उसमें एक्चुअली हमने जो सफ़र स्टार्ट किया था वो हमने स्टार्ट किया था 2013 में, जो ऑनरेबल हाई कोर्ट की अपील हुई थी. तो हीमोफीलिया पर्सन्स विद हीमोफीलिया उनको ट्रीटमेंट नहीं मिल रहा था, तो वो सिर्फ यही ब्लड प्रोडक्ट्स पे थे. तो उन्होंने फिर क्योंकि उसमें जैसे डॉक्टर नरेश बोल रहे थे, देयर वर सो मेनी चैलेंजेस ऑफ ट्रांसफ्यूजन ट्रांसमिटेड इन्फेक्शंस एंड ऑल साइड इफ़ेक्ट्स ऑफ जो ब्लड एंड ब्लड प्रोडक्ट्स थे. तो उन्होंने फिर पिल ली कि बहुत सी बच्चों को हेपेटाइटिस हो गया, HIV हो गया. तो उन्होंने फिर ऑनरेबल हाई कोर्ट में पिल डाली कि हमें ऐसे हो रहा है, तो हमें ये एंटी हीमोफिलिक ड्रग्स चाहिए. तो उसमें फिर उन्होंने स्टार्ट किया. दे हैव गिवन द 2 करोड़ ऑनरेबल हाई कोर्ट ने फिर 2013. तो दे जस्ट सैंक्शन 2 करोड़ एट दैट टाइम. तो उसमें हमने एंटी हीमोफिलिक ड्रग्स फिर हमने खरीदे. तो यूजुअली ये जो आते थे ये आते नहीं थे, जब भी इनको कुछ ब्लीड होता तब ये आते थे ब्लड में. तो फिर जब इन्होंने सुना कि मतलब फैक्टर्स अवेलेबल हैं अब सेंटर में, तो दे जस्ट गॉट पीपिंग अप इनटू द सेंटर. तो फिर हमने उसी वक्त का उस मौके का फ़ायदा उठाया, हमने इनको सारों को रजिस्टर करना स्टार्ट कर दिया. तो धीरे धीरे सफ़र चला. तो फिर हर साल ऐसे 2 करोड़ 3 करोड़ मिलता था. तो 2017 तक ऐसे ऑन डिमांड ही हम चल रहे थे. मतलब जब भी आता तो हम फैक्टर्स की दे रहे थे. 2017 में हमने क्या किया कि उसमें उस पर हमने ऐसी जैसी CMEs करते हैं, तो हमने एक CME कर ली. तो उसमें हमने ये उनको जो हमारे प्रिंसिपल थे या एडमिनिस्ट्रेटर थे, उनको ये मतलब एक ओवरव्यू दिया कि डायग्नोसिस इज़ वेरी इंपॉर्टेंट. सो डायग्नोसिस के लिए हमें एक लैब चाहिए, लेबॉरेटरी चाहिए मॉनिटरिंग के लिए, ट्रीटमेंट के लिए और डायग्नोस के लिए. तो 2017 में हमने वो हीमोफीलिया डे पे 17 अप्रैल जो था किया. तो उनको ये समझ आया कि थोड़ा हाँ इसकी इम्पोर्टेंस है. तो फिर हमने 2017 में हीमोस्टैटिक लैब स्टार्ट किया. तो धीरे धीरे उसमें हमें बहुत फ़ायदा आया. एटलीस्ट मतलब हमने वो उससे पहले PTA-PTT नहीं होता. तो फिर हमने फैक्टर से भी स्टार्ट कर दिए. तो आज हमारे पास फुल फ्लैज हीमोस्टैटिक लैब है. उसका ये फ़ायदा हुआ कि एक तो हम मॉनिटर करते थे ट्रीटमेंट का, और उसका नए स्क्रीनिंग करते थे. तो ये हो रहा था. तो अल्टीमेटली 2019 में फिर हमें जब उन्होंने डेटा हमें गवर्नमेंट को दे दिया कि हमारे पास इतने सीवियर हीमोफीलिया A हैं या B हैं, और उनका ब्लीडिंग फिनोटाइप दिया कि कितनी बार ये आते हैं हॉस्पिटल, कितना, क्योंकि हमारा जम्मू कश्मीर का जो कश्मीर का पर्टिकुलरली जो रीजन है वो थोड़ा जोग्राफिकली वेरी टफ रीजन है. पहाड़ी इलाके हैं, पेशेंट्स दूर दूर के हैं. तो कनेक्टिविटी विद द मेन सेंटर ऑफ द श्रीनगर, बिकॉज वहाँ पे एक ही सेंटर है हीमोफीलिया ट्रीटमेंट सेंटर, वो श्रीनगर में है, दूसरा जम्मू में है. तो वहाँ पे अलग डिस्ट्रिक्ट सब डिस्ट्रिक्ट लेवल पे कोई से वहाँ एक ही सेंटर है. तो एवरी दिस PWH is treated under the one roof of in Kashmir and one in the Jammu. तो फिर हमने 2019 में उनको दे दिया कि ऐसे हमारे पास ये आ रहे हैं, चैलेंज आ रहे हैं, बहुत सी आई मीन लाइफ थ्रेटनिंग ब्लीड्स आते थे, बहुत हॉस्पिटल का खर्चा होता था, मतलब केयर गिवर्स का बर्डन था, ट्रैवलिंग का था, दूर दूर से आते थे, तो सिटी में रहना बहुत मतलब महंगा था. तो वो देख के उनको हमें बोला कि हमने किस तरह की ना वो प्रपोज बना दिया कि कितने सीवियर हैं. हमने उनको वो मालूम प्रोटोकॉल के हिसाब से लो डोज प्रोफाइलैक्सिस स्टार्ट किया, ट्वाइस आई मीन 10 to 15 और 20 IU per kg. उस वक्त तो स्टैंडर्ड हाफ लाइफ प्रोडक्ट्स थे, ये चल अभी नहीं आया था, और प्लाज्मा डेराइव्ड प्रोडक्ट्स थे. तो हमने उनको वही प्रोटोकॉल दिया, ट्वाइस वीकली या थ्राइस वीकली डिपेंडिंग अपॉन द ब्लीडिंग फिनोटाइप. उस हमने एक प्रपोजल तैयार किया 2019 में एक बजट का. तो हमने गवर्नमेंट को बोला कि ये हमें चाहिए. तो fortunately I mean there was nobody to question us. I don't know, maybe because of the lack of knowledge, and we just gave them the demand. Because हमारे क्या होता है, हमारे पास एक पोर्टल खुलता है जनवरी या मार्च में फॉर एनुअल डिमांड. तो हमने उसको कैलकुलेट करके हमें फॉर एग्जांपल हमारे पास 10 करोड़ का बजट आ रहा है, तो हम दे रहे हैं वो बजट. जब दे रहे हैं तो वहाँ से हमें कोई क्वेश्चन नहीं कर रहा है, तो हम बोल रहे हैं ये है हमारी रिक्वायरमेंट, ये फिर आपका डोमेन है, आप दोगे तो ठीक, नहीं दोगे तो हम आपको कुछ नहीं बोलेंगे. हाँ, अगर कुछ क्राइसिस होगी, कुछ अनइवेंटफुल थिंग हो गया, तो देन यू विल बी रिस्पॉन्सिबल, वी विल नॉट बी रिस्पॉन्सिबल फॉर दैट. तो उससे वो थोड़ा डर गए, तो वो उन्होंने बजट दे दिया. तो तब से हमने 2019 दिसंबर से हमने फिर रेगुलर रिप्लेसमेंट थेरेपी स्टार्ट की सीवियर हीमोफिलिक्स को, सीवियर हीमोफिलिया ए एंड सीवियर हीमोफिलिया बी. तो ये सफ़र चला 2 साल, 2021 जून तक. तो जब फिर नॉन फैक्टर थेरेपी आई, तो उसमें हमने जब वो इम्पैक्ट देखा तो बहुत कम आई मीन वो आते थे, या उनको हम घर में ही देते थे क्योंकि दूर दराज थे, 1 महीने की सप्लाई देते थे, फिर हम खाली वहाँ से वायरस लाते थे साथ. तो वो सफ़र बहुत अच्छा चला. तो हमने फिर उसको कंपेयर किया ऑन डिमांड के साथ, जो हमारा पीरियड था 2013 से 2019 तक, और जो 2019 से 2021 तक. तो उसमें उन्होंने देखा कि कितने विजिट्स आते थे, कितनी कॉम्प्लिकेशंस आते हैं, कितनी ICH ब्लीड आते थे, कितना उनको ट्रैवल करना पड़ता था, कितना केयर गिवर्स का बर्डन था, कितने बच्चों का स्कूल जा रहा था, कितने लेबरर्स का लेबर जा रही थी, तो मेंटल स्ट्रेस कितना था, बाकी फैमिली स्ट्रेस कितना था. तो वो जब देखा तो वो इट वाज वेरी आई मीन एविडेंट. जो हमने रेगुलर रिप्लेसमेंट थेरेपी जो 2 साल दी, उसमें तो रिमार्केबल डिफरेंस थी. वो तो आते नहीं थे, उनका तो सारा वो बच्चे स्कूल जाने लगे. तो वो तो अल्टीमेटली फिर दूसरा जो गेम चेंजर हुआ वो नॉन फैक्टर थेरेपी. उसमें ये हुआ, वो हमने जून 2000 we were the first to start it जून 2021. तो हमारे पास सबसे बड़ा डेटा है राइट नाउ. वी हैव 5 years एक्सपीरियंस नॉन फैक्टर थेरेपी. तो उसमें सबसे बड़ा एडवांटेज क्या था, once a month सब कट, उनको 1 महीने के बाद आना पड़ता था. वो भी मतलब अपना बच्चे अपना, तो हमारे पास डेटा वो हमने पब्लिश भी किया है इसमें इंटरनेशनल जर्नल ऑफ हेमेटोलॉजी में, रिव्यू हेमेटोलॉजी में. तो उसमें पूरा उनका जो टारगेट जॉइंट ABR या क्वालिटी ऑफ लाइफ बहुत इम्प्रूव हो गया. बच्चे स्कूल जाने, उनको ये भी भूल गया कि शायद हमें हीमोफिलिया ठीक हो गया. उस चक्कर में क्या हुआ कि वो ज़्यादा उछलने कूदने लगे, तो वो ट्रॉमेटिक ब्लीड्स आ रहे हैं हमारे पास, कुछ फॉल्स आ रहे हैं, कुछ साइकिल, कुछ स्कूटर एक्सीडेंट्स एंड ऑल दैट. वो ज़्यादा हमें वही ब्रेक थ्रू ब्लीड बहुत कम आ रहे हैं. तो अभी तो वैसा ही जा रहा है, क्योंकि वही है स्टैंडर्ड ऑफ केयर. क्योंकि ये हम उनको समझाते हैं, देखो भाई ये जो है, मतलब परसों भी हमारी एक टेक्निकल कमेटी बनी परचेज के लिए. तो वहाँ पे HOD मेडिसिन था, पीडियाट्रिक्स थे, हेमेटोलॉजिस्ट थे, बाकी डिपार्टमेंट्स के थे. तो उन्होंने क्वेश्चन डाला, यार ये तो हमारा बजट है यार, बजट में तो इतना कहाँ, ये तो हम तो बाकी मेडिसिन लाते नहीं, सारा बजट तो इसी में जाता है. देखो मैंने बोला यार ये हमारा डोमेन नहीं है, हमारा डोमेन है, देखो हम प्रोजेक्ट करेंगे, ये है एज ए टेक्निकल पर्सन. फिर गवर्नमेंट दे या ना दे, वो उनका डोमेन, दैट इज नॉट आवर डोमेन कि बजट इतना ही है, काम है. दिस इज द प्रॉब्लम विद डॉक्टर्स. आई डोंट नो व्हाई दे आर स्केरी ऑफ बजट. वी शुड नॉट बी वरिंग अबाउट बजट. बजट इज अ पार्ट ऑफ गवर्नमेंट एंड एडमिनिस्ट्रेशन. उनके पास है तो देंगे, नहीं होगा तो नहीं देंगे. बिकॉज कल को क्या होता है, ऐसे भी मैंने केस देखे, अगर आप बजट कम दे रहे हो, कल को पेशेंट को गॉड फॉरबिड सम ICH हो गया, यहाँ लाइफ थ्रेटनिंग या मॉर्टलिटी हो गई कोई, तो न्यूज़पेपर में आ गया, पेपर में आ गया, ऐसा बढ़ गया, फिर वो उसी एंड यूज़र को पकड़ते हैं. ये क्या हो गया, उसने वो बोलेगा नहीं दवाई नहीं, वो बोला आपने बोला क्यों नहीं, आप अगर बोलते हम तो देते हमारे पास पैसे हैं, उस वक्त तो वो नहीं बोलेंगे हमारे पास पैसे नहीं है, लेकिन उस वक्त वो बोलेगा ज़रूर कि हमारे पास इतना पैसा है, गवर्नमेंट के पास इतना पैसा है, आप क्या बोल रहे हो, आप अगर देते, अगर आपने प्रोजेक्ट किया होता तो हम देते आपको। इसीलिए मैं कहता हूँ हर किसी टेक्नोक्रेट को यू शुड बी सेफ एट योर लेवल बिकॉज यू आर अ टेक्निकल।
तो डॉक्टर बिलाल का बहुत बड़ा एक्सपीरियंस है
वैसा जा रहा है
इन प्रोफाइलेक्सिस एंड ही इज वन ऑफ द एडिटर ऑफ आवर नेशनल गाइडलाइंस ऑन हीमोफीलिया। थैंक यू सो मच सर। तो आपका जो स्टैंडर्ड हाफ लाइफ और आपने फिर सीधा जंप कर गए आप नॉन फैक्टर EHL का भी कुछ एक्सपीरियंस है आपका?
में ज़्यादा क्योंकि वो प्रॉब्लम आ जाती है सप्लाई चेन में, EHL आपका ना वो सप्लाई चेन कंटिन्यूसली नहीं रह जाता है, तो उसमें हमें 5-6 महीने का है, उसमें भी बहुत बढ़िया जाएगा, उसमें मतलब एज कम्पेयर टू SHL बिकॉज फ्रीक्वेंसी ऑफ इंजेक्शंस कम थे, डोज भी आप इवन 20 IU अगर भी देते उससे भी अगर हाफ डोज भी उससे भी अच्छा जा रहा था 1 से भी, तो उसमें मतलब अगर उसमें 8 इंजेक्शन लगते हैं 1 महीने के, उसमें 4 ही लगते हैं।
तो जैसा भी हो, चाहे स्टैंडर्ड हाफ लाइफ फैक्टर आपके पास अवेलेबल हो या EHL अवेलेबल हो, नॉन फैक्टर हो, प्रोफाइलेक्सिस पे लेना है पेशेंट को कैसे न कैसे। हालांकि नॉन फैक्टर थेरेपी आने के बाद में पेशेंट्स इजीली मान जाते हैं, फॉर द फैक्टर्स मे बी ट्वाइस इन ए वीक और even once in a week, it was very difficult for all of us. Now we move to a pediatrician, renowned pediatrician of Punjab. आपके हीमोफीलिया में काफ़ी काम कर रहे हैं आप डॉक्टर जसकरण, और अभी मेरी आपसे बाहर भी काफ़ी बात हुई, तो आप प्रोफाइलेक्सिस को लेके काफ़ी सोच रहे हैं कि ज़्यादा पेशेंट्स को प्रोफाइलेक्सिस पे लिया जाए। तो पीडियाट्रिक एज ग्रुप में आपका क्या मानना है कि प्रोफाइलेक्सिस के लिए कितना इजीली पेरेंट्स मान जाते हैं, और स्टैंडर्ड हाफ लाइफ और EHL के साथ क्या प्रॉब्लम्स रहती हैं, और अभी ये जो नॉन फैक्टर थेरेपी आ रहा है इसमें कितना प्रॉमिसिंग है कि हम ज़्यादा से ज़्यादा पेशेंट्स को ले पाएंगे प्रोफाइलेक्सिस पे?
सर लाइक इन जो बच्चे हैं, जो पीडियाट्रिक पॉपुलेशन है, उसमें सर एक तो कैनुलेशन का बहुत इशू है, बहुत बड़ा इशू है कि उनको अगर उनको स्टैंडर्ड हाफ लाइफ या EHL हमें लगाना है तो उसको बार बार प्रिक करना पड़ेगा, एंड उनकी जो स्किन होती है इट इज़ क्वाइट मतलब मच सबक्यूटेनियस टिश्यू, उसमें वेन इजीली फाइंड नहीं होती है, बच्चे चबी होते हैं, जो इन्फेंट्स होते हैं वो चबी होते हैं, सो दैट इज़ अ बिग इशू व्हेन व्हाइल एडमिनिस्ट्रिंग IV इंजेक्शंस। सो इन दीज पेशेंट्स prophylaxis with non-factor therapy like emicizumab would be a good option. Yeah. So likewise in older children we can consider prophylaxis with EHL, but in smaller children like usually less than 6 years we need to give prophylaxis with non-factor therapy.
You shared some experience regarding individualized low dose prophylaxis, but your experience is not encouraging. What would you like to say?
Actually I tried to start patients on prophylaxis with low dose like 10 IU to 20 IU per kg weekly dose, but patients of severe hemophilia used to have bleeds even on that low dose also. So likewise we have treated cases of like hematuria, like tooth shedding with a single dose of 50 IU per kg. I have treated many cases of hematuria with a single dose of EHL 50 IU per kg, and they used to be bleed free after that. And likewise if we shift them on a low dose prophylaxis with EHL, still patient experience bleeds.
In many centers there have been good trials on low dose prophylaxis, like in our SMS Medical College Hospital at Jaipur. They are doing keeping patients on low dose factor prophylaxis, and the results are quite encouraging. Sir, डॉक्टर रविंद्रन सर, आपका ब्लड बैंक से काफ़ी जुड़े हुए हैं और तमिलनाडु में भी काफ़ी अच्छा हेल्थ सर्विसेज हैं। प्रोफाइलेक्सिस के बारे में फैक्टर्स का प्रोक्योरमेंट की आप आर यू
Can you ask in English?
Yes, yes, yes. So I want to know your experience of Tamil Nadu government regarding procurement of the factors, availability of the factors all around the year, and what are the challenges you face with prophylaxis of hemophilia patients?
Yes, sir. Actually, we started prophylaxis only 3 years back, sir. Actually, we started on 16/8/23. Since then, we are getting prophylaxis drugs regularly. But since 2008, we are getting on-demand drugs. But during the on-demand drugs they are getting, sometimes the intern get late for 1 month, like that. During that time, before 3 months, before starting the prophylaxis, we used to give cryo and FOB. But after starting this prophylaxis, they are giving regularly drug. But only one time in these 3 years, only one time there is a delay of 1 or 2 weeks. But actually at that time we take drugs from the on-demand intern, because these are two separate intern actually. We borrow from on-demand when there is no drugs in the prophylaxis, and we can vice versa, we can take it. So because of this reason, we are continuously having the drugs, and they are sanctioning every year adequate amount for, because in our center out of 180 patients we are having, we are treating with prophylaxis only for 28. After this 23 hemophilia 8 and 4 hemophilia B. So no problem with this continue. Sometimes the intern in the on-demand may go off, but not with the prophylaxis. They continuously we are getting it, because still we are using only.
We are using standard half-life.
Only standard half-life, not even extended half-life. No,
no non-factor therapy.
No non-factor therapy. Just still we are going with only with the standard half-life drugs.
Okay, so you are happy with the standard half-life factor. How often you give in a week?
Actually, we asked the we have selected very carefully that patients from 3 to 12 years, less than 1%, and more than 1% with frequent bleed or with the episodes of life dangerous bleed. If there only these 4 categories we selected. So as they are school going, we ask them to come only twice a week. On Wednesday and Saturday, there is separate hemophilia and hemoglobinopathy center is there. So there is a separate nurse for that. They take care of that, no problem. But still, some people, some students likes to quit some doses. They decide to quit some doses, and they come for the next one like that. Because they are coming all the way from 50 kilometers, the travel itself a burden for them, and the travel expense is there. That is the problem. After coming, getting, because they are coming frequently, getting the 2 problem is there, getting IV line one problem, and time consumption is another problem. So that they decide to quit 1 or 2 doses, but after that they will come.
So sir, this non-factor therapy you have not demanded, or the government of Tamil Nadu is not supplying non-factor therapy for prophylaxis?
Not yet started, sir. The proposal is there, not yet started.
In the entire state, the non-factor therapy is not given?
Not yet given, sir. Actually, there is awareness for these patients actually. Every week they are asking, sir, when we are going to give us the subcutaneous injection, when you are going to give us subcutaneous. The patients going and asking for that. We are the next month, next year we are just postponing the time, but not yet it is confirmed, sir, in the government.
So thank you, Dr. Ravindran, for honestly sharing the experience of Tamil Nadu. You see a lot of disparity between the protocol and between the prophylaxis regimens used for the patients. In Kashmir, the non-factor therapy is available, and Dr. Bilal is free to use anyone, standard EHL or non-factor, whereas in Tamil Nadu, such a advanced state for healthcare, still the non-factor therapy is not made available. So a lot of disparity in policies, because the health is basically a subject of the state. So that is why every state has its own problems. Now I would ask one question to Dr. Yadvendra Reddy sir about, because he is a physician, so he must be having an experience on treating and on giving prophylaxis to the adult patients. So sir, What is your experience of prophylaxis and treatment?
First of all, sir, our state has selected 3 centers for pilot study of non-factor therapy. MC Jubam they are giving. One is Visakhapatnam, another is Guntur, and another is Kadapa Government General Hospital. I am working at Kadapa Government General Hospital. Now we are giving 25 patients for the emicizumab. It is around 26 weeks we are giving it. After going through these 3 centers, they want to extend to all the teaching hospitals. As per our experience, we are treating 26 patients in 26 weeks. We have selected these patients with who are severe hemophilia, less than 1%, and also we are having ABR more than 30 per year. After giving treatment, out of the 26 patients, only 1 patient has a bleeding. Is also after a road traffic accident. He has a minor bleeding. These results are encouraging. So we request our government to extend all these emicizumab to all the teaching hospital centers and extend this prophylaxis. And all of you saying as it has a replacement therapy, there is no prophylaxis. There is a prophylaxis, but it's not a prophylaxis. With the help of early intervening centers, we are providing prophylaxis above the age of 3 years children. We are providing a prophylaxis kit which is containing a soft wall, compressor, and bandages, and we are giving a counseling and with the help of a physiotherapy. This is also the role of prophylaxis in hemophilia.
Sir, you are having a hemophilia treatment center or hemophilia comprehensive
This is
care
the
center?
teaching hospital. I am working at the government center. We are a general physician and pediatrician, physiotherapist, and district early intervention
So
center
almost
is
a
there.
hemophilia comprehensive care center you are
Yeah,
having.
we have a comprehensive center.
So in the same center you have pediatric patients, as you cater pediatric and adult patients?
Pediatric patient, adult patients, we are treating them.
Under same roof?
Same roof, same medical college. We have a pediatrics department, medicine department, and pathology. The blood bank officer is also there. We are giving, and less severe patients we are giving SHL. Daily we will have 5 patients of SHL. They are learned now. They will come before that bleeding. Whenever they are anticipating bleeding, they are coming for the prophylaxis of the SHL.
So Andhra, according to Dr. Reddy, is among the front runners as far as the prophylaxis and treatment of hemophilia is concerned. So I've been asked thrice by the organizers to sum up. In my state in Rajasthan, at R&T Medical College, Udaipur, where I worked, we started non-factor prophylaxis, emicizumab, in January last year. And around 44 patients are on prophylaxis. It was the pursuance of our Hemophilia Society, Mr. Babulal Purohit. So I request all of you to kindly give a big round of applause for Babulal ji, because it is because of him only, his persuasion, his repeated meetings with us, when I was principal at that time. So with me, with the superintendent, with the HOD, and ultimately, despite having no policy for such prophylaxis, in Rajasthan government there is a policy, Nishulk Nirogi Rajasthan. So in Nishulk Nirogi Rajasthan, the doctors can prescribe the medicine which is not there in the essential drug list to a needy patient. So we took advantage of that scheme, Nishulk Nirogi Rajasthan, and from the funds of superintendent, it was not the fund from state government or from NHM, it was the funding from our own hospital. We saved from the insurance schemes, Ma Yojana and then Ayushman Bharat Yojana. That saving goes to the superintendent. So from that budget only, we started emicizumab prophylaxis, and there are 44 patients. Will almost zero breakthrough bleeding. And at our biggest pediatric hospital in Jaipur, SMS Medical College, they are giving EHL prophylaxis, and they have a very large series of patients on EHL prophylaxis in the low dose, and they have a very encouraging data on low dose EHL prophylaxis. So every center is having different policy. Every state is having different policy. In the same state, different hospitals and medical colleges are having, depending upon the availability of the funding, upon the willpower of the administration, and on the pursuance of HFI. Babulal ji is here. So we had lot of questions, but because there is a time constraint, so I thank all my esteemed panelists for being here and sharing the experiences of their state. And I thank HFI, Mr. Prem Alva and his team for giving me this opportunity to share our experiences on hemophilia prophylaxis. Thank you so much.
Thank you so much, sir, and all our Duranda panelists for having this enlightenment session. और थैंक यू सो मच टू लवली ऑडियंस जो अभी तक हमारे साथ है, और थोड़ा देर आपको रुकना है. अभी हम अप्रिशिएट करना चाहेंगे हमारे सारे पैनलिस्ट को और होस्ट को. सो आई रिक्वेस्ट मिस्टर समर सिंह सर, मिस्टर सुभाषिश बेहरा and Mr. Vinod to felicitate our panelists. So much everyone. This is our day 1 और हम day 2 कल सुबह sharp 9 बजे शुरू करेंगे. So everyone please be on time, and now we are having dinner. Dinner is same place where we had the lunch, or please proceed for the dinner. Thank you.